for volunteering for MAPICON 2022 under the guidance of Dr. Vitul K. Gupta. I am very exciting and enjoying. Hello, I am Akansha from Ajmer, Rajasthan. I am student at AIMS Bathinda. I am here for volunteering for MAPICON 2022 under the guidance of Dr. Vitul K. Gupta. I am very exciting and enjoying this MAPICON 2022. I have enjoyed the hosting the stage for the really eminent and educated doctors from all over the India. And I am really excited for MAPICON 2023. Thank you.
नमस्कार जी, मैं अमित रतन कोटफत्ता एमएलए बठिंडा रूरल आम आदमी पार्टी से। आज हम यहाँ पे आए हैं तो ये प्रोग्राम कॉन्फ्रेंस ऑर्गेनाइज की है फिजिशियन एसोसिएशन की तरफ से। बहुत ही बढ़िया मालवा यूनिट ने काम किया है और इस इलाके में जो डॉक्टर्स को नॉलेज शेयरिंग का प्लेटफॉर्म दिया है, तो बहुत बड़ा और अच्छा मैसेज जाता है इससे। बहुत बहुत धन्यवाद।
डॉक्टर DK सिंह, डायरेक्टर एम्स बठिंडा, जो भारत सरकार डॉक्टर DK सिंह
डॉक्टर अंजलि बंसल, मैं सीनियर पीडियाट्रिशियन यहाँ पे सिविल हॉस्पिटल बठिंडा में। आई हैव बीन वर्किंग फ्रॉम द पास्ट 12 years and I did my MBBS from Patiala and then did my post graduation from CMC Ludhiana. After that I worked for about 3 years at RML Delhi in my SRship and gained all the experience there. Today at MAPICON, I have presented my lecture on pubertal problems in office practice. You know, in today's world, a lot of kids during the adolescent age group are there having so many problems and issues, and parents are really worried about this age group in pediatrics, how to do 5-10 problems of usual that comes in the usual practice, and how to answer them and how to deal with them. My experience with MAPICON has been good, and there is wide variety of lectures and speakers from all over India. Best speakers have come here to deliver lectures, and the arrangements are really good. The organizing team has put on a lot of efforts, and the lectures especially started at a particular time and they are ending at a particular time, and there is no delay, and the organizing committee has done a wonderful job. Thanks to Dr. Vital Gupta.
Good day to you, friends. This is from MAPICON Bathinda 2022. I am Dr. Ashish Saxena from Ludhiana, practicing diabetologist and non-invasive cardiologist. And it is nice that I could see a very young budding doctors as well as my colleagues and my seniors who have joined together to make MAPICON a success. The topic which I chose today was to discuss about the noise stress concept. Now you might be wondering, what is the noise stress concept? The noise stress concept is the effect which above the permissible limit of noise can create onto the cardiovascular system via increment of blood pressure, lipids, catecholamines, anxiety, sleeplessness, depression, creating problem for the coming population. Now this is something which has been ignored, or maybe people know but they do not know what to do. Above a permissible limit, noise can always create a problem. The recommended limit is 60 for the house. For a concert is around 100, 110. And with every 10 decibel rise, you are actually exposing yourself and your population to the risk of hypertension, to the risk of lipid abnormality, endothelial dysfunction, causing a derangement of blood sugar levels and causing coronary artery disease like arrhythmias. People can have stroke, people can have a heart attack. So this was the concept which I was talking about today, to create an awareness both at the population level, a noise at the administrative level, and knowledge at the younger level, so that we can prevent this. So take care, look to the guidelines, let us have in a less noisy place. We enjoy the environment of the hills because it is silent there. The same environment comes to our home. So let us enjoy in a comfortable way and live a long life. Thank you. Have a great day.
मैं Dr. Janakara Singla, MD Medicine from Mansa. I have been deputed from Punjab Medical Council as an observer for this conference. I'll like to say कि ਜਿਹੜੀ ਇਸ ਤਰ੍ਹਾਂ ਦੀਆਂ ਕਾਨਫਰੰਸ ਸਾਡੇ ਬਠਿੰਡਾ ਵਰਗੇ ਇਲਾਕੇ ਸੁਣਦੀਆਂ ਨੇਗੀਆਂ, ਸਾਡੇ ਮੈਡੀਕਲ ਪ੍ਰੋਫੈਸ਼ਨ ਵਾਸਤੇ ਬਹੁਤ ਜ਼ਿਆਦਾ ਜਿਹੜੇ ਤਰੱਕੀ ਵਾਸਤੇ ਸਹਾਈ ਸਿੱਧ ਹੁੰਦੀਆਂ ਨੇਗੀਆਂ। ਇਹਨਾਂ ਦੇ ਵਿੱਚ ਜਿਹੜੇ 60 ਤੋਂ ਲੈ ਕੇ 70 ਲੈਕਚਰਸ ਹੁੰਦੇ ਆ, ਤਰ੍ਹਾਂ ਤਰ੍ਹਾਂ ਦੇ ਜਿਹੜੇ ਹੈਗੇ ਆ ਵੱਖਰੀਆਂ ਵੱਖਰੀਆਂ ਥਾਵਾਂ ਤੋਂ ਸਪੈਸ਼ਲਿਸਟ ਡਾਕਟਰ ਜਿਹੜੇ ਹੈਗੇ ਆ ਏਮਸ ਵਗੈਰਾ ਤੋਂ ਵੀ ਤੇ ਹੋਰ ਚੰਗੀਆਂ ਰਿਪਿਊਟਡ ਇੰਸਟੀਟਿਊਸ਼ਨ ਤੋਂ ਲੈਕਚਰ ਦੇਣ ਲਈ ਆਉਂਦੇ ਆ। ਤਾਂ ਸਾਡੇ ਮਾਲਵੇ ਦੇ ਜਿਹੜੇ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਹੈ ਉਹ ਸਾਰੇ ਉਹਨਾਂ ਦੀਆਂ ਗੱਲਾਂ ਬਾਤਾਂ ਸੁਣ ਕੇ ਬੈਨੀਫਿਟਡ ਹੁੰਦੇ ਆ। ਵੈਸੇ ਸਾਡੇ ਪ੍ਰੋਫੈਸ਼ਨ ਦੀ ਜਿਹੜੀ ਹੈ ਇੱਕ ਜ਼ਰੂਰਤ ਹੈ ਕਿ ਅਸੀਂ ਆਪਣੇ ਆਪ ਨੂੰ ਸਾਡੇ ਫੀਲਡ ਦੇ ਵਿੱਚ ਅਪਡੇਟ ਰੱਖੀਏ। ਸੋ ਇਸ ਕਰਕੇ ਮੈਂ ਕਾਨਫਰੰਸ ਦੇ ਜਿਹੜੇ ਆਰਗੇਨਾਈਜ਼ਰਸ ਆ ਉਹਨਾਂ ਨੂੰ ਬਹੁਤ ਵਧਾਈ ਦਿੰਦਾ ਤੇ ਪੰਜਾਬ ਮੈਡੀਕਲ ਕਾਉਂਸਲ ਵੱਲੋਂ ਹਰ ਤਰ੍ਹਾਂ ਦੇ ਸਹਿਯੋਗ ਦੀ ਜਿਹੜੀ ਹੈ ਉਹ ਵਿਸ਼ਵਾਸ ਦਵਾ।
I am Dr. K.K. Noharia, Chairman Organizing Committee, MAPICON, and Senior Consulting Physician, Internal Medicine. We are holding our 9th annual conference of MAPICON a academic feast for the year 2022. It all started in the year 2014. That was our first meeting. This is 9th annual meeting of MAPICON. Since then, regular meetings have been held every year. In fact, the basic reason for starting this conference in this region was that our doctors had to travel a long way to attend these conferences, since we never had too many conferences in our region. So that's why you see, to make it easy for our young budding doctors to attend the meetings and get the credit hours. So we had to start this MAPICON or Malwa chapter of the API of India. You can see the growth of our MAPICON, that we started with 1 day in the year 2014. It has grown to 4 days conference now, with all your help to help us to grow it so fast, so quickly. You can very well imagine this year we had almost 70 lectures and 75 oral and poster presentations. That speaks about the volume of our MAPICON. Because of so much of volume of MAPICON, the PMC has granted 16 hours to our MAPICON. And the credit hours are necessary for our young budding doctors, you see, for the renewal of their registration. We have requested, as you probably know, even yesterday, requested our Honorable Health Minister as well as the members of the Punjab Medical Council to make this conference hybrid conference, so that more and more people can participate and take the advantage of MAPICON offline as well as online. I hope that in future, probably with our efforts and with the efforts of all our colleagues, we may be able to make this conference a hybrid conference. Because by giving a hybrid sort of nature to this conference, you see, we will be able to raise the image and then the academic feast of our this conference to a very higher level. With all these words, you see, again I wish a very success to MAPICON and long live MAPICON.
Myself, Dr. Karamjeet Kaur Taliwal from GGS Medical College, Faridkot. I came here MAPICON Bathinda for poster presentation. It was a great initiative by Dr. Vittal sir for our young doctors to present such posters and interacting with other faculty members and new young doctors and senior doctors. We thank Dr. Vittal sir for having us, and we expect sir to initiate other. In future, sir will be having such conferences again, and we will be attending. Thank you.
Myself, Dr. M.R. Gupta, MD Medicine, Consultant Physician from Bathinda. I am the Scientific Advisor and Chairman of the Organizing Committee of MAPICON 2022. This MAPICON is the 9th annual conference of the Association of Physicians of India, Malwa branch. We are organizing this conference every year in Bathinda for the last 9 years. With every day, this conference is gaining more and more popularity, and we are organizing it every year. There are about more than 70 lectures by the different faculty members from all over India, from the reputed medical colleges and the other medical institutions. The topics are range from wide variety of the topics, medical arena. Latest knowledge medical field is shared with everybody, all the doctors who attend the conference, so that the latest treatment modalities are shared with the participating delegates, and which further benefits patients when they go in their hospitals and treat the patients according to the latest guidelines. This is all about the MAPICON.
Myself, Dr. Mehul Cholera, MD General Medicine from MMU Hospital, Mullana, Ambala. I came here for a poster presentation in MAPICON 2022, Bathinda. It was a good experience presenting poster here. We had very much to learn in this conference. It has been good initiative by Dr. Vitul Gupta sir to organize such conferences and giving opportunities to all the young doctors to present their posters presentation, and it was great learning and great interacting with all such faculties from different regions, gathering and sharing their experiences, and hope such events will be organized later on, and so that we can come regularly and experience such experiences of all the delegates from across different regions. Thank you.
Myself, Dr. Mohit Madhukar, pathologist at Civil Hospital Bathinda. Today I attended the MAPICON 2022 at Hotel Sapel, and I am thankful to Dr. Vitul for giving the opportunity for the guest lecture at MAPICON, and it is a nice conference and very informative. All the topics are discussed by guest faculties very nicely, and it leads to the revision of our topics. So I presented the topic sample collection and its techniques. So briefly I will say that sample collection is very important. If there is error in the sample collection, it will result in the false values. So these false values will hamper us to arrive at the clinical diagnosis. So there are new techniques like vacuum system. So we should use the vacuum system to eliminate the errors during the sample collection. Thank you.
Dr. Nisha, and I am currently a PG resident in the Department of Medicine at Dr. RML Hospital in New Delhi. So I had came to MAPICON for mainly for the poster presentations and the oral paper presentation. It's basically required for our curriculum, that's why. But my experience here was quite good. The reason being the lectures that they had organized, even the recorded lectures, most importantly from the cardiology point of view, I really like those lectures very much. So it has quite given me an opportunity to clarify my doubts, and also to mainly to think that what should I pursue in future about the DM or the super specialty of the examination. Secondly, the organization and the management of this whole MAPICON was really good from my side. Just one or two things that I did find towards not very good about that was the low attendance of the conference. But I think that can be taken care of in the future prospects, as it's already been being advertised in all the peripheral regions also. So I really think that MAPICON is a way to go forward. Thank you.
My name is Dr. Raj Rawal. I am presenting a poster in MAPICON. This is a great experience. Very thankful to Dr. Vitul sir for such a great event. And we also plan to further these great events, many more in the next year by the Vitul sir.
I'm Dr. S.B. Gupta. I'm physician cardiologist at Care Clinic, Charkop, Mumbai. I was the past president of Association of Physicians of India and was working at consultant cardiologist at Asian Heart Institute at Mumbai. My topic of presentation is ECG, yesterday, today and tomorrow. As we know, ECG was invented about more than 100 years in 1893 by Einthoven, and since then the ECG has been the prime investigation for diagnosing acute coronary syndrome and various arrhythmias. And over 100 years there are a lot of investigations have come and gone, but ECG still remains the drug of investigation of choice for diagnosing acute coronary syndrome and diagnosis of various arrhythmias. Over a period of times, there have been a lot of innovations as far as recording of ECG and the monitoring of ECG. Like initially we had Holter monitor, then now we have got loop recorders, and now we have got the Apple watches, the smartphones, where the ECG can be recorded and transmitted to the treating physician. That is the development of ECG monitoring in present days. And future of ECG remains in the artificial intelligence, which I will be talking tomorrow, because the artificial intelligence can tell from the ECG itself what is the age of the patient, what is the sex of the patient, what is his LV function, what is his potassium level, or whether the patient had atrial fibrillation in past or he is likely to develop atrial fibrillation in future. So that is the outlook of the ECG which will happen in future. So ECG has got lot of promises even in future and has got lot of importance as of today. Thank you.
I am Dr. Satish Arora. I am done my MS in general surgery. I am doing the private practice at Philor by the Rodon Nursing Home. And I am and Dr. Vitul Gupta is a class fellow. Congratulations, Dr. Vitul Gupta for organizing the conference in this area. This is the 9th conference in this area. This is very informative and valuable for this area's doctors. Now the doctors from all over the north participating in this conference. I wish Dr. Vitul Gupta very success and good luck. I am Dr. Satish Arora. I am done my MS in general surgery. I am doing the private practice at Philor by the Rodon Nursing Home. And I am and Dr. Vitul Gupta is a class fellow. Congratulations, Dr. Vitul Gupta for organizing the conference in this area. This is the 9th conference in this area. This is very informative and valuable for this area's doctors. Now the doctors from all over the north participating in this conference. I wish Dr. Vitul Gupta very success and good luck.
Dr. Shelza. myself, Dr. Sham. I am currently working as PG third year student in the Dr. RML Hospital, New Delhi. I basically MAPICON 2022 for the poster presentation, for the oral presentation as well. My knowledge and basically knowledge regarding medicine field has improved a lot after attending all the lectures and the recent updates in the field of cardiology, and I came to know regarding various new diagnostic method in the field of cardiology and the basically field in the intervention cardiology, and it has improved my knowledge a lot. So basically I want to come here next year also for just updating my knowledge like this year. Thank you.
I'm Dr. Srishti Arora, and I'm working as a consultant radiologist at Star Imaging Diagnostics, Ludhiana. I've done my MD radiology from DMCH, and I have done my SRship in intervention radiology from DMC Ludhiana. Today I'm here to talk about a very important topic that patients present with in emergency department, that is small bowel obstruction. How radiology plays a very important role in the diagnosis of small bowel obstruction. I'll be discussing about the various imaging modalities that can diagnose small bowel obstruction and which should we go for first, which can help clinicians make a better diagnosis and to assist in therapeutic decisions, that is whether to go for conservative management or to go for immediate surgery. In this, radiology plays a very important role, as we all know. First, the preliminary investigation is X-ray. As we know that the patient comes to the emergency, the first investigation that we order is an abdominal X-ray if the patient presents with abdominal pain, nausea, vomiting, abdominal distension. X-ray is useful to help us to tell whether there is obstruction or not. Dilated small bowel loops can be picked up, but the diagnostic accuracy is very less. The major modality is CT, multi-detector CT. Ultrasound also has a very limited role. If the fluid-filled loops are there, then ultrasound plays an important role, but if the bowel loops are filled with gas, then ultrasound has no role in detecting small bowel obstruction. The major modality is multi-detector CT, CECT as we say, contrast enhanced CT. In this, oral contrast is not given because the patient is already in distress, the bowel loops are dilated, distended with fluid, and we are forcing him to drink more liquids, more oral contrast. So what is the purpose behind it? And the fluid retained in the bowel loops is sufficient for helping us to make the diagnosis. IV contrast is a must in CECT to help in diagnosing the small bowel obstruction, and it is very useful in detecting the extramural abnormalities in the abdomen and to determine the cause of obstruction, the transition point, which is the zone of transition between the dilated and non-dilated bowel loops. I will be discussing all this in my lecture. And CT also plays a very important role in detecting the complications of small bowel obstruction like bowel ischemia, perforation. Pneumoperitoneum can be detected on X-ray also, but bowel ischemia is detectable only on CT. Thank you.
मैं डॉक्टर विजय कुमार बोदल मैंबर पंजाब मैडिकल काउंसिल मैं इस मैपकॉन 9th ਤੇ ਐਜ ਏ ਅਬਜ਼ਰਵਰ ਆਇਆ ਦੇਖਿਆ ਕਿ ਜੋ ਜਿਹੜਾ ਜ਼ਿਲ੍ਹਾ ਬਠਿੰਡਾ ਬਹੁਤ ਹੀ ਪਛੜਿਆ ਹੋਇਆ ਸੀ ਪਰ ਅੱਜ ਦੇਖ ਕੇ ਇਸ ਤਰ੍ਹਾਂ ਲੱਗਦਾ ਕਿ ਜੈਸੇ ਇੰਡੀਆ ਦੇ ਸਭ ਤੋਂ ਵਧੀਆ ਜ਼ਿਲ੍ਹਿਆਂ ਦੇ ਵਿੱਚ ਇਸ ਦਾ ਨੰਬਰ ਆ ਰਿਹਾ ਕਿਉਂਕਿ ਇੱਥੇ ਏਮਸ ਦਾ ਇੰਸਟੀਚਿਊਟ ਖੁੱਲ੍ਹ ਗਿਆ ਇੱਥੇ ਕੈਂਸਰ ਇੰਸਟੀਚਿਊਟ ਖੁੱਲ੍ਹ ਗਿਆ ਇੰਨੀਆਂ ਮੈਡੀਕਲ ਫੈਸਿਲਿਟੀ ਹੋ ਗਈਆਂ ਜੋ ਡਾਕਟਰ ਵਿਟਲ ਵੱਲੋਂ ਮੈਪੀਕੌਨ ਕਰਵਾਈ ਜਾ ਰਹੀ ਆ ਇਸ ਦੇ ਨਾਲ ਇਕੱਲਾ ਪੰਜਾਬ ਦੇ ਵਿੱਚ ਹੀ ਨਹੀਂ ਪੰਜਾਬ ਤੋਂ ਬਾਹਰ ਵੀ ਕਿੱਥੇ ਕਿਹੜੇ ਜਿੰਨੇ ਵੀ ਇੰਡੀਆ ਦੇ ਸਭ ਤੋਂ ਵਧੀਆ ਇੰਸਟੀਚਿਊਟ ਨੇ ਮੈਡੀਕਲ ਹੈਲਥ ਦੇ ਉਹਨਾਂ ਤੋਂ ਡਾਕਟਰ ਇੱਥੇ ਲੈਕਚਰ ਕੁਛ ਆਨਲਾਈਨ ਦੇਣਗੇ ਕੁਛ ਜੋ ਡਾਕਟਰ ਨੇ ਇੱਥੇ ਫਿਜ਼ੀਕਲੀ ਲੈਕਚਰ ਦੇਣਗੇ ਇਹ ਇਕੱਲੇ ਪੰਜਾਬ ਦੇ ਲਈ ਨਹੀਂ, ਇਹ ਪੂਰੇ ਆਲ ਇੰਡੀਆ ਲੈਵਲ ਤੇ ਹੀ ਇਹਦਾ ਮੈਸੇਜ ਆ ਰਿਹਾ, ਕਿਉਂਕਿ ਇੱਥੇ ਜਿੰਨੇ ਵੀ ਸਭ ਤੋਂ ਵਧੀਆ ਡਾਕਟਰ ਨੇ ਆਪਸੀ ਤਾਲਮੇਲ ਕਰਕੇ ਜੋ ਨਵੀਂ ਮੈਡੀਸਨ ਆਈਆਂ ਨੇ, ਨਵੀਂ ਟੈਕਨੀਕ ਆਈਆਂ ਨੇ, ਉਹ ਇੱਕ ਦੂਜੇ ਨਾਲ ਡਿਸਕਸ ਕਰਕੇ ਉਹ ਪੰਜਾਬ ਦੇ ਲੋਕਾਂ ਦੇ ਲਈ ਭਲੇ ਦੀ ਗੱਲ ਕਰਨਗੇ। ਦੂਸਰਾ, ਜੋ ਵੀ ਇਹ ਜ਼ਿਲ੍ਹਾ ਪਛੜਿਆ ਹੋਇਆ, ਮੈਂ ਸਮਾਜ ਦੇ ਬਾਕੀ ਜਿਹੜੇ ਸਾਡੇ ਭੈਣ ਭਰਾ ਨੇ ਕਿ ਜੋ ਵੀ ਇੱਥੇ ਲੈਕਚਰ ਸੁਣਨਗੇ ਉਹਨਾਂ ਨੂੰ ਮੈਂ ਇਹ ਅਪੀਲ ਕਰਾਂਗਾ ਕਿ ਸਭ ਤੋਂ ਪਹਿਲਾਂ ਹੈਲਥ ਆ, ਦੂਸਰੇ ਨੰਬਰ ਤੇ ਪੈਸਾ। ਪੈਸੇ ਦੇ ਨਾਲ ਤੁਸੀਂ ਹੈਲਥ ਨਹੀਂ ਖਰੀਦ ਸਕਦੇ। ਹੈਲਥ ਦਾ ਜਿਹੜਾ ਵੀ ਸਿਸਟਮ ਆ, ਕਿਉਂਕਿ ਅਸੀਂ ਇਹੋ ਜਿਹੇ ਵੀ ਮਰੀਜ਼ ਦੇਖੇ ਨੇ ਜਿਹੜੇ ਅਰਬਾਂਪਤੀ ਨੇ, ਜਿਹੜੇ ਕਰੋੜਾਂਪਤੀ ਨੇ, ਪਰ ਉਹ ਜਦੋਂ ਵੀ ਬਿਮਾਰ ਹੁੰਦੇ ਨੇ ਬਸ ਇੱਕੋ ਹੀ ਕਹਿੰਦੇ ਵੀ ਡਾਕਟਰ ਸਾਹਿਬ ਮੇਰੀ ਸਿਹਤ ਬਚਾ ਲਓ, ਮੈਨੂੰ ਬਚਾ ਲਓ। ਪਰ ਜੇ ਹੈਲਥ ਚੰਗੀ ਆ ਤਾਂ ਸਾਡਾ ਸਮਾਜ ਚੰਗਾ ਹੋਵੇਗਾ, ਜੇ ਸਾਡਾ ਸਮਾਜ ਚੰਗਾ ਹੋਏਗਾ ਸਾਰਾ ਸਾਡੇ ਜੋ ਬੱਚੇ ਆ ਉਹ ਵੀ ਚੰਗੇ ਹੋਣਗੇ। ਇਸ ਲਈ ਮੈਂ ਸਾਰਿਆਂ ਨੂੰ ਅਪੀਲ ਕਰਾਂਗਾ ਆਪਣੀ ਹੈਲਥ 'ਤੇ ਖਿਆਲ ਰੱਖੋ ਅਤੇ ਆਪਣੀ ਹੈਲਥ ਨੂੰ ਵਧੀਆ ਢੰਗ ਦੇ ਨਾਲ ਸਵੇਰੇ ਸ਼ਾਮ ਸੈਰ ਕਰੋ, ਚੰਗਾ ਖਾਓ, ਚੰਗਾ ਬੋਲੋ, ਮਾੜੀ ਸੋਚਣੀ ਨਾ ਕਰੋ। ਇੰਨੀਆਂ ਸ਼ਬਦਾਂ ਨਾਲ ਮੈਂ ਸਾਰਿਆਂ ਨੂੰ ਬਹੁਤ ਬਹੁਤ ਧੰਨਵਾਦ।
Myself Hargun Kaur Khera. I'm from Ludhiana, Punjab. I am a second year MBBS student here at AIMS Bathinda. I've volunteered for MAPICON 2022. It has been a great experience so far. It's been a great learning experience and we've also enjoyed in the same. And we're learning new skills and there are physicians from all over India who've gathered here to discuss the latest trends in medical education and medical sciences, and we're learning a lot from that as well. It's been a wonderful experience so far under the guidance of Dr. Vitul Gupta sir. He has been a great mentor and guide, and we've had great fun in this whole thing.
Hello, I am Ishan from Dafrozpur, Punjab. I am currently studying in the AIMS Bathinda pursuing MBBS in second year. And I have volunteered from the MAPICON 2022 and under the guidance of the Vitul sir and also other organizing members. There is such a nice experience. We are learning and also enjoying the conference. There are great teachers which are telling us about the various advances in the medical science. And we are also learning and enjoying the conference. So we have also met with the Health Minister of the Punjab, which was very nice guy, and it was very delightful experience for us. And our MAPICON team has given us opportunity to join this conference, and we are also waiting for the next MAPICON conference 2023. Thanks Vitul sir and other organizing members for this. Thanks.
Second year MBBS student from the AIMS Bathinda. I volunteered here for the MAPICON 2022, which is a 9th conference of the annual Association of the Physicians of India from the Malwa region. Apart from doing my volunteer activities here, I had a lot of the academic experiences, and I come to know about the new research projects going on and the newer technologies coming these years. I am looking forward for the next year MAPICON 2023, which is going to held in Bathinda itself in the September month.
डॉक्टर DK सिंह, डायरेक्टर एम्स भटिंडा, जो भारत सरकार का एक फ्लैगशिप प्रोजेक्ट है, उसके संचालन के लिए मैं यहाँ हूँ। मैं डॉक्टर वितुल गुप्ता को बधाई दे रहा हूँ उन्होंने बहुत अच्छी चिकित्सा शिक्षा की एक सतत प्रक्रिया जो होती है उसको जारी रखने का प्रयास किया है और एक मालवा प्रांत के लिए एक अच्छी कॉन्फ्रेंस ऑर्गेनाइज की है। एम्स भटिंडा यहाँ बहुत तेजी से प्रगति कर रहा है। भटिंडा का लोकेशन भी ऐसा है कि यहाँ पर हमें उम्मीद है कि बहुत जल्द ही पंजाब का एक ये मेडिकल सेंटर, मेडिकल हब, चाहे वो प्राइवेट सेक्टर में हो चाहे वो गवर्नमेंट सेक्टर में हो, बनने जा रहा है। मैं आप सभी का स्वागत करना चाहूँगा एम्स भटिंडा के परिसर में।
मैं Dr. Janakras Singla, MD Medicine from Mansa. I have been deputed from Punjab Medical Council as an observer for this conference. I'll like to say कि ਜਿਹੜੀ ਇਸ ਤਰ੍ਹਾਂ ਦੀਆਂ ਕਾਨਫਰੰਸ ਸਾਡੇ ਬਠਿੰਡਾ ਵਰਗੇ ਇਲਾਕੇ 'ਚ ਹੁੰਦੀਆਂ ਨੇਗੀਆਂ, ਸਾਡੇ ਮੈਡੀਕਲ ਪ੍ਰੋਫੈਸ਼ਨ ਵਾਸਤੇ ਬਹੁਤ ਜ਼ਿਆਦਾ ਜਿਹੜੇ ਤਰੱਕੀ ਵਾਸਤੇ ਸਹਾਈ ਸਿੱਧ ਹੁੰਦੀਆਂ ਨੇਗੀਆਂ। ਇਹਨਾਂ ਦੇ ਵਿੱਚ ਜਿਹੜੇ 60 ਤੋਂ ਲੈ ਕੇ 70 ਲੈਕਚਰਸ ਹੁੰਦੇ ਆ, ਤਰ੍ਹਾਂ ਤਰ੍ਹਾਂ ਦੇ ਜਿਹੜੇ ਹੈਗੇ ਆ ਵੱਖਰੀਆਂ ਵੱਖਰੀਆਂ ਥਾਵਾਂ ਤੋਂ ਸਪੈਸ਼ਲਿਸਟ ਡਾਕਟਰ ਜਿਹੜੇ ਹੈਗੇ ਆ ਏਮਸ ਵਗੈਰਾ ਤੋਂ ਵੀ ਤੇ ਹੋਰ ਚੰਗੀਆਂ ਰਿਪਿਊਟਡ ਇੰਸਟੀਟਿਊਸ਼ਨ ਤੋਂ ਲੈਕਚਰ ਦੇਣ ਲਈ ਆਉਂਦੇ ਆ। ਤਾਂ ਸਾਡੇ ਮਾਲਵੇ ਦੇ ਜਿਹੜੇ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਹੈ ਉਹ ਸਾਰੇ ਉਹਨਾਂ ਦੀਆਂ ਗੱਲਾਂ ਬਾਤਾਂ ਸੁਣ ਕੇ ਬੈਨੀਫਿਟਡ ਹੁੰਦੇ ਆ। ਵੈਸੇ ਸਾਡੇ ਪ੍ਰੋਫੈਸ਼ਨ ਦੀ ਜਿਹੜੀ ਹੈ ਇੱਕ ਜ਼ਰੂਰਤ ਹੈ ਕਿ ਅਸੀਂ ਆਪਣੇ ਆਪ ਨੂੰ ਸਾਡੇ ਫੀਲਡ ਦੇ ਵਿੱਚ ਅਪਡੇਟ ਰੱਖੀਏ। ਸੋ ਇਸ ਕਰਕੇ ਮੈਂ ਕਾਨਫਰੰਸ ਦੇ ਜਿਹੜੇ ਆਰਗੇਨਾਈਜ਼ਰ ਆ ਉਹਨਾਂ ਨੂੰ ਬਹੁਤ ਵਧਾਈ ਦਿੰਦਾ ਤੇ ਪੰਜਾਬ ਮੈਡੀਕਲ ਕਾਉਂਸਲ ਵੱਲੋਂ ਹਰ ਤਰ੍ਹਾਂ ਦੇ ਸਹਿਯੋਗ ਦੀ ਜਿਹੜੀ ਹੈ ਉਹ ਵਿਸ਼ਵਾਸ ਦਵਾ।
मैं डॉक्टर विजय कुमार बोधल, मैंबर पंजाब मैडिकल काउंसिल। मैं इस मैपकॉन 9th ते एज ए ऑब्जर्वर आया। देखिया भी जो ਜਿਹੜਾ ਜ਼ਿਲ੍ਹਾ ਬਠਿੰਡਾ ਬਹੁਤ ਹੀ ਪਛੜਿਆ ਹੋਇਆ ਸੀ, ਪਰ ਅੱਜ ਦੇਖ ਕੇ ਇਸ ਤਰ੍ਹਾਂ ਲੱਗਦਾ ਵੀ ਜੈਸੇ ਇੰਡੀਆ ਦੇ ਸਭ ਤੋਂ ਵਧੀਆ ਜ਼ਿਲ੍ਹਿਆਂ ਦੇ ਵਿੱਚ ਇਸ ਦਾ ਨੰਬਰ ਆ ਰਿਹਾ, ਕਿਉਂਕਿ ਇੱਥੇ ਏਮਸ ਦਾ ਇੰਸਟੀਚਿਊਟ ਖੁੱਲ੍ਹ ਗਿਆ, ਇੱਥੇ ਕੈਂਸਰ ਇੰਸਟੀਚਿਊਟ ਖੁੱਲ੍ਹ ਗਿਆ, ਇੰਨੀਆਂ ਮੈਡੀਕਲ ਫੈਸਿਲਿਟੀ ਹੋ ਗਈਆਂ ਜੋ ਡਾਕਟਰ ਵਿਟਲ ਵੱਲੋਂ ਮੈਪੀਕੌਨ ਕਰਵਾਈ ਜਾ ਰਹੀ ਆ। ਇਸ ਦੇ ਨਾਲ ਇਕੱਲਾ ਪੰਜਾਬ ਦੇ ਵਿੱਚ ਹੀ ਨਹੀਂ, ਪੰਜਾਬ ਤੋਂ ਬਾਹਰ ਵੀ ਕਿੱਥੇ ਕਿਹੜੇ ਜਿੰਨੇ ਵੀ ਇੰਡੀਆ ਦੇ ਸਭ ਤੋਂ ਵਧੀਆ ਇੰਸਟੀਚਿਊਟ ਨੇ ਮੈਡੀਕਲ ਹੈਲਥ ਦੇ, ਉਹਨਾਂ ਤੋਂ ਡਾਕਟਰ ਇੱਥੇ ਲੈਕਚਰ ਕੁਛ ਆਨਲਾਈਨ ਦੇਣਗੇ, ਕੁਛ ਜੋ ਡਾਕਟਰ ਨੇ ਇੱਥੇ ਫਿਜ਼ੀਕਲੀ ਲੈਕਚਰ ਦੇਣਗੇ। ਇਹ ਇਕੱਲੇ ਪੰਜਾਬ ਦੇ ਲਈ ਨਹੀਂ, ਇਹ ਪੂਰੇ ਆਲ ਇੰਡੀਆ ਲੈਵਲ 'ਤੇ ਹੀ ਇਹਦਾ ਮੈਸੇਜ ਆ ਰਿਹਾ, ਕਿਉਂਕਿ ਇੱਥੇ ਜਿੰਨੇ ਵੀ ਸਭ ਤੋਂ ਵਧੀਆ ਡਾਕਟਰ ਨੇ ਆਪਸੀ ਤਾਲਮੇਲ ਕਰਕੇ ਜੋ ਨਵੀਂ ਮੈਡੀਸਨ ਆਈਆਂ ਨੇ, ਨਵੀਂ ਟੈਕਨੀਕ ਆਈਆਂ ਨੇ, ਉਹ ਇੱਕ ਦੂਜੇ ਨਾਲ ਡਿਸਕਸ ਕਰਕੇ ਉਹ ਪੰਜਾਬ ਦੇ ਲੋਕਾਂ ਦੇ ਲਈ ਭਲੇ ਦੀ ਗੱਲ ਕਰਨਗੇ। ਦੂਸਰਾ ਜੋ ਵੀ ਇਹ ਜ਼ਿਲ੍ਹਾ ਪਛੜਿਆ ਹੋਇਆ, ਮੈਂ ਸਮਾਜ ਦੇ ਬਾਕੀ ਜਿਹੜੇ ਸਾਡੇ ਭੈਣ ਭਰਾ ਨੇ ਕਿ ਜੋ ਵੀ ਇੱਥੇ ਲੈਕਚਰ ਸੁਣਨਗੇ ਉਹਨਾਂ ਨੂੰ ਮੈਂ ਇਹ ਅਪੀਲ ਕਰਾਂਗਾ ਕਿ ਸਭ ਤੋਂ ਪਹਿਲਾਂ ਹੈਲਥ ਆ, ਦੂਸਰੇ ਨੰਬਰ 'ਤੇ ਪੈਸਾ। ਪੈਸੇ ਦੇ ਨਾਲ ਤੁਸੀਂ ਹੈਲਥ ਨਹੀਂ ਖਰੀਦ ਸਕਦੇ। ਹੈਲਥ ਦਾ ਜਿਹੜਾ ਵੀ ਸਿਸਟਮ ਆ, ਕਿਉਂਕਿ ਅਸੀਂ ਇਹੋ ਜਿਹੇ ਵੀ ਮਰੀਜ਼ ਦੇਖੇ ਨੇ ਜਿਹੜੇ ਅਰਬਾਂਪਤੀ ਨੇ, ਜਿਹੜੇ ਕਰੋੜਾਂਪਤੀ ਨੇ, ਪਰ ਉਹ ਜਦੋਂ ਵੀ ਬਿਮਾਰ ਹੁੰਦੇ ਨੇ ਬਸ ਇੱਕੋ ਹੀ ਕਹਿੰਦੇ ਵੀ ਡਾਕਟਰ ਸਾਹਿਬ ਮੇਰੀ ਸਿਹਤ ਬਚਾ ਲਓ, ਮੈਨੂੰ ਬਚਾ ਲਓ। ਪਰ ਜੇ ਹੈਲਥ ਚੰਗੀ ਆ ਤਾਂ ਸਾਡਾ ਸਮਾਜ ਚੰਗਾ ਹੋਵੇਗਾ, ਜੇ ਸਾਡਾ ਸਮਾਜ ਚੰਗਾ ਹੋਏਗਾ ਸਾਰਾ ਸਾਡੇ ਜੋ ਬੱਚੇ ਆ ਉਹ ਵੀ ਚੰਗੇ ਹੋਣਗੇ। ਇਸ ਲਈ ਮੈਂ ਸਾਰਿਆਂ ਨੂੰ ਅਪੀਲ ਕਰਾਂਗਾ ਆਪਣੀ ਹੈਲਥ 'ਤੇ ਖਿਆਲ ਰੱਖੋ ਅਤੇ ਆਪਣੀ ਹੈਲਥ ਨੂੰ ਵਧੀਆ ਢੰਗ ਦੇ ਨਾਲ ਸਵੇਰੇ ਸ਼ਾਮ ਸੈਰ ਕਰੋ, ਚੰਗਾ ਖਾਓ, ਚੰਗਾ ਬੋਲੋ, ਮਾੜੀ ਸੋਚਣੀ ਨਾ ਕਰੋ। ਇੰਨੀਆਂ ਸ਼ਬਦਾਂ ਨਾਲ ਮੈਂ ਸਾਰਿਆਂ ਨੂੰ ਬਹੁਤ ਬਹੁਤ ਧੰਨਵਾਦ।
ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਜੀ, ਮੈਂ ਚੇਤਨ ਸਿੰਘ ਜੋੜਾ ਮਾਜਰਾ, ਹੈਲਥ ਮਿਨਿਸਟਰ ਪੰਜਾਬ। ਸੋ ਅੱਜ ਅਸੀਂ ਇੱਥੇ ਬਠਿੰਡਾ ਵਿਖੇ ਪਹੁੰਚੇ ਹਾਂ, ਜੋ ਮੈਪੀਕੌਨ ਵੱਲੋਂ ਜਿਹੜਾ 9ਵੀਂ ਕਾਨਫਰੰਸ ਹੈ ਉਹ ਕਰਵਾਈ ਗਈ ਹੋਈ ਆ। ਉਹਦੇ ਵਿੱਚ ਬਹੁਤ ਸਾਰੇ ਨਵੇਂ ਸਾਡੇ ਨੌਜਵਾਨ ਜਿਨ੍ਹਾਂ ਨੂੰ ਬਹੁਤ ਲੋੜ ਹੈ ਸਿੱਖਣ ਦੀ, ਉਹ ਇਸ ਕਾਨਫਰੰਸ ਦੇ ਵਿੱਚ ਪਹੁੰਚੇ ਨੇ, ਕਿਉਂਕਿ ਇਹ 9 ਸਾਲ ਕੋਈ ਛੋਟਾ ਪੀਰੀਅਡ ਨਹੀਂ ਹੁੰਦਾ, ਬਹੁਤ ਲੰਬਾ ਪੀਰੀਅਡ ਹੈ। ਜਦੋਂ ਪਹਿਲੀ ਕਾਨਫਰੰਸ ਡਾਕਟਰ ਵਿਤਲ ਗੁਪਤਾ ਜੀ ਨੇ ਕਰਵਾਈ ਤਾਂ ਉਹਨਾਂ ਨੂੰ ਕਿੰਨੇ ਜਿਹੜਾ ਮਸ਼ੱਕਤ ਕਰਨੀ ਪਈ ਹੋਣੀ। ਸੋ ਉਹਨਾਂ ਨੇ ਜਿਹੜੇ ਸਾਡੇ ਨਵੇਂ ਨੌਜਵਾਨ ਜੋ ਹੁਣ ਮੈਡੀਕਲ ਕਰ ਰਹੇ ਨੇ ਉਹਨਾਂ ਜਿਹੜੇ ਡਾਕਟਰੀ ਕਰ ਰਹੇ ਨੇ ਉਹਨਾਂ ਵਾਸਤੇ ਬਹੁਤ ਸੋਹਣੇ ਮੌਕੇ ਨੇ ਜਿਹੜੇ ਜਦੋਂ ਕਿ ਉਹਨਾਂ ਨੂੰ ਆਪਣੇ ਟ੍ਰੇਨਿੰਗ ਦੇ ਵਾਸਤੇ ਜਿਹੜੀ 10 ਘੰਟੇ ਦੀ ਜਿਹੜੀ ਲੋੜ ਹੁੰਦੀ ਹੈ ਐਕਸਪੀਰੀਅੰਸ ਇਹਦੀ ਲਾਉਣ ਦੀ ਕਲਾਸਾਂ ਲਾਉਣ ਦੀ ਆਪਣਾ ਕਾਨਫਰੰਸ ਦੇ ਵਿੱਚ ਉਹ ਕਰਨ ਦੀ ਉਹਦੇ ਵਿੱਚ ਉਹਨਾਂ ਨੂੰ ਉਹਨਾਂ ਦੇ ਘਰ ਦੇ ਵਿੱਚ ਜਦੋਂ ਮਿਲ ਜਾਂਦੇ ਜੇ ਮਾਲਵੇ ਦੇ ਸਾਰੇ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਜਿਹੜੇ ਇਕੱਠੇ ਹੋ ਕੇ ਜਿਹੜੀ ਕਾਨਫਰੰਸ ਕਰਦੇ ਨੇ ਔਰ ਪਹਿਲਾਂ ਜਦੋਂ ਸ਼ੁਰੂਆਤ ਕੀਤੀ ਗਈ ਸੀ ਤਾਂ 175 ਜਿਹੜੇ ਡੈਲੀਗੇਟ ਇੱਥੇ ਪਹੁੰਚੇ ਸੀ ਅੱਜ ਉਹਨਾਂ ਡੈਲੀਗੇਟਸ ਦੀ ਜਿਹੜੀ ਗਿਣਤੀ ਆ ਉਹ ਵੱਧ ਕੇ 500 ਹੋ ਗਈ ਹੈ ਸੋ ਇੱਥੋਂ ਪਤਾ ਲੱਗਦਾ ਕਿ ਇਸ ਜਿਹੜੀ ਮੈਪੀਕੌਨ ਜਿਹੜੀ ਕਾਨਫਰੰਸ ਆ ਉਹਦਾ ਕਿਵੇਂ ਲੋਕਾਂ ਦੇ ਵਿੱਚ ਜਿਹੜਾ ਪ੍ਰਭਾਵ ਛੱਡ ਰਹੀ ਹੈ ਸੋ ਮੈਂ ਸਾਰੇ ਜਿਹੜੇ ਸਾਡੇ ਪੰਜਾਬ ਦੇ ਜਾਂ ਹੋਰ ਦੇਸ਼ ਦੇ ਵਿੱਚ ਜਿਹਨੇ ਡਾਕਟਰ ਆ ਉਹਨਾਂ ਨੂੰ ਬੇਨਤੀ ਕਰਨਾ ਕਿ ਤੁਸੀਂ ਵੀ ਆਓ ਔਰ ਰਲ ਕੇ ਅਸੀਂ ਸਾਡੇ ਦੇਸ਼ ਨੂੰ ਸਾਡੇ ਪੰਜਾਬ ਨੂੰ ਜੋ ਬਹੁਤ ਸਾਰੀਆਂ ਬਿਮਾਰੀਆਂ ਤੋਂ ਪੀੜਤ ਨੇ ਉਹਨਾਂ 'ਤੇ ਅਸੀਂ ਵੀ ਕੁਛ ਨਵਾਂ ਕੁਛ ਲੈ ਕੇ ਆਈਏ ਤਾਂ ਕਿ ਬਹੁਤ ਸਾਰੀਆਂ ਬਿਮਾਰੀਆਂ ਇੱਦਾਂ ਦੀਆਂ ਨੇ ਜਿਨ੍ਹਾਂ 'ਤੇ ਲੰਬਾ ਸਮਾਂ ਮੈਡੀਸਨ ਖਾਣੀ ਪੈਂਦੀ ਆ ਸੋ ਉਹਨਾਂ ਤੋਂ ਕੋਈ ਨਵੀਂ ਆਜ਼ਾਦ ਕਰਕੇ ਅਸੀਂ ਕੋਈ ਇਹੋ ਜਿਹੀ ਮੈਡੀਸਨ ਲਈਏ ਜਿਨ੍ਹਾਂ ਨੂੰ ਲੰਬਾ ਸਮਾਂ ਜਿਹੜਾ ਮੈਡੀਸਨ ਦੀ ਯੂਜ਼ ਨਾ ਕਰਨਾ ਪਵੇ ਉਹਨਾਂ ਨੂੰ ਥੋੜ੍ਹੇ ਸਮੇਂ ਦੇ ਵਿੱਚ ਹੀ ਜਿਹੜਾ ਇਲਾਜ ਹੈ ਅਸੀਂ ਮੁਹੱਈਆ ਕਰਾ ਸਕੀਏ ਸੋ ਅਸੀਂ ਆਪਦੇ ਵੱਲੋਂ ਅਸੀਂ ਪੰਜਾਬ 'ਚ ਜਿਹੜਾ ਸਿਹਤ ਪ੍ਰਤੀ ਹੈ ਸੋ ਪੂਰੀ ਸੰਜੀਦਗੀ ਨਾਲ ਜਿਹੜਾ ਕੰਮ ਕਰ ਰਹੇ ਸੋ ਅਸੀਂ ਵੀ ਚਾਹੁੰਦੇ ਹਾਂ ਕਿ ਹਰ ਇੱਕ ਨਾਗਰਿਕ ਦਾ ਜਿਹੜਾ ਇਲਾਜ ਹੈ ਉਹ ਉਸਦੇ ਨੇੜੇ ਤੇੜੇ ਸੋ ਕੀਤਾ ਜਾਵੇ ਸੋ ਸਾਰਿਆਂ ਦਾ ਬਹੁਤ ਬਹੁਤ ਧੰਨਵਾਦ
I am Dr. Lajja Goyal, Professor and Head, Department of Obstetrics and Gynae, AIMS Bathinda. So I had come to the MAPICON today to deliver a talk on the elimination of cervical cancer with screening and HPV vaccine. So cervical cancer, we know that in India, every day we are losing 200 women with the cervical cancer, and every 7 minutes, one woman is dying. So the importance of this cancer is that this cancer is fully preventable and it is caused by a virus which can be attacked at multiple sites. Like preventing with the vaccine, we should vaccinate all the young girls who are less than 15 years, but vaccine can be given up to the age of 26 years also. Those who are not sexually active, it will be effective to those women. And then we are having more of the population who is infected with the virus, and the virus is persistent and can lead to precancerous lesion and cancer. And it takes around 10 years from the infection of HPV virus to develop into a precancerous lesion, and from precancerous lesion to develop into cancer, it will take another 10 years. So we have approximately 10 years to 20 years period to prevent and pick up this cancer and precancerous lesion to treat these women. So we have so many tests available, but women are not availing those tests. Those tests are available in almost every hospital in the city, which are Pap test and acetic acid test and HPV DNA test. Although HPV DNA test is costly, but Pap test is not that costly, and VIA test will cost nothing, and it is just we have to apply an acetic acid and we can see the precancerous or cancer lesion, and at the same sitting we can treat the patient. And if the disease is at precancerous stage, we don't need to remove the uterus, we can just ablate the lesion with various modalities we have. Those includes leaf procedures, cryocautery and ablative therapy with the thermal ablation. And unfortunately, if any patient who is having cancer that in early stage, we can treat with the Bardheim's hysterectomy, that is extended hysterectomy, that is a surgical procedure, but it is a fully curable if it is in the early stage. In the later stage, we don't have surgical treatment available, and we have to treat with the radiotherapy and palliative treatment only. So we urge all the ladies to undergo pap smear who are more than 30-year-old, and those who are less than 30-year-old, they can be coming to the hospital for acetic acid examination and pap cytology also, and test should be done every 3 years. It does not cost any much, and VIA test will not cost anything So it is a very cheap test. It doesn't cause any pain. It is an OPD procedure, will not require any anesthesia, will not require any admission. So I urge everybody that all the women whom you know are married and sexually active should undergo screening test, so that we can eliminate the cervical cancer if all of us get together. And all the young girls less than 15 years should be vaccinated with the 2 dose, and vaccine should be given at 0 dose and after 6 months 2 doses. So 2 doses are only required, and now Government of India has launched the vaccine, and this vaccine will be available from December 2022, and maybe this vaccine is incorporated in the national immunization schedule. So we must tell everybody and promote this vaccine so that we can eliminate the cervical cancer.
Good morning, everyone. I am Dr. Monica Singla, Associate Professor Neurology from Dayanand Medical College and Hospital, Ludhiana. I was invited here at MAPICON 2022 for a talk on primary headache disorders. This is a very common topic. Headache is the most common neurological disorder which we see in routine. It's a very prevalent disorder. Headache is more common in women than men. So I discussed in my talk about various headache disorders, out of which commonest are migraine, tension type headache, various trigeminal autonomic cephalalgic headaches, and other common headache disorders. If we talk about these disorders, migraine must be the commonest headache disorder, more common in children and women in younger age. There are so many triggers of migraine, which are routinely lack of sleep or oversleep, hunger, missing of the meals, sunlight, and menstrual periods in women, and lot of stress, anxiety, and there's some food triggers are also there. So if we need to control migraine, we should control our triggers. Then there's usually a family history of migraine. Migraine can be of two types, migraine without aura and migraine with aura. Migraine without aura means it's a common migraine which we see routinely. Migraine with aura is a migraine when there is an aura which can be in the form of visual aura. Patient can see some bright lights and bright spots, zigzag lines, scotomas, or black spots. Or it can be in the form of sensory symptoms, motor weakness, or it can be in the form of some kind of noises or sounds in the ear. So migraine with aura is like that. And the other type of headache which I discussed was cluster headache. Cluster headache is usually, it's a very strictly unilateral headache, so it's usually on the one side of the head, and there are autonomic symptoms along with. Patient can have nasal congestion, redness of the eye, lacrimation, and nasal stuffiness. And this headache usually lasts for 30 to 180 minutes. And other type of trigeminal cephalalgic headaches are when there are short lasting pains which can be brief current like pains on one side of the head with autonomic symptoms. Besides these common headaches, we see tension headache. Usually tension headache people, they complain of continuous type of bilateral pain, tenderness in the skin, scalp, and there is a bilateral pain. It's not like migraine, but there is a mild to moderate continuous type of heaviness of the head. The other primary headaches which we see routinely as per the ICSD classification 2018 are primary exercise headache. When people do heavy exercise, they feel pain, and these headaches are usually responsive to painkillers like indomethacin, but these people have pain only during exercise. Now another type of primary headache disorder is primary sexual headache, and there can be primary cough headache. When people have severe cough, heavy cough, they feel headache, but they don't have headache otherwise. So if they have this kind of pain, usually we need to rule out the secondary causes. Sometimes there can be primary nuclear headache, like they have it in a small coin shaped area in the scalp, they feel pain, and this goes after few hours. And there can be like stabbing pain, thunderclap pain. But if somebody has severe headache, it does not mean it comes under category of primary thunderclap headache. We should always rule out some kind of brain hemorrhage, reversible vasoconstriction syndrome, some subarachnoid hemorrhage before labeling it as a primary thunderclap headache. And some people have, like in children, another common headache which is seen is Alice in Wonderland syndrome. Like as they're feeling, they start imagining or they feel that there's some disfiguring of the body shape. They can see one body in two halves, or sometimes they feel their ear is increasing into 6 inches size. So these type of perceptions or visual hallucinations are there during headache. So these are the common headache disorders, but the only crux is that we should always show to a physician or a doctor or neurologist whenever we feel pain, because all headaches are not primary headache disorders. These headaches can be secondary to some kind of tumor, trauma, any structural lesion, any SOL in the brain, any clot or vascular pathology. So these things need to be ruled out. And if we are very sure that these are not the symptoms of secondary headache, then we should treat as a primary headache, and we should take regular treatment so that to avoid any further complication in the body. Thank you so much. Have a nice day.
ਜਗਰੂਪ ਸਿੰਘ ਗਿੱਲ MLA ਬਠਿੰਡਾ ਸ਼ਹਿਰੀ। ਅੱਜ ਇਸ ਜਿਹੜੀ 9ਵੀਂ ਕਾਨਫਰੰਸ ਹੈ ਮੈਪੀਕੌਨ ਦੀ ਮਾਲਵਾ ਚੈਪਟਰ ਵੱਲੋਂ ਕਰਾਈ ਜਾ ਰਹੀ ਹੈ, ਇਸ ਦੇ ਵਿੱਚ ਬਹੁਤ ਸਾਰੇ ਗਿਆਨਵਾਨ ਊਰਜਾਵਾਨ ਨਵੇਂ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਇੱਥੇ ਆਏ ਨੇ। ਔਰ ਇਸ ਦੇ ਲਈ ਸਭ ਤੋਂ ਪਹਿਲਾਂ ਮੈਂ ਵਿਤਲ ਗੁਪਤਾ ਜੀ ਨੂੰ, ਜਿਨ੍ਹਾਂ ਨੇ ਅੱਜ ਤੋਂ 9 ਸਾਲ ਪਹਿਲਾਂ ਇਹ ਸ਼ੁਰੂ ਕੀਤੀ ਸੀ ਔਰ ਲਗਾਤਾਰ 9 ਸਾਲ ਦੇ ਵਿੱਚ ਮਿਹਨਤ ਕਰਕੇ ਅੱਜ 9ਵੇਂ ਸਾਲ ਦੇ ਵਿੱਚ ਇਹਨਾਂ ਨੇ ਬੜੀ ਵੱਡੀ ਕਾਨਫਰੰਸ ਕੀਤੀ ਹੈ, ਜਿਹਦੇ 'ਚ ਉਹਨਾਂ ਨੇ ਦੱਸਿਆ 500 ਦੇ ਕਰੀਬ ਅੱਜ ਪਾਰਟੀਸਪੈਂਟਸ ਹੈ, ਭਾਗ ਲੈਣ ਵਾਲੇ ਲੋਕ ਨੇ। ਇੱਥੋਂ ਜਿਹੜੇ ਡਾਕਟਰ ਨੇ ਬਹੁਤ ਕੁਝ ਸਿੱਖ ਕੇ ਜਾਣਗੇ, ਨਵਾਂ ਸਿੱਖ ਕੇ ਜਾਣਗੇ। ਗਿਆਨ ਕਈ ਵਾਰ ਕਿਸੇ ਦੇ ਕੋਲ ਹੁੰਦਾ ਉਸ ਨੂੰ
Punjab Medical Council, you see, he showed his inability to come at the time as it was mentioned, so he's a little late. So that's why there is a little deliberate delay sort of starting the program. So we are starting this now with your representation today. As you all know, today we are almost the last the day of our this conference, MAPICON. So with your representation, we're starting the last day of today. Thank you very much.
Good morning, everyone. For oral paper presentation, I would like to invite Dr. Reshu Garg, who will be presenting on the topic to look for association between clinical and biochemical factors among patients of non-alcoholic fatty liver diseases. 5 minutes will be provided for the presentation and 5 minutes for the questionnaire.
Good morning, everyone. Today I am presenting a study which was done at GGS MCH Freethcourt entitled Association of Clinical and Biochemical Factors Among Patients of Non-Alcoholic Fatty Liver Disease. Non-alcoholic fatty liver disease is a clinico-pathological condition characterized by abnormal lipid deposition in the hepatocytes known as steatosis in the absence of excess alcohol intake. It comprises a spectrum of diseases ranging from simple hepatic steatosis to steatosis in association with necroinflammation and fibrosis, also known as non-alcoholic steatohepatosis, to cirrhosis. It is rapidly becoming the most common cause of liver disease in children, adolescents, and adults. It is strongly associated with obesity, insulin resistance, hypertriglyceridemia, and metabolic syndrome in adults. It can be viewed as an hepatic manifestation of insulin resistance. A significant association is seen between the histological severity of disease and components of metabolic syndrome. Waist circumference is a surrogate marker for visceral fat, and visceral fat appears tightly correlated with hepatic triglyceride content, elevated ALT levels, liver inflammation, and fibrosis. Waist circumference may independently predict liver fibrosis on biopsy. Diabetes is a well-known risk factor for development of fatty liver. Majority of patients with type 2 diabetes mellitus have evidence of fatty liver on imaging. It is closely linked to many established cardiovascular risk factors abdominal obesity, hypertension, type 2 diabetes, and dyslipidemia. And cardiovascular disease is the main cause of mortality in adults with non-alcoholic fatty liver disease. This study was conducted on the patient diagnosed as non-alcoholic fatty liver disease on ultrasonography, presenting in the outpatient and inpatient department of internal medicine at Guru Gobind Singh Medical College and Hospital. A total of 330 patients were included in this study. Inclusion criteria. Patients who satisfy the European Association for Study of the Liver criteria, which is alcohol consumption threshold for men 30 gram per day and 20 gram per day for women, in which there was evidence of fatty liver on ultrasonography and or liver elastography, in which there were no other causes of steatosis. Age more than 18 years were taken in this study. Chronic alcoholics, patients of hepatitis B and hepatitis C, patients who are known cases of renal disease, pregnancy, and patients who are on drugs which are known to cause fatty liver like methotrexate, amidron, ART, tamoxifen, barium salts, tetracyclines, estrogen, and glucocorticoids were excluded from this study. All the patients were assessed with complete history, and the following clinical and biochemical investigations were done. In clinical profile, weight, BMI, waist circumference, and waist and hip ratio were taken. In biochemical parameters, AST, ALT, triglyceride total cholesterol, LDL, HDL, triglyceride levels, fasting blood sugar, HbA1c levels, and thyroid profile was done. Homeostatic model assessment of insulin resistance, which was calculated according to the formula fasting insulin by fasting glucose divided by 405 were done. The chemical and biochemical parameters were correlated, and results obtained were tabulated and analyzed using appropriate statistical methods and tools. This is a summary for which the study was done. Mean age for the patient enrolled in the study was 40.84 plus minus 5.9 years. Most of the patients, around 56.6%, were females, and mean waist circumference calculated about to mean of 88.84 plus minus 13.36 centimeter. Waist hip ratio, which was raised in about 182 patients out of 330 patients, and mean about 0.87 plus minus 0.22 centimeter was calculated. Mean BMI, it was raised in 47.28% patients, and mean BMI was 227 plus minus 4.85. Among biochemical parameters, HbA1c levels were raised in 45.15% patients, out of which 29% were pre-diabetic and 16% were diabetic. Fasting insulin levels were raised in 36.4% patients, and homeostatic model assessment insulin resistance was raised in 54.2% patients. AST and ALT levels were raised in 48.4% patients. Mean AST levels were 40 plus minus 9, and mean ALT levels were 42.78 plus minus 9. AST-ALT ratio, it was raised in 86% of patients were has a ratio less than 1. Serum cholesterol levels were raised in 43.6% patients. Triglyceride levels were raised in 49.4% patients. LDL levels were raised in 38.8% patients, and HDL levels were decreased in 52.4% patients. NAFLD is an increasing public health issue that largely remains underdiagnosed. NAFLD is a consequence as well as precursor of metabolic syndrome. Cardiovascular disease is the leading cause of death in these patients. Therefore, adequate diagnosis and effective treatment are critical. Its pathogenesis is closely associated with disorders such as obesity, type 2 diabetes, and insulin resistance, and timely management of these can prevent the development of hepatic steatosis and progression to fibrosis and cirrhosis. In this study, we analyzed the clinical and biochemical parameters and their association in patients of non-alcoholic fatty liver disease. Majority of the patients who had deranged clinical parameters were found to have deranged biochemical parameters also. A significant positive correlation was observed between clinical parameters, especially waist circumference, waist hip ratio, BMI, and biochemical parameters including homeostatic model assessment, insulin resistance, LDL, triglyceride levels, AST and ALT levels. So these parameters can serve as an effective non-invasive markers of NAFLD. Waist circumference, waist hip ratio was found to be an independent predictor of NAFLD. Also, homeostatic model assessment insulin resistance strongly correlates with the risk of NAFLD and can be used as an early marker to detect non-alcoholic fatty liver disease. This study concludes that the clinical and biochemical parameters can guide in early diagnosis of non-alcoholic fatty liver disease and prevent its progression and metabolic and cardiovascular complications. Thank you.
Thank you, Doctor. I think as you have rightly said, the NFLD is a quite common problem, you see, usually underdiagnosed or maybe we don't look for it. You see, previously when we were students, we thought the cirrhosis of the liver is probably caused by alcohol only. And you see, then slowly and gradually we found that in Indian setup, the females usually don't use any alcohol, but still they have the incidence of cirrhosis as much as the men are. You see, probably then this concept of NAFLD came into market, that is the fatty liver disease probably is a precursor or maybe predisposed to the cirrhosis of liver.
Yes.
You mentioned the cardiovascular probably is the most important cause of death in all these patients. I thought cirrhosis is again equally sort of a responsible
Actually, cardiovascular risk and cardiovascular progression. Before progressing steatosis to cirrhosis, these patients have cardiovascular events. As NFLD is closely linked with cardiovascular risk factors, cardiovascular cardiovascular-related deaths were more common in these patients. Instead of cirrhosis, cardiovascular disease like stroke and MI were common associated deaths.
When you say effective treatment, what do you mean by effective treatment?
Effective treatment, there is no FDA approved treatment for NFLD. We can only reduce the risk factors for this disease. In patient diagnosis as only steatosis, 3 to 5% weight reduction is advised. In patient diagnosed as steatohepatitis, about 10% weight reduction is advised. And for other that, in patient coming with dyslipidemia, statins, phenofibrates, and omega-3 fatty acids are recommended. And in patient with diagnosed insulin resistance, insulin sensitizers like metformin, SGL1 agonists, and DPP4 inhibitors were advised. And vitamin E and tocopherol were also found to be decrease the oxidative stress for liver in these patients.
I think probably the effective treatment, you see, we mean always that the treatment of the underlying cause. Number two is the lifestyle management, you see, that probably is more important. And any question? Okay, thank you very much.
Thank you, sir, for your presentation. Now, next I want to invite Dr. Shivali Goyal, who will be presenting on the topic, a study of factors influencing readmission in general medicine and its association with mortality.
Good morning, everyone. I'm here to present my study. My topic is a study of factors influencing readmission in general medicine and its association with mortality. Introduction. Admissions to a general medicine ward contribute to a large proportion of total admissions. In most of the hospitals, one of its major contributor being readmission. Hospital readmission is considered a major focus of quality care as it puts an unnecessary physical, social, and also emotional burden on the patients. About 1/3 of them occur within a 1 month of discharge, half of them within 90 days, and 80% within a year. The term readmission has been defined variously as a repeated hospitalization within 1, 2, 4, or 12 months of discharge. There have been many factors that influence readmission risk and can be divided into 3 broad categories. First one is medical factors, for which information is readily available from secondary data sources. Example, discharge abstracts or claim forms such as age, sex, diagnosis, and procedure performed. Second one is other medical factors such as self-reported global and functional health status. And third one is non-medical factors such as marital status, living arrangements, access to care, and insurance coverages. Patients who are hospitalized in medicine wards are usually senior citizens who are suffering from chronic diseases with associated comorbidities. Material and methods are source of data. Participants were patients readmitted in the Department of Medicine at GGS Medical College and Hospital, Faridkot. My type of study was a hospital-based longitudinal observational study. Readmitted patients were followed up for a period of 6 months from the date of enrollment into the study. Place of study, GGS Medical College and Hospital, Faridkot. Study duration was 2 years and sample size was 100 patients. Sampling method, non-probability consecutive sampling. My inclusion criteria, patients readmitted within 1 year in the Department of Medicine, GGS Medical College Hospital, Faridkot. Age 18 years or above, and who give informed consent to participate in the study. Exclusion criteria was taken: patients on daycare hemodialysis, thalassemics, hemophiliacs, patients whose prior admission was more than 1 year back, prior admissions at hospital other than GGS Medical College Hospital and Faridkot, and readmission within 24 hours that were excluded from the study. Results were, there were several factors that were compared and studied in this study. First one was association with number of the readmissions with age and gender. We found there is no statistically significant differences was observed. Second, association between number of readmissions and number of addictions. There were significant association observed. Third one is association between number of readmission and total number of medications received in all hospital admission. Significant association was observed and more medications prescribed that leads to more readmissions. Fourth one is association between the number of readmission and more health insurance. We find if there is a more health insurance, there were more number of admissions. Fifth one is association between number of readmissions and number of comorbidities. There were when more number of comorbidities, it leads to more number of readmissions. Fifth one is association between number of readmission and affordability of treatment after discharge. Patients who were not affordable after discharge, that was readmitted more. Next is association between the number of readmissions and mortality. It was observed that patients who expired were admitted more number of times as compared to the patients who were alive at the end of the study. And this difference in the number of readmission between two patients groups was statistically significant. Conclusion, the present study was a hospital-based longitudinal observational study that was conducted on 100 patients who were readmitted in the medicine department of GGS Medical College and Hospital, Faridkot. Male predominance was observed in the present study. In the present study, the maximum number of patients admitted were twice, 62%, followed by 23 who were admitted thrice. 12% of the patients were admitted 4 times, and 3% of the patients have 5 admissions. It was observed that 72% patients were complained with their treatment, and 67 had medical insurances, and 98% could afford treatment during hospital, and 71% who could not afford treatment after discharge. The maximum number of patients had hypertension, followed by liver disease, that was 35, and diabetes 29%, renal failure 28%, some neurological disorder that were 28, and coronary artery disease that were 15%. 12% subjects reported previous surgery, while 7% each had hypothyroidism and HIV-related diseases. Maximum patient has a hospital stay of 6 to 15 days in the 6 months period, followed by 16 to 30 days in 35% patients. 10% of patients had a hospital stay of 31 to 45 days, and 5% has a hospital stay of more than 45 days, while 4% has less than 5% of hospital stay. Number of readmissions or readmission risk was found to be significantly associated with number of addictions. The patients who expired during the 6 months follow-up period were admitted more number of times as compared to the patients who were alive at the end of the study. And this difference in the number of readmissions between the two patients groups was statistically significant. My summary is hospital readmission is a major focus of quality care as it puts an unnecessary physical, social, financial, and emotional burden on the patients. Several patient-centric and treatment-centric factors influence the rate of readmission, important ones being substance abuse, presence of health insurance, comorbidities, treatment affordabilities, polypharmacy, length of hospital stay, and etc. Timely and effective redressal of these factors may reduce the risk of readmission, thus reducing the patient's financial burden and improving their quality of life. Thank you.
Thank you. What made you to think, to present this paper, you see, on readmissions? Why did you, thought about it?
Sorry, once again?
What made you think, you see, to write a paper on this readmissions, you see?
So this was a study that was done during my.
Because I think, you see, at times, even, you see, in a very busy hospital, when we are short of beds, sometimes, you see, early discharge of the patient is another reason for readmission, you see. So partly we are also to be blamed for that, for the readmission of a patient.
So you are right that actually this study needs more time and it needs.
The other probably reason is, you see, probably we, not in India, but shortly and slowly and gradually, I think we are also facing the same problem. I remember the incidents in UK that every year people used to go on holidays for 2 weeks, and they used to, you see, write a letter to the hospital that my father is not well, you see, or he's at home alone. So please admit him for 2 weeks because we are going on holidays. So there was twice a year, you see, we have to, that was a mandatory for us to admit all those patients, you see. So that was another reason for readmission, social cause for readmission.
Yes, sir.
Thank you.
Thank you, sir. Yes, I can say this study is equally important, that equally tells you about the multi-special, about the tertiary care center care and everything. That is right. Thank you.
Thank you, ma'am, for your presentation. Now I would like to invite Dr. Shubham Aryan, who will be presenting on the topic evaluation of clinical, endoscopic, and histopathological profile in patients with persistent dyspepsia.
So, good morning, everyone. Today I am here to discuss a study that is evaluation of clinical and endoscopically and histological profile in a patient with persistent and dyspepsia. This study was conducted last year in 2021 on the patient that are presenting with a persistent dyspepsia. So what is the aim of the study? We have done the study to evaluate the clinical, endoscopical, and histological profile among a patient with persistent dyspepsia. So this is a hospital-based observational study, and patient, both OPDs and in IPDs patients were taken in the study, and 180 patient was taken included in the study. Patient above age 18 of any gender is taken. Patient with a persistent clinical symptom of dyspepsia, that is epigastric pain, postprandial fullness, epigastric pain, nausea, vomiting, were considered. Pregnant and lactating women, patient with persistent lesions in the oral cavity and pharynx, and the patient who are not fit for the upper GI endoscopy were excluded in the study. So the detailed history of patient was taken, and patient who present with the symptoms of dyspepsia were subjected to upper GI endoscopy. Then the endoscopy specimen were taken from lower end of the esophagus and the upper end of the duodenum and sent for the histopathological examination in our in our pathology department. The endoscopically and histological findings of these patients and their clinical characteristics were assessed and correlated. And that specimen, that biopsy specimen underwent the rapid urease test for the presence of the H. pylori. So what we found is the patient who are dyspeptic slightly show the male predominancy with the age group of 30 to 50 years. The maximum presenting symptoms among these patients were epigastric pain, that was around 85%, which is followed by nausea and vomiting, which is around 66%, and heartburn in 57% of the patient. Along with indigestion was seen in 48% patient, and with loss of weight and intolerance in 11.3 and 11.6% respectively. 37% patient has a history of taking a spicy food and complained that their dyspepsia increased with the spicy food. Almost 21% patient have a history of alcohol intake, and 25% has a history of smoking. About 17% patients are on NSAID and other chronic conditions, such as arthritis. So most of the endoscopical findings we have found is gastritis, which is around 28%. That is followed by gastric ulceration, duodenitis, and duodenal ulcer. Esophagitis too was seen among 7.2% patient, and 4.4% show the growth. And about 13% show the normal endoscopically study. The most common histological findings that we seen in these patients were chronic gastritis, which is followed by gastric ulcer, duodenitis, duodenal ulcers. Esophagitis was seen among almost 9% patient, 3.9%, that is almost 4% patient had carcinoma, 1.1% patient have intestinal metaplasia, and 6% has intestinal polyps. And almost 14.4% show the normal endoscopical study. And the maximum patient that show the gastric ulcer, maximum patient of gastric ulcer and gastric carcinoma show a significant correlation with the presence of H. pylori. So conclusion, H. pylori is one of the major cause of dyspeptic symptom in the Northeast population. The proper evaluation and eradication therapy are needed to overcome this situation. There is a significant correlation between endoscopically and histological finding in H. pylori patients. However, a normal endoscopical appearance is a poor predictor of histological finding, and H. pylori infection may be positively associated with gastric ulcer and GI carcinoma in a statistical significant manner. Thank you.
Can I ask
Yes,
two
sir.
questions?
Yes, sir.
What is persistent dyspepsia in your study?
Sir, in this study, the patient who are having a symptom that are more than 2 months, we consider that patient as a persistent
But
dyspepsia.
I don't think you mentioned anywhere in your paper. Did you mention? No.
In this study,
Okay. You are saying 13 to 14% of the patient had no cause, histopathological. No known cause for their dyspepsia. 13 to 14%. This is what is in your study.
sir, 30 to 40% on endoscopically they were found normal.
Even histopathologically also they were normal.
Yes, sir.
No urease test was also negative.
That was negative, sir.
What is this patient group? Why didn't you label them with something like essential dyspepsia, psychogenic dyspepsia? Did you administer any psychological assessment also for such patients?
No, sir, we
No.
haven't done that.
There
for
has been a lot
psychological
of
profile.
literature upon essential dyspepsia. People have done primarily to find out patients who have got psychological problems of various nature.
Yes, sir.
Your study is quite good. In fact, you have covered many aspects, but I think these couple of aspects also need to be looked into because these are the patients who are primarily in terms of medication by most of the physicians also. They are subjected to, various kinds of medication.
Yes, sir.
So they enter into the vicious cycle of these abuse of antacid medications or PPIs and other kinds of things. So that is primarily what I wanted to tell you. Thank you.
Further, adding to Dr. Ravi's sort of a query, I think the incident 34% you say endoscopically, histopathologically normal. But I feel probably they're all patients who probably had H. pylori in the past. Unfortunately or fortunately in Indian scenario, anybody having with a little stomach pain or anything, either will be taking antibiotics or metronidazole without even consulting a doctor,
Yes,
you see. Probably partially that explains, you see, that those patients who never had any sort of endoscopical or histopathological changes, probably they're all H. pylori positive because H. pylori is very, very common here.
Yes, sir.
So maybe, you see, I think we need more study to confirm that.
Yes, sir.
So what I feel, you see, is clinically, you see, I mean, in day-to-day practice, you see, as most of our patients, they are consuming metronidazole, antibiotics all the time
Yes,
without
sir.
consulting the doctor.
What is the incidence of this H. pylori infection in India?
Sir, what is the incidence of?
Incidence of H. pylori infection, prevalence of H. pylori infection in India?
Incidence. So most of the, I didn't know the exact value, but most of the patient present with the gastritis, like sir says, have H. pylori, have a recent or a past infection of H. pylori.
It is about 85.
I think it's a crude method, it's not so evidence-based, that anybody who's having a recurrent dyspepsia and taking pantoprazole and everything, you see, and even without even second thought, you give a kit for H. pylori, probably I think 90% patients do respond to that, you see.
Yes, sir.
And if they don't have the facility for endoscopy or anything else, you see, probably that is a crude sort of, I mean, it is not evidence-based, but from observation, from clinical experience, that's what my feeling is.
So most of the patient that having a dyspepsia symptom from past 1 month or even 2 weeks, they do response with the H. pylori kit, sir.
Thank you.
Thank you, sir, for presentation. For next oral paper presentation, I would like to call Dr. Vikas Kumar, who will be presenting on the topic, Study to Determine the Diagnostic Utility of Treadmill Test in Asymptomatic Coronary Artery Disease Patients with Type 2 Diabetes mellitus.
Good morning, everyone. Today my topic is study to determine the diagnostic utility of treadmill test in asymptomatic coronary artery disease patient with type 2 diabetes mellitus. Diabetes mellitus is heterogeneous chronic metabolic disorder characterized by persistent hyperglycemia resulting from defect in insulin secretion and defect action or both. It is the commonest endocrine disease with every fifth diabetic in the world lives in India. The cardiovascular disease accounts for 80% of death in diabetic patients. Prevalence of silent myocardial ischemia among diabetes mellitus patients is Diabetes mellitus is a heterogeneous chronic metabolic disorder characterized by persistent hyperglycemia resulting from defect in insulin secretion, insulin action, or both. It is the commonest endocrine disease with every fifth diabetic in the world lives in India. The cardiovascular disease accounts for 80% of death in diabetic patients. Prevalence of silent myocardial ischemia in diabetic patient is 20% to 50%. Coronary artery disease is one of macrovascular complication which is leading cause of death and disability across the world. Patients having diabetes are up to 3 times more likely to die with cardiovascular disease than non-diabetics. Patient identification having probability of significant ischemia while performing routine activity can be done by treadmill test. Approximate sensitivity is 68% and specificity is 77% respectively in people with coronary artery disease. The absolute contraindication to exercise stress test including acute MI, high risk unstable angina, uncontrolled cardiac arrhythmia, symptomatic severe aortic stenosis, refractive heart failure, acute pulmonary thromboembolism, acute myocarditis or pericarditis and acute aortic dissection. Absolute contraindication to exercise testing include acute MI, high risk unstable angina, uncontrolled cardiac arrhythmia, symptomatic severe aortic stenosis, refractive heart failure, acute pulmonary thromboembolism, acute myocarditis or pericarditis, and acute aortic dissection. Aims of study to study attempts of demonstrating the diagnostic utility of treadmill test in asymptomatic coronary disease patient with type 2 diabetes mellitus and assessment of asymptomatic coronary artery disease by exercise treadmill test. Material and method, we use diagnostic criteria for type 2 diabetes mellitus with fasting glucose greater than 126 milligram per deciliter and postprandial 2 hour greater than 200 milligram per deciliter and HbA1c greater than 6.5%. We use observational study in 20% in 20 cases. Patient to be selected on the basis of inclusion and exclusion criteria. Inclusion criteria is type 2 diabetes mellitus patient without clinical evidence of coronary artery disease and normal resting 12-lead ECG. Exclusion criteria, patient who have history of chronic artery disease like hypertension and CVA, stable angina and unstable angina and myocardial infection, and other like chronic kidney disease and thyroid disorder, severe osteoarthritis. Patient with any other disease, we may not allow him and her to undergo treadmill test. Otherwise, patient not giving consent for treadmill test. And other investigation, routine investigation and treadmill test with ECG and 2D echocardiography if specific. Relation of diabetes mellitus and coronary artery disease. The coronary artery disease is associated with very high morbidity and mortality in type 2 diabetes mellitus. Coronary artery disease has more direct consequence, more prevalence among youngsters who are type 2 diabetes mellitus. Overall prevalence of coronary artery disease amongst diabetes is high as 55%, in contrast with 2 to 4% among general population. Dr. Anand D.V. et al. Showed in asymptomatic and uncomplicated cohort study compromising individual with type 2 diabetes, 3% had confirmation of coronary calcification indicative of coronary atherosclerosis. In autopsy study performed by Goria T and al. Of diabetes showed that prevalence of anatomic coronary artery disease as high as 50 to 81%. Approximate 80% of the mortality in diabetic resulted from cardiovascular disease, out of which 75% is due to coronary artery disease. Diabetic compared to non-diabetic have silent MI and increased risk of multivessel coronary artery disease due to severe atherosclerosis. Patient without diabetes but with history of previous MI or any cardiovascular event has prognosis similar to diabetic patient who do not have any history of previous myocardial infarction or any cardiovascular event. Observation in this observational study, we include 20 asymptomatic diabetic patients during study period. Out of 14, 70% were male and 30% were female. In our study, we found that 30% of the total participant had positive treadmill test, resulting of 4 male participants and 2 female participants, while remaining 70% of study group had negative treadmill test. Result which include 10 male participants and 6 female participants. During treadmill test on diabetic study participant, we found positive result of 30% of study participants suggest of coronary artery disease. Hence, in our study, we found that 30% of prevalence of asymptomatic coronary artery disease based on treadmill test. In our study, we did not found any significant correlation of gender with exercise treadmill test with p-value of 0.5824 with using chi-square coefficients. Summary: after analyzing various results and summarize in our study, we found that 20 study participants, 70% were male and 30% were female, with mean age of study population were 47.3 plus minus 7.8. In our study, we found that 30% participant had positive exercise treadmill test and 70% participant had negative treadmill test result. During treadmill test on diabetic study participant, we found positive result in 30% of study participant suggest of coronary artery disease. Hence, in our study, we found 30% prevalence of asymptomatic coronary artery disease based on TMT result. Conclusion: our study shows that 30% of prevalence coronary artery disease in asymptomatic type 2 diabetes mellitus participant. Screening for coronary artery disease should be done in all type 2 diabetes mellitus patient with prolonged duration of diabetes, as it will lead to early detection of coronary artery disease and its management will reduce the morbidity and mortality due to the same. All type 2 diabetes mellitus patient are high risk candidate for coronary artery disease, and those with prolonged duration of diabetes should undergo exercise treadmill test irrespective of symptom. Limitation of our study that is a pilot based study conducted at tertiary care center with small sample size, so result in our study could not be extrapolated to the general population. More community based study required for larger population to get prevalence of coronary artery disease in asymptomatic type 2 diabetes patients. Thank you.
Thank you. I think the basis of your study was exercise treadmill test. I think you never ever mentioned anywhere, you see what is the false positive and false negative sort of TMT sort of.
Yes, sir.
I mean, 30% patient TMT positive, again the rest 70% probably TMT negative. TMT negative, does it mean that they probably don't have any coronary artery disease?
Sir, TMT actually false negative result can be patient taking any drugs like digitalis, yeah, otherwise patient have less than 40-year age without any symptom of ischemic heart disease, and pre-menopausal women who have no history of ischemic heart disease.
Because it contradicts, you say in diabetes up to 81% probably patient have this coronary artery disease. But the study says only 30% people are positive with TMT. That means still there are 50% people you see who are still negative, but still having asymptomatic, but maybe having coronary artery disease.
Yes, sir. Then we required further more investigation.
I think probably false positive and false negative is again big drawback, you see, as far as TMT is concerned. I think they need to be subjected for further testing
Yes,
to
sir.
make sure that they don't have any coronary artery disease.
Yes, sir. We need further testing.
Hello. What was the diagnostic criteria for asymptomatic CAD?
Sir, asymptomatic CAD who have no in ECG finding we have no ST segment elevation and no pathological Q wave formation in the ECG, and
How will you label the patient as of CAD?
sir, patient have symptom of angina, sir, and
You take asymptomatic patients to include the asymptomatic patients of CAD.
yes, sir. Sir, patient have no complaint of chest pain and
How to diagnose it to be a CAD case?
I'm answering it on your behalf.
yes, sir. Sir, we use cardiotroponin marker and high. Yes, sir.
So there are false negative tests. So what is the relevance of your study when the 30% are detected, 50% are not detected? So why to harass the patient to undergo a test where false negative is more than the positivity is less? So why do this study? So basically it points out, why do we do a study? Either it is having got public health perspective, or it changes the clinical scenario, or the investigational part.
Sir,
only then it is relevant. So you have told that we did TMT, like in 30% asymptomatic, 30% were positive, and we are not considering the false positivity of TMT. Then what is the relevance? Why do the patient, you are spending 1500 rupees of the patient on the investigation, which has no relevance? Understood my point?
Yes, sir.
So basically, the inference of the study is irrelevant. It is not going to help the patient. It is not going to help in detecting CAD. So why do it? Definitely, definitely. You can go for lifestyle modification, because potentially diabetic patient is land up with CAD. If hypertension is there, treat hypertension. Obesity is there, treat obesity. Dyslipidemia is there, treat dyslipidemia. So treat the risk factors in asymptomatic patient and go for investigations if patient is symptomatic. Otherwise, asymptomatic patient, if the patient have all the investigations normal, still next day patient can have acute MI because of the unstable plaque. And you should know that stable plaque of more than 70 stenosis is not going to cause acute MI, rather 20% blockage is going to cause acute MI. So your study should have been, controlling the risk factors rather than going for investigation, which is not effective in screening the patient for CAD. Thank you.
Thank you.
Thank you, everyone. With this, we come to the first phase of our today's proceedings, that is case presentation. Now we start with the lecture presentation. Thank you.
For the guest lecture, I would like to invite Dr. Ravi Chand Sharma, who is Principal MMHCH Solan, former DM East and R Himachal Pradesh, Principal and HOD Psychiatry, IGMC Shimla, who will be presenting on the topic Psychiatric Comorbidities in Non-Communicable Disease, How Important.
Thank you, Dr. Ravi, for accepting our invitation to present this important topic. Thank you very much. MAPICON is obliged with your presence. Thank you.
Dr. K.K. Nohria, Organizing Chairman, Dr. Ashok Goyal, Organizing Chairman, Dr. M.R. Gupta, Dr. Keval Krishan, Organizing Chairman, Dr. Vitul Gupta, Organizing Secretary of this all-time awaited conference in so very important city of Punjab, Bathinda. Dr. Sonia Arora, Dr. Meghna Gupta, my student at Triple MCH, Komarati Solan. The entire cast and crew who have been managing this MAPICON 2022. I am thankful for being given an invitation on a topic which is so very important in modern times. I'll try to do some justice with this lecture. Psychiatric comorbidities in non-communicable disease. NCDs are basically chronic diseases which tend to be of long duration and are result of combination of genetic, physiological, environmental, and behavioral factors. That's the definition given by WHO. And the main 4 types of NCDs, which are a matter of concern for all of us, all physicians, all endocrinologists, even psychiatrists and other discipline people, are primarily cardiovascular diseases, whether it is cardiac disease, stroke, or hypertension. Diabetes, chronic respiratory diseases, and cancers of various types. Now, etiology and risk factors. As I am telling you that these are long duration diseases, they have got a protracted course, multiple risk factors, complex etiology with disability and impairment. which they leave the patient with. The rise in NCDs has been attributed primarily to 4 risk factors, which we all know. But probably sufficient efforts have not been done to control and contain them. Tobacco use in various forms, physical inactivity, harmful use of alcohol, and unhealthy eating. It's important to know that commonly used substances such as tobacco, which is prevalence shows roughly 15% or so, alcohol 28.6%, they cause significant morbidity and mortality in NCD patients and psychiatric disorder patients or mentally ill patients. Mental disorder prevalence average 14.3% is also a matter of great concern, and this is a major health problem in India. Now, for the sake of simplicity, if you divide mental disorders into common mental disorders and major mental disorders, let us see how they are affecting NCDs. The common mental disorders which are invariably associated with NCDs are depressive disorders and anxiety disorders. Now, these are quite common and they affect mood and feelings. Symptoms ranging from mild to severe in terms of severity, and they last from months to years. These are diagnosable but are distinct from routine feelings of sadness, stress, or fear. This is very important. There are certain definite criteria in the International Classification of Disease and American Psychiatric Association diagnostic classificatory systems, different for a different kind of a psychiatric disorder. Being common emotion, they should not be simply thought of that somebody is having a simple sadness or stress due to some routine life situation. That may not be so important, but if it is a chronic or if it is qualifying for a diagnosable mental disorder, then of course it's a matter of concern. Severe mental disorders primarily include bipolar affective disorders, mania and depression, mixed disorders, or mania and depression separately or in the form of a bipolar disorder, then schizophrenia and other types of psychotic disorders. Now, world over, the magnitude and burden of NCDs and mental disorders, if we see, NCDs are a major cause of mortality and morbidity in developing nations, including India. Globally, mental disorders are third biggest cause of disability, adjusted life years. If you see the disability which the individual is having, and he's living a life with that particular disability, so primarily this disability has been seen mainly in the mental disorders. These people go for sickness, absenteeism, leave of various kinds, and live mostly a non-productive kind of a life. Mental disorders, especially depression, accounts for significant morbidity and financial burden upon the family. Now, if we see, a study was done, cross-sectional survey was done in South India by Nimhan's people, and another study was conducted in indoor medical patients at Nepal. So NCDs were found to have a high mental or psychiatric comorbidity, as is evident from the table. Somatization disorders, depression, anxiety primarily figured out. South India, 35% patient had somatization disorders, variety of pains, conversion symptom, all those kinds of hypochondriasis, all those kinds of disorders. Depression, roughly 30%, anxiety, roughly 20%. And in the hospital-based studies, obviously this data is on the higher side, because this was done primarily in the patients who were admitted in the medical wards at Nepal. Now, globally, NCDs account for 41 million deaths per year, making up to 71% mortality worldwide. More than 15 million people between 30 and 69 years of age die from non-communicable disease per year. 85% of these premature deaths occur in low and middle income countries. 77% of all deaths occur in low and middle income countries. And if you see the mortality, cardiovascular disease, about 18%, cancers 9.3, respiratory disease 4.1, diabetes 1.5. These 4 NCDs account for over 80% premature non-communicable disease deaths. That's why Government of India has rolled out a program for the control and of course to do various kinds of research upon NCDs. So NCDs are leading cause of death in India and accounts for 20% of cardiovascular deaths in NCD patients worldwide. Prevention of 2 leading risk factors for cardiovascular disease, as it was said by one of the students in his study, diabetes and hypertension. So they are topics of public health priority. Compared to West, cardiovascular disease manifests about a decade earlier in Indian population. Rapid urbanization, industrialization, globalizations have led to drastic change in the lifestyle of people. And this has led to the increasing burden of obesity, hypertension, diabetes, and dyslipidemia, which are known risk factors for cardiovascular disease and events. Cardiovascular disease roughly account for 23% and 30% of the total mortality in rural and urban population. Urban little higher, rural little less, but it is still there also. Now WHO, World Health Organization, is seized with this problem, and they have made a target of reducing premature deaths from NCDs by 1/3 in order to achieve 2030 agenda for sustainable development. Action plan to control NCDs, India being a signatory state to Global Action Plan for Prevention of NCDs in India, is committed to halt the rise of diabetes by 2025 and reduce the prevalence of hypertension by 25% between 2010 and 2025. And to achieve this, India has launched a multi-sectoral plan for the prevention of NCDs. Now, what is the commonality between NCDs and mental disorders? Primarily topic given to me for discussion. NCDs are supposed to have a complex etiology with multiple causal risk factors, such as hyperfunctioning HPA axis, hypothalamic pituitary adrenal axis. This is the axis which is very important not only for endocrinologists or for a psychiatrist, but for a physician, for a gynecologist also, and so on. Genetic factors, childhood adversity, again generating a lot of stress, stressful life events, and substance abuse. Now, these are risk factors for mental disorders also. That is why it has been said that it's a hand-in-glove association of mental disorders with NCDs. Another group which is a matter of concern for all of us, aging population, and NCDs are common in elderly. NCDs are known risk factors for cognitive decline and dementia. Now, in a couple of studies, it has been seen that 25% subjects with hypertension and diabetes had cognitive decline, again because of complex factors of dyslipidemia and vascular problems. In another 1/3 subjects from an NCD clinic, it was found that they had anxiety and depression. Comorbidity is a big challenge and it continues to grow yet remains underestimated. Increase in life expectancy, lifestyle changes, stigma of mental illness, late recognition of comorbid diseases and failure to treat them timely and adequately. I would request youngsters to focus upon the lecture rather than simply sleeping on the table or otherwise. If they're too tired, they can move out. Some girl is still sleeping. Dr. Vitul, I think this forum is primarily meant for youngsters also and other people also. We are all seniors also. If students have come to sleep in the auditorium, then there is no fun. If simply they have to present papers which are not worth presenting, I don't think the very purpose of this MAPICON is met with. Lot of mistakes, grammatical mistakes. The girl doesn't know what is conclusion, what is summary. I am not criticizing youngsters, but I think there should be a critical analysis of their papers also.
So definitely true, because this reflects their guides in fact. They should check the papers before, it is very easy to point out the deficiency of the students, but I think the teachers are at the fault because they don't check the, each and everything what the students are going to present. And I will agree with you that these is substandard papers, only formality for fulfilling the NMC or their MD criteria. Because I have checked a few posters where routine presentations were presented as rare presentations. So that is why my passion is challenges in medical education. Wherever I go, I speak on this thing, that challenges in medical education, where both teachers, the faculty, as well as the students are failing, posing a great challenge for medical education in India. Definitely, sir, you are very right in pointing out.
NMC basically has done a good job, but are we really following that job or those directions sincerely? That's a matter of question. Anyway, I am very sure that from next time onwards, there should be a proper screening of all those posters and papers also, which you really put in this so-called and so very important conference. And it should not be simply used as a forum simply for coming and getting your paper, registered in this conference. Sorry for my words, but I think they should be taken as encouraging words.
Yeah, point well taken. We will do that next time, sir.
No, the attitude of the student is reflected, If somebody is sitting in the auditorium, they should be sitting for a purpose. If they are simply sitting for a certificate to be given them, go and have tea outside, relax outside, and come when the papers, your certificates are being delivered. Okay, anyway, I'll continue. Lifestyle change, stigma with mental illness, late recognition of comorbid diseases and failure to treat them timely and adequately. I was referring to one of the youngster who was presenting here, essential dyspepsia. The first thesis which was done, I had joined my medical college in IGMC, was on essential dyspepsia. That time this urease test, etc. was not probably there, and we had put up in the limitation also that we have not done this. But as Dr. Saab also pointed out, you should critically analyze what you are presenting, what new thing you are bringing out, what is the cause, why you are doing research. Just for the sake of doing research is not a research. So that is, what is need to be looked into. Now, current trend of super specialization, we were discussing in the that coffee room, has worsened the situation. Healthcare professions may be aware of the problems related to comorbidity, but most of them are not trained to deal with such patients. They say, sir, मेरे को इतना ही आता, मुझे नहीं पता जा रहा. So comorbidity issues are usually not adequately addressed in the management of such patients. Now, diagnosis of a physical disorder is often neglected in the presence of a mental disorder. This is true for the psychiatrists also. Dr. Meghna is here. Invariably, I have been, scolding them. मेरे को कोई पेशेंट अगर आप फिजिकल एग्जामिनेशन के बिना किसी ने प्रेजेंट किया तो स्टूडेंट बाहर. So that is what is, my kind of a stance in this regard. Everybody should be like that. Psychiatrist doesn't get marks for simply diagnosing mental disorders. We are supposed to do otherwise also. They should get marks for the patients who are borderland, who should be sent to medical people, gynae people, surgery people and all that. Otherwise, we are going to commit harm. yes, vice versa is equally true. So neglect of the patient, neglect by the family member, mentally ill patient I am talking of, neglect by the physician also. Sir, a psychiatry, refer to psychiatry, not even pulse BP you have seen, sir, psychiatry. So invariably the patient have to suffer from various kinds of subsequent aggravation of the illness. Now, presence of mental disorder has got a negative impact upon the treatment adherence. You must have seen a lot of physicians here, sir, dawai nahi khate. So how would you control their physical ailment? Perception of the physical ailment is colored. Depression, of course, is very important reason. Perception is altered and improvement may not be reported due to hopelessness. We get invariably call from medical wards, sir, ये आप देखिए इनको ये ठीक नहीं हो रहा है. अब देखो depression तो नहीं है कहीं पे. So patients with psychosis may not pay heed to physical ailment at all. And in fact, they are overlooked also. Many a times they are having, acute abdomen problems or even MI also. Many people die in the wards also. Sir, ऐसे ये maybe hypochondriacal or otherwise false complaint of pain. And if you see the patient is having a coronary artery disease. Now, people with mental disorders, they ignore physical health hygiene, then hygiene, do not follow healthy lifestyle. They suffer from deprivation, discrimination, and poverty, and commonly abuse tobacco, alcohol, and drugs. Lot of schizophrenic patients smoke. अब कर लीजिए जो कुछ करना, वो नहीं छोड़ते. So that, in fact, remains a problem. There are various theories. Many people have done studies also. There is some kind of a stimulation because of nicotine and all that, so they don't want to leave it. He is having an active symptom of schizophrenia, but they will not. तंबाकू का पता है, बीड़ी कहाँ से मिलेगी, मैंने पीनी है. They suffer from adverse effects of psychotropic medications also. So another risk factors increase mortality in majority of such patients is due to physical disease, which co-occur, which are not prevented adequately, not picked up, and not treated effectively. Mental disorders as such are risk factors for NCDs, and the common factors are poor nutrition, use of tobacco and alcohol, and less physical activity. Now, these factors also predispose for medical comorbidities. We all know hypertension, metabolic syndrome, obesity, CAD, stroke, and cancer. Now, common mental disorders, the relation between diabetes and depression is well known. I am sure a lot of theses have been in our institution also. People have been doing, theses, the patients of diabetes mellitus having depression or other psychiatric comorbidities. That also becomes a topic for theses. Overall rates of depression in individuals with type 1, type 2 diabetes across the lifespan is 2 times greater than in the general population. Diabetes is more common among people with severe mental disorders. And anxiety and depression are common among people with respiratory disease. A lot of thesis work has been done in this direction also. And various research papers. Poor communication between the patient and the treating staff is very important. Belief that, sir, cancer ko treat karo ji, depression apne aap theek ho jayega. So that belief has to be broken. You should treat the depression. I hope the patient will cooperate more for cancer treatment. Stigma discourages patient to speak about psychological symptoms. I have seen many friends of mine, their sons and daughters suffering from various kinds of examination-related stress or otherwise psychotic disorders. Even my friends also, so asking them, कि यार तुम्हारे पापा मेरे दोस्त है, सर उन्होंने कहा साइकाट्रिस्ट को नहीं दिखाना है, तो किसको दिखाना फिर? So that is the kind of stigma, you can imagine when if it is present even in medical colleagues also what to talk of others. Late diagnosis of depression in cancer patients is because sufficient time is not given by the treating staff or they are not trained enough to pick up the depression. Somatic symptoms are attributed to medical illness rather than somatization and depression. There is one of the lectures, I suppose I read somewhere that there was a lecture in this MAPICON, pain all over. somebody you have called for giving this lecture also. So this pain all over is not only of psychiatric concern, it may be of a concern for rheumatologists also or other endocrinologists also. Meta-analysis of 14 Indian studies has found that 10.81% versus 33.5% metabolic syndrome in community versus hospital-based studies has been there. Metabolic syndrome is a matter of great concern these days. All medical and psychiatric wards, there should be adequate efforts that the height, weight parameters, insulin resistance, GTT, blood pressure, and all those things, waist circumference. These parameters, I think if we start recording, we have started recording it regularly, you can bring out very, extensive data and a good data, which can throw better light again upon these and how to control also these things. Metabolic syndrome. Bipolar patients, 55%, which is much more than schizophrenia, 34%, and again, more than controls, 6%. High proportion of prevalence of insulin resistance in bipolar drug naive patients versus controls. Even if they have not been exposed to drugs also, still you find there is insulin resistance. And there again calls for a commonality between the causation of NCDs and mental disorders. Psychoeducation, kya kare? Management, what is to be done? Educate the person with mental disorder in subject areas that serves the goals of treatment and rehabilitation. We focus here upon the importance of adaptive lifestyle. Exercise, aerobics, yoga therapy, we all talk about. We must ask our patients also to do these things. Diet counseling, less of salt, sugars, fats, increased fruits and veggies, minimizing fast foods, colas, etc. Abstaining from tobacco and alcohol. Tobacco in any form is deleterious to health. Controlled, no or controlled drinking, sensible drinking, question of debate, but better not to take alcohol. Psychotropic medications, kaun si use kare? Frequently asked questions. All those psychotropic drugs with little potential for metabolic side effects should be used. If I talk about antidepressants, sertraline is one of the best drugs. Escitalopram, all physicians use. Bupropion, they may not be using so commonly. It is used for smoking cessation also. Tanaptine is also another good drug in cardiac patients also. Very safe and very good. Antipsychotic drugs, quetiapine is one of the best drugs. Anybody can use, very safe drug. Low dose is very effective. Organic brain syndrome, dementia, whatever, delirium even, mania, depression also we use it. Ziprasidone does not increase weight, but it causes concern with cardiac side effects. Torsades de pointes, there's widening of the QRS complexes. That's a matter of concern, but primarily used by psychiatrists. Aripiprazole, another good drug, less of metabolic side effects. Haloperidol, of course, a sheet anchor. Comparatively, out of the typical antipsychotics, it is used and has got less potential for metabolic syndrome. Mood stabilizers, lithium we use, comparatively having a less potential for metabolic syndrome. Oxcarbazepine and lamotrigine, good drugs. And others, lurasidone is another drug which psychiatrists use in bipolar depression or even in schizophrenia. Using medications to control weight gain, metformin and topiramate. I use it very frequently. And many times, my patients go to the chemist, they say, "Aapko diabetes hai?" नहीं सर ये तो psychiatrist है उन्होंने लिखी अच्छा इन्हें तो diabetes के लिए देते हैं so we have been using this medication for controlling their obesity. Liaising with physician, endocrinologists and gynecologists. Advice to healthcare providers, they should be sensitized about comorbidity issues and should be trained enough to detect somatic symptoms which are exaggerated or unexplained by underlying medical condition. They should pay attention to the lifestyle modifying behaviors of the persons with mental disorders. Persons with severe mental disorders should have some basic health screening program. This is very important for the general population. cardiovascular risk factors, diabetes, COPD, and cancer. We hardly include these patients in various types of camps. I have myself seen. I have been organizing camp, our institution has been organizing camps. They don't include a psychiatrist, but anyway, I took them to my village also. We had 300 odd patients, and of course, psychiatric consultation was also done. And now I have asked them that include this thing also there, you know. And if you have got a screening program, please include mentally ill patients also. They are kept aside. They are not assessed for cardiovascular risk factors, COPD, diabetes, cancer also, because invariably they don't complain. Persons with NCD should be screened for comorbid mental disorders also. Vice versa I am talking, as well as for tobacco, alcohol, and drug abuse. In Himachal Pradesh, there has been, when I was Director of Medical Education, there was a program rolled out by Government of India, and we have successfully launched it in the state of Himachal Pradesh through, those Anganwadi workers and ASHA workers. The health screening of patients, community population for NCDs, and primarily of my concern, tobacco, alcohol, and history of mental illness. These are also factors which have been included therein, and the project is going on. So, concluding my presentation, reduced life expectancy, healthy life expectancy due to high burden of both mental disorders and NCDs is a major public health concern. The links between mental disorders and major NCDs are well established. Mental disorders in patients with NCDs as well as NCDs in patients with mental disorders are often overlooked. Increased morbidity, disability, and mortality can be reduced if we manage comorbidity timely and effectively. Further reading. And with that, I thank you all of you for forcibly giving me time for my presentation, particularly youngsters I am focusing, not the senior ones. Thank you very much.
Thank you, sir, for
I
a
would
great
welcome
talk.
any questions or any comments, compliments.
So any questions?
Thank you, Dr. Ravi, for a very nice presentation of an overlooked problem, as you rightly said. I just have a little doubt, you see. I may be wrong, you see. I don't think there's, because most of my patients, particularly females, they do complain about weight gain with the antidepressants. And as you said, you see, using metformin or topramide, you see, to reduce weight. As far as, you see, I may be wrong, there's not mentioned anywhere as far as to reduce weight, you see, or in obesity, you can use metformin or topramide. I mean, is it common practice with you, or is it?
Now, if you see, our psychiatric literature, world over, psychiatrists have been using these drugs because we are primarily fighting out of the obesity, which is caused because of the psychotropics. There may be n number causes of obesity, particularly in females also. Not only, even thyroid and other kinds of disorders, of ruling out all those things and of course adequately treating them also. Psychotropic drugs, which I know that I have to give to this patient, for example, divalproenosodium, I have to give, there is no other way out. Olanzapine, I have to give. So again, we still combine these drugs also to minimize, at least if not very effective, we minimize that kind of a weight gain. So that is the main aim. But primarily anti-obesity drugs is not the thing which I am telling.
Fine. I got your point.
Any other comment? So Dr. Ravi, excellent talk. As far as our experience goes, NCDs, 80% of people are having mental disorders. And definitely it is affecting mortality, morbidity, as well as quality of life. And tragedy is whenever we suggest, so basically a physician is acting as a psychiatrist also. Awareness is being generated and more people are going to a psychiatrist. But majority, when we suggest that you have major depression, it is obvious. And you should go to a psychiatrist. So, majority of the patients tell, "Main sir pagal thodi hai ji." So that is the hindrance. As you have rightly suggested, that NCD camp should have a psychiatrist also. But, again, the government is not sensitive. And we are to generate awareness for the government as well as for the public, which is much more important for public to accept that mental disorders are to be treated by an expert psychiatrist. If the physician treats, maybe to some extent, but it may not be properly being treated. So definitely great lecture for awareness of doctors as well as for public. Thank you very much, sir.
And we assure you, next time probably we'll be more critical about the oral presentations. Thank you very much.
Before I leave, just a few words about that which Dr. Vitul has said already. I think I have been the main proponent, not that I am a psychiatrist, that is why I am advocating for the rights of mentally ill people. In my own institution, starting postgraduate course in psychiatry in Indira Gandhi Medical College, that was the last course started, along with chest and TB. Now I think all over Himachal, my students are there. Now they have become senior professors and all those also, APs and also, not beyond that. There was no psychiatrist except for me and one or two other person. So invariably one of them would leave and the youngsters I'll pull and motivate them, stay here, stay. There were no PG also. So I have been able to start postgraduate courses in my medical college and now it's a well-established department. I was the individual who fought for the stigma which Dr. Vitul is straightway saying. Initially I said, I was telling Dr. Meghna also that we started PG. I said, aayega koi yahan pe kisi ne karna hai. But there were, even girls were the first to come. I said, we didn't have a psychiatrically trained nurse. They have to do diploma in psychiatry. So a lot of nurses were there, sir, maine aapke ward mein kaam karna hai. And we never had, dearth of nurses. But somehow that jinx had to be broken. We have broken it. It needs to be broken primarily by physicians, by gynecologists, by surgeons and other people. As we were talking, everybody is a psychiatrist except for a psychiatrist. So if you have this attitude, then the patient will not be referred to. They will be half-treated, non-treated, maltreated. A very small, incident I'll tell you. One big person, you all know, I don't want to tell the name. Various kinds of, government high official and all that, living a very exemplary kind of a life. One day the news comes that he hangs himself and dies. I just inquired one of my friends, he was having a, evening drink with him and he just told me. I said, yeah, he must be having a psychiatric problem. He said, yes, he did. And I was motivating him. He said, I won't meet a psychiatrist. He was suffering from depression for a couple of months. And I used to have a couple of pegs with him. Maybe that was his medicine to get away with the depression also. And I suggested him that you take 5 milligram of escitalopram if you don't want to go to a psychiatrist. After 5-7 days, he hung himself and died. So everybody thought that it was a planned suicide and kuch nahi tha, koi psychiatric issue nahi tha. We have not to stigmatize such people in the guise of that they had a psychiatric issue. But the research shows that more than 85% of the patients have got some kind of a psychiatric association if they commit suicide. But even then we don't send patient for psychiatric referral. Physicians are the first person. Now the question is how to send a patient. बीबी तेरी मर्ज मैनू समझ नहीं आई तू छदम कर दी है तेनों कुछ पता नहीं लगता तेरी प्रॉब्लम मैनू नहीं समझ आई तू पागला ने डॉक्टर को जा तू साइकियाट्रिस्ट को जा now would you see the patient will come they will never come. So I think we will have to be a little soft and we should talk in a proper way how we refer the patient. But otherwise mild cases, even moderate cases also, physicians are the best person. Even radiotherapy, people who admit patient in cancer wards can treat their depression there and then. If they find that these are the patients who need to be referred, it is your skill, which is called art in medicine, how to refer that patient to a psychiatrist.
Definitely, sir. I do one simple thing. I know one question, ke maran nu ji karda. If she says he is a fit patient to be referred, if he is not conducive to the idea of referral, I tell him that I will treat you for 15-20 days. If you are okay, it is fine. Otherwise, you need to see a psychiatrist. And 90% of the times, if patient is not adequately treated with antidepressants by me, patients are conducive to go to a psychiatrist. So you need to prime the patients that psychiatry is not only Paglanda doctor. He is going to treat each and every small mental illness, and 90% of, definitely you are very right, that it is how the patient is being referred by a physician to psychiatrist, that patient is going to go a psychiatrist. When I am referring, almost 99% patients go to a psychiatrist.
Thank you. Thank you very much.
Thank you, sir.
Our next guest speaker is Dr. P.D. Bansal, Professor and Department of Psychiatry, GMC Freethcourt, who will be presenting on the topic stress management.
Respected Dr. Noria, Dr. Ashok Goyal, Dr. Agarwal, Dr. Vitul Gupta, Dr. Usha, my colleague Dr. Poonam, my friends, colleagues, and students. A very good morning to all of you. First of all, I thank MAPICON for uplifting the name of Bathinda, a lesser known district on the map of Indian history. My topic today is stress and its management, and I have tried my best to keep this a simple one. First of all, what is stress? Stress, as you know, is defined as any internal state caused by physical demands on the body or by external or environmental events which are perceived as harmful and dangerous, and which are beyond our capacity to cope up with. These causes, physical, environmental, or social, these are called stressors. Once induced, stress can lead to various bodily responses, for example, increased heart rate, increased BP, which later on produces cardiac diseases, or long-term psychological changes in the form of depression, anxiety, irritable behavior, hopelessness, etc. If these changes, they hinder our way, how we deal with daily activities, they disturb our life and causes discomfort in our life, then these stressors, they become problematic and leads to a vicious cycle which continues. On the other hand, many people, they develop right ways of coping with these problems and lead to a wellness cycle. Today, our aim is to achieve this wellness cycle with the help of right coping mechanisms. Stressor can be external to our body, for example, toxins, environmental noises, etc., or internal to the body in the form of our attitudes, our mood, anticipations, memories. Whereas stress can be acute if it is of short duration, occurs out of the blue, chronic stress in the form of longer duration, episodic, which occurs in definable periods of time, and PTSD, that is post-traumatic stress disorder, where stress occurs when we confront or see a life-threatening situation. To achieve wellness cycle, the first step is to identify the sources of stress. In this, a stress journal can help us. So start writing stress journal. A stress journal, it will help you to identify the regular stressors in your life and the way you deal with them. Each time you feel stressed, keep record of it in your journal. As you keep a daily log, you will begin to see common themes and patterns. So write down what causes you stress. If you are not sure, then make a guess. How you feel both physically and emotionally. How you acted in response to that stressor. And what you did to make that situation comfortable. Then think about the ways how you are coping with these stresses. Are your coping mechanisms healthier or unhealthy, fruitful or unproductive? Unfortunately, many of us, they deal with problems in such a way that we compound the problem. These are the unhealthy ways of dealing with problems. Initially, for a shorter time, these mechanisms, they decrease the stress, but in the long term, these are more damaging. Some of the unhealthy ways of dealing with stress are smoking, drinking too much, overeating or undereating, watching TV for long hours, withdrawal from friends, families, and activities, using pills or drugs for relaxation, sleeping too much, procrastinating, filling up every minute of the day to avoid facing problems, and taking out your stress on others in the form of anger outbursts or physical violence. If your method of coping with problems is not working, then it is time to change these into healthier ones. That is, right coping mechanisms. There are many healthy ways by which we can manage and cope with stress, but they all require change. Change in the way we react to the problems. When we are deciding to change, then please think about 4 A's. That is, avoidance, alteration, adaptation, or acceptance. Since everyone has a unique response to stress, there is no one-size-fits-all solution. No single method works for everyone or in every situation. So please try with different techniques and strategies to solve the problems. And which strategies are helpful to you, please stick to them. So the first strategy to manage stress is avoidance. Not all stress in your life should be avoided, as some sort of stress is required for our physical and mental growth. But with the help of stress journal, we can reduce a lot of stress in our daily life. Always know your boundaries, your limitations, both in personal and professional life. When you are overburdened, please avoid taking added responsibilities. Because in these scenarios, if you handle on more than you can handle, then these will surely misfire you. So in these scenes, simply and politely say no to save your professional relationships. If certain peoples or colleagues, they are stressing you, then try to end the relationship with those persons. If it is not feasible, then at least restrict the time you spend with these persons. If you are stuck in an environment where you cannot escape, for example, in long traffic, then take it as an opportunity to regroup yourself, take it as a time to relax yourself or listen to some of your favorable music. If current religious or political matters, they are bothering you, then stop your conversations when these are the matter of concern. Or at least excuse yourself when these are the topic of discussion. If you have a lot of work to do, then please make a list of all the important things priority-wise. First of all, do all the important works. The lesser important ones can be eliminated. Second strategy is alteration. If avoidance fails, continue with alteration. This requires change in your behavior, how you operate and communicate with the people. When the things are not going in your way, please raise your voice. If you will not raise your voice, resentment will build up and the situation will remain the same. When you require a change from other people, be willing to compromise yourself also. As when both of you are ready to change, then there are more chances that you will find a healthier solution. Be positive in your life. always take the problem head on. Please try your best to solve the problem so that it does not occur again in future. And manage your time better, as poor time management can lead to various types of avoidable stress. When you are too stressed, proper time management, with the help of prior proper management, we can handle the situation very well. Third is adaptance to the stressors. This requires change in your adaptability. Look at the picture from more positive side. Look at the bigger aspect of the problem. Ask yourself, how is this problem going to impact you in longer time? Will it impact for a few days, few months or weeks? If the answer is no, then leave it behind and move ahead. Perfectionism is another source of avoidable stress. Please avoid demanding perfectionism from yourself and your colleagues. Always be happy with the good enough. And if the stress is making you down, take a pause, look at all the positive qualities and positive gifts you have. This simple strategy will help you to keep the things in perspective. In life, many situations are where we cannot do anything. So in those situations, accept the things. It is difficult to accept the things, but in the longer run, it is easier rather than railing against a situation where we cannot do anything. Some sources of stress, they are unavoidable. For example, behavior of other people. In those circumstances, focus on your behavior, how you respond to the situation. Look at the bigger picture of the problem. As is the saying, which does not kill us, make us stronger. So if the problem cannot be avoided, look at your own mistakes or your current scenarios, how you can deal with this problem. Learn from your mistakes and move ahead. Share your feelings. This is also important. When you are stuck in a difficult situation where you can do nothing, at least share your feelings with a trusted friend, as this will help in ventilating your emotions, and by way of catharsis, you will feel better. Next important thing is learn to forgive. As we are living in an imperfect world, so be ready to forgive people. Strategy number 5 is to find time for relaxation. This can be done with the help of going for a walk, spending some time in nature, calling a good friend, sweating out tension with good workout, by writing in journal, by taking a long bath, or with the help of light-scented candles, by playing with a pet, or by gardening, by getting a massage, by reading a good book, by listening to favorable music, by watching a comedy movie. So all these are methods for relaxation. Next and the last step is to adopt a healthy lifestyle by indulging in exercise. Please do exercise daily for at least 15 to 30 minutes, as healthy body is better prepared to cope up with stress. Eat a healthy and balanced diet. Reduce the amount of caffeine and sugar in your daily life. Avoid excessive alcohol, cigarettes, and other drugs. And take good sleep. As with fresh mind, you will take good decisions so as to cope with stress in a nicer way. Thank you. Any question?
Thank you, Dr. Bansal, for an excellent talk. And this is what is needed today, I think, stress management. It is very easy to say कि यार टेंशन ना लाया करो. ਤੁਸੀਂ ਸਕੂਟਰ ਬਾਹਰ ਕੱਢਦੇ ਹੋ ਨਾ ਤਾਂ ਟੈਨਸ਼ਨ ਹੋ ਜਾਂਦੀ ਹੈ ਵੀ ਕੋਈ ਵਿੱਚ ਨਾ ਮਾਰ ਜੇ. ਜੇ ਪਰਸ ਲੈ ਕੇ ਜਾਂਦੇ ਹੋ ਟੈਨਸ਼ਨ ਹੋ ਜਾਂਦੀ ਹੈ ਕੋਈ ਖੋ ਕੇ ਨਾ ਲੈ ਜੇ. So it is very, very important stress management. How to manage that stress. I think it should generate lot of questions कि सारे stressful हो कि किमें manage करिए.
Hello. Methods how to decrease stress, but the problem is in implementation. Simply by avoidance, alteration, adaptance and acceptance, we can decrease more than 50% of our daily stress.
Dr. Bansal, I feel strongly, मैं तो मानना है कि अगर कोई मैंने कहता मैंने स्ट्रेस नहीं है, I think वो झूठ बोल रहे हैं. पहली गल. दूसरी गल है, it is said easy said than done. You see, I mean it is not that easy as we always talk about. कि यार स्ट्रेस ना ले. अब सवेर तो लेकर शाम तक मरीजों ने कोई गल कही नहीं स्ट्रेस ना ले, स्ट्रेस ना ले. You see, if he has his own environment, which is so stressful, unless you deal with that environment, I don't think he's going to be off his stress, you see. The other thing you said, you raise your voice, and at the same time you say, don't crumble. You see, it is two are the contradictory statement. You see, if you raise your voice, you see, then you can't complain about it.
That was the point in your professional life to safeguard your professional relations.
And I think at the end of the day, probably forgive is the best sort of a solution for everything, you know. वो कहते हैं हम सुबह भगवान की प्रार्थना इसलिए करते हैं कि जो मेरी गलतियां माफ हो जाएं, तो इसलिए वो एक्सपेक्ट कि अगर हम माफ करना सीख लेंगे तो probably everything will be all right.
Regarding your, sir, as you previously said, stress तो फिर चाहिए sir, otherwise we cannot grow. Stress. Thank you.
Thank you, Dr. Bansal. We are highly obliged with your lecture. Thank you.
Thank you, sir. Now I would like to invite Dr. Shankha Sen, MD Medicine, Senior Consultant Physician, Dr. Sen's Diabetes and Thyroid Clinic, Neosia Gatwell Healthcare Center and Basus Clinic, Siliguri. He will be talking on the topic, vertigo, what to do.
So thank you, Dr. Sen, for coming all the way from Siliguri. I think he deserves a lot of applause. And we are highly obliged with your presence. Thank you very much.
Thank you, sir, for your kind words and your kind invitation. It's my pleasure to be at Bathinda on invitation of API Malwa branch. I am from Siliguri in the district Darjeeling in North Bengal. Probably you know it's at a good tourist place. My welcome to all of you if sometimes you get a time to visit us. So my talk is on updates in the treatment of vertigo. So I will be talking mainly on the medical management part of vertigo. As you all know, it's a doctor's nightmare. When a patient presents with vertigo, it's not always plain and simple. It involves not only the visual input, the proprioceptional input and vestibular input, which involves the labyrinths. So the equilibrium is maintained by a balance between all these three: visual inputs, proprioceptional input, and vestibular input. So dizziness is a very common generic term which describes a variety of experiences, including giddiness, lightheadedness, vertigo, faintness, and all these things. And it is a very important third most common complaint among all outpatients, and 10 to 15% of all ENT clinic attendants, and most common complaint among patients of more than 75 years of age. Among these, vertigo itself accounts for more than 50% of cases of dizziness. So it's a complex neurological symptom reflecting a perturbation of normal balance, perception, and spatial orientation. But very importantly, the quality of symptoms approach suggests that dizziness should be classified as one of the four types based on the nature of the dizziness. It can be vertigo itself. It's a proper vertigo which I'm going to discuss, or it can be pre-syncope, it can be disequilibrium, or even non-specific dizziness. And the case distribution among all these causes of dizziness, vertigo accounts for more than 50% of the cases, and the other three comes later. So true vertigo is spinning or rotatory sensation which is aggravated by head movement. Root cause is the vestibular system. It can be the peripheral vertigo or the central vertigo. Second point is faintness. Patients come with a low blood pressure or orthostatic hypotension, and that is faintness, which can be a part of dizziness, but it's not proper vertigo. Imbalance is the third type, which is a sensation of falling or losing balance. The cause are usually neurological disorders, and it mandates careful neurological examination. And imbalance is another form of dizziness, and it can be sometimes misinterpreted as vertigo. And the fourth one is the psychogenic variety. It vaguely described as lightheadedness. Mild form of type 1, type 2, and type 3 may appear as type 4. So ruling out the earlier types is very important. So what are the common causes of dizziness? Psychogenic, usually the patient might present with hyperventilation syndrome with respiratory alkalosis. Imbalance, like Parkinson's disease or peripheral neuropathy. Faintness, that is mentioned as orthostatic hypotension, can be a very common cause of faintness. But most importantly, the true vertigo is represented by either benign paroxysmal vertigo, Meniere's disease, vestibular neuronitis, migraine. Vestibular migraine can be a very common cause of vertigo, and certain CNS causes like strokes, multiple sclerosis, and tumors. So is it dizziness or vertigo? We have to rule it out. If the room is spinning around, vertigo it can be, but the patient is unsteady. The unsteady feeling can be because of disequilibrium. If the patient is about to faint, then it is called presyncope, and there are certain non-specific causes. Other reasons are anemia, hypoglycemia, medications, anxiety, and sudden drop in blood pressure. Vertigo itself is a sense of movement of the environment or self. It's a Latin word vertere, which means whirling or to turn. So it's a false sense that the body or the environment is moving, usually spinning, and suggests a disturbance of the vestibular system. A feeling of movement, a sensation as if the external world were revolving around the patient, which is called objective vertigo, or as if he himself were revolving in space, that is subjective vertigo. So in short epidemiology, the lifetime prevalence in adults is around 7.4%, and female preponderance is there with vertigo, and 3 times it is more frequent in the elderly compared to the young. So what's its impact? It's very impactful, so we're discussing today. Otherwise, it wouldn't have been a topic assigned to me. Recurrence in 88% of affected patients. It affects the daily lives in about 80% of persons. It reduces the quality of life. Psychiatric problems are involved. It leads to sick leaves and frequent medical consultations. And very importantly, in our geriatric population, in our day-to-day practice, it leads to falls in the elderly with its multiple consequences. The types of vertigo are mainly peripheral and central. There are certain other causes also. So how do we differentiate between peripheral and central vertigo? Peripheral vertigo is something which involves a structure which is not part of the CNS, and it is most frequently in the inner ear. Central causes is due to involving of the structures in the cerebrum, cerebellum, or brainstem. So you can differentiate by these certain points. If there are hallucinations of movement, if the onset is paroxysmal, if the intensity is severe, if the duration is from seconds to hours, and if it is induced by change in head position, if nystagmus is present, then all these more importantly it points to peripheral vertigo. But very importantly, if the tinnitus and hearing loss are also present, then definitely it's more pointing towards peripheral. But if there is disturbance of consciousness and other neurological signs are present, it points to central vertigo. So these are the common causes, as I mentioned. Most commonly BPPV, vestibular neuritis, Meniere's disease, vestibular schwannoma, bilateral vestibulopathy are very common for peripheral vertigo. For commonly, the causes for central vertigo are vascular diseases, tumors, epilepsy, multiple sclerosis, infections, and certain medications. So peripheral vertigo is important because this is commonly encountered in our clinical practice. This arises from abnormalities in the vestibular end organs, which are semicircular canals and utricles in the ear. the vestibular nerve, and the vestibular nuclei. But very importantly, this is very common, but usually they are benign and readily treatable. The common causes of vertigo involve all these causes as I mentioned in my last slide. Similarly, for central vertigo, it is an involvement of the brain, especially the cerebellum, and it exhibits more serious consequences and aggressive treatment is recommended. So this is the very important because here the treatment is very important and we have to pick up the difference early. The most common causes are cerebellar hemorrhage, brainstem ischemia, and vertebrobasilar insufficiency. Other types are cervical vertigo, the drug-induced ones like tricyclic antidepressant, anticonvulsant, or anti-Alzheimer's usage, and psychological vertigo, which involves mood, anxiety, personality, and alcohol abuse. So, how to assess on the basis of associated symptoms? We have to ask and look for ear symptoms like hearing loss, discharge, tinnitus, neurological symptoms like visual disturbance, headache, dysarthria, paresthesia, muscle weakness, or ataxia, and autonomic symptoms like nausea, vomiting, sweating, or palpitations. Symptoms suggesting a migraine aura is also very important. So there are various symptoms as is mentioned in this slide. I'm not going into the details. And hearing loss and tinnitus focuses more on Meniere's disease and all. But both in peripheral and central vertigo, nystagmus is very important. And tinnitus is very common in acute labyrinthitis, Meniere's disease, and acoustic neuroma. So the most important diagnostic tool in vertigo is not very important investigations. Here the investigations come later. History unlocks mystery. So history taking can guide in diagnosis in most of the patients. And when was the patient perfectly well, describing the first attack, whether the symptom is rotatory or there is unsteadiness, whether it is constant or intermittent, the time interval, the severity, and the accompanying symptoms as I discussed in my last slide. So history of recent upper respiratory infection or ear infection may lead to symptoms can be due to vestibular neuronitis or labyrinthitis. If there is direct trauma to the ear, there can be a perilimb fistula and so on. History of migraine or Meniere's disease may increase the likelihood of vertigo. If there is acute intoxication with alcohol and medications like aminoglycosides, furosemide, antidepressant, antipsychotics, and anticonvulsants are related to it. So the questions can be, do you become dizzy just rolling over in bed? It is usually common in benign paroxysmal positional vertigo. Are you light sensitive during your dizzy spell? It can be vestibular migraine. Does one ear feels full before or during an attack? It can be Meniere's disease. Does a loud sound make you dizzy or make your word jiggle? It can be superior semicircular canal dehiscence. So did your first attack of vertigo last hours with nausea, vomiting? It can be vestibular neuritis. Are you lightheaded when you get up from a bed or chair for a few seconds? It can be postural hypotension due to cardiovascular diseases. And do you pass out completely with your dizziness? It can be due to definite cardiovascular diseases. Similarly, the assessment on duration, like on the basis of duration, if it is episodic, it happens in seconds, it can be BPPV or vertebrobasilar insufficiency. If it takes hours, it can be Meniere's disease. For prolonged ones, it can be vestibular neuronitis, head injury, vascular lesions, or if there is any cerebropontine angle lesions along with metastatic deposits, it can be prolonged from weeks to months. So single episode of prolonged vertigo can be due to vestibular neuronitis, acute brainstem or cerebellar lesion, and first attack of migrainous vertigo. So what are the causes of recurrent vertigo? Usually migrainous vertigo, Meniere's disease, vertebrobasilar TIAs, vestibular paroxysmia, and perilymphatic fistula are the important causes of recurrent vertigo. So to diagnose, the history, as I said, is most important. We don't need very much investigations, but in certain cases, if there are dangerous mimics like TIAs, the cardiac arrhythmias, toxic exposure, brainstem, cerebellar or labyrinthine strokes, vestibular neuritis, Ornick syndrome, brainstem encephalitis, these are very important dangerous mimics and we should not miss them out. And here the investigations come into the picture. Usually we have to look into the ear, the eyes for nystagmus, slight neurological examination in our clinic, and combination of 3 bedside accumulator tests and more sensitive than early MRI even. Impulse normal or fast phase alternating or refixation on covered tests, these are certain tests we can do in our clinical practice. Rombox test is commonly done, and it is primarily for somatosensory function and proprioception. Dix-Helpic maneuver is very commonly done for diagnosing the different forms of benign paroxysmal vertigo. Head impulse test and Unterberger test are also some commonly done tests in our clinical settings. So how to differentiate clinically? Usually regarding nystagmus, the first phase is away from the lesion and it never reverses the direction. This is for peripheral vertigo. For central, it sometimes reverses the direction if the patient is looking in the direction of the slow phase. Postural instability, other neurological signs are very important. And if deafness or tinnitus is present, peripheral vertigo is common. So the primary care investigations, no investigation is needed in the primary care setup unless there are certain red flag signs. Then for secondary care investigations, when you need to refer our patients, they may need audiometry, they may need CT or MRI if there are some symptoms and signs of neurological involvement, EEG for epilepsy, lumbar puncture for certain cases, and serology for syphilis. Now my final part of lecture is regarding the management. Diagnose the cause, not merely suppress the symptoms. We should try to restore normalcy to the deranged balance function by promoting vestibular compensation through physical therapy. Improve the neuronal metabolism, cognition, and correct any concomitant psychological disorder. We should try to provide symptomatic relief with anti-vertigo and anti-emetic drugs. So the treatment aims and options are regarding, it involves drug therapy, cognitive behavioral therapy, physical therapy, and definitely in certain cases, we can need surgical therapy also. There are certain beneficial exercises which we can show it to our patients in our clinic, and ultimately they can get it done in their home. The eye exercises, the head and neck exercises, we can give them leaflets also. Exercise in sitting position, exercise in standing position, and exercises while moving. So pharmacological agents like vestibular suppressants, which involve anticholinergic, antihistaminics, and benzodiazepines can be used. Antiemetics, dopamine receptor antagonist, calcium channel antagonist can be done. Among the antihistaminics, promethazine and meclizine are commonly used. Among histamine analogs, beta-histine is there. Among calcium antagonists, cinnarizine is very commonly used. And among antiemetics, prochlorperazine and metoclopramide and dimenhydrinate are commonly being used. So we have various classes of drugs, and in certain diseases like Meniere's syndrome, we need diuretics along with the other medications for vertigo itself. Migraine, we know we have to use beta blockers, calcium channel blockers, tricyclic antidepressants also. For vertebrobasilar insufficiency, aspirin is very important because antiplatelet drugs prevents the progression of the disease. So, and there are certain molecules, as I mentioned, and the drugs dosage are given in this chart. Regarding prochlorperazine, it is a anti-muscarinic and anti-dopaminergic effect. Contraindications are very important. Side effects are very less. Muscle stiffness, flu-like symptoms, and sometimes there can be extrapyramidal symptoms if used for a prolonged period. Regarding beta-histine, it is very commonly used. It is contraindicated in bronchial asthma, peptic ulcer, pheochromocytoma. The side effects are mild to moderate nausea, dry mouth, dyspepsia. So there are certain roles coming up for the combination of cinnarizine and dimenhydrinate. Cinnarizine is a calcium antagonist which acts on the labyrinth and it improves the cerebral circulation. While dimenhydrinate is an anticholinergic and antihistaminic, it acts on the centrally acting mechanism, regulatory effect on vestibular nuclei, and affects the related vegetative centers in the brainstem. So with its anti-vertiginous and anti-emetic property, when we are encountering a patient for the first time with high severity, we can use a combination until and unless the final diagnosis is done. There are certain clinical evidences also for the combination. So we have various drugs to treat. Now the final part of my talk is on the urgency of referral. If there is severe nausea and vomiting and inability to tolerate oral fluids, then need to be admitted to the hospital. If there is very sudden onset of vertigo within seconds, that is not provoked by positional change, we need to consult a neurologist or an ENT specialist. If there are central neurological signs and symptoms, a new type of headache, usually occipital, gait disturbance, truncal ataxia, we should refer to a neurologist. Acute deafness needs to be treated by an ENT specialist. And for all other persons with vertigo of undetermined cause, refer to a balance specialist. So the treatment ladder of Meniere's disease is such, like it starts from reassurance, salt-restricted diet, diuretics, beta-histine, and finally there are various other modes of treatment in those who are severely affected. And most importantly, we should stress upon vestibular rehabilitation, and it should be started from day one. It is defined as a form of physical therapy recommended for vertigo, which uses specialized exercise to regain the gaze and gait stabilization. Singly or in combination with pharmacological treatment has proved useful for managing vestibular or central balance dysfunction. So vestibular neuronitis, gentamicin toxicity, Meniere's disease, perilymphatic fistula, BPPV are all indications for vestibular rehabilitation exercises. So we should take care of the cardiac red flags. The vascular vertigo, when blood supply through the body is reduced, it can cause vertigo and dizziness. And if there is history of high blood pressure, heart attacks or strokes, arteriosclerosis is very important. History of angina and arrhythmia is very important. And dizziness from primary cardiovascular disease may often be an important cause of dizziness and which can be confused with vertigo. So if the history of sudden onset, new severe headache with history of cardiovascular risk factors, these are red flags. If the nystagmus is not so simple, if it is direction changing, if it is purely vertical or torsional, and it is unsuppressed by visual fixation, we should think of red flags and inability to walk, negative head thrust test, and certain neurological signs of aphasia, dysarthria, weakness, sensory loss are very important. They can be central cause of vertigo. For vestibular migraine, we have to treat with anti-migraine therapy. There are certain investigations which can be done like pure tone audiometry. And there are certain diagnostic tests for vestibular migraine because vestibular ocular reflex with head impulse test is very important. There are certain sophisticated investigations which is beyond our scope of discussion today in certain cases of vestibular migraine. The treatment is usually done with aspirin or NSAIDs, antiemetics, beta blockers, topiramate or valproic acid. And triptans or somatriptan are commonly used along with antiemetics like dimenhydrinate and vestibular suppressants like promethazine and meclizine. Propranolol is very commonly used for prophylactic treatment for vertigo and also for migrainous vertigo along with flunarizine and tricyclic antidepressants which we commonly use in our day-to-day practice. So we have to differentiate with Meniere's disease from vestibular migraine, and usually the hearing loss is very common with Meniere's disease. And similarly, for BPPV, usually the Dix-Salpinx test is very normal in vestibular migraine, but it is commonly positive with BPPV, and it has earlier onset in life, and positional nystagmus is persistent in these cases. Regarding basilar migraine also, there can be at least 2 posterior circulation symptoms lasting 5 to 60 minutes, immediately followed by migraine. And it can involve ataxia, paresthesia, and dysarthria for basilar migraine. There are certain exercises which we can prescribe to our patients, and surgery is not a routine procedure. This is considered only in following cases like unilateral Meniere's disease not responding to conventional medical treatment, if there is refractory Meniere's disease, acoustic neuroma where the tumor needs to be removed, purulent labyrinthitis from chronic suppurative otitis media, surgical correction of a superior semicircular canal dehiscence, perilymphatic fistula, and in recurrent BPPV that is not responding to the liberatory maneuvers. There are certain instances of nowadays vestibular implants done by ENT surgeons. So the red flags are very important. The patient comes with dizziness. We have to know whether it is a pseudo vertigo like spree syncope, disequilibrium, or lightheadedness, as I discussed in my first few slides. If there is rotatory vertigo, we have to rule out the red flags first and then go on as our normal pathway to treat vertigo. So to conclude, defining the dizziness is most important. The nature, the duration, and frequency. Time spent in history taking is worth, often leading to clinical diagnosis. It is important to recognize the red flags for urgent referral, thus decide between true vertigo and pseudo vertigo. And when we know that it's a vertigo, we have to decide between whether it is a peripheral or central vertigo. And as we all know, peripheral causes are very common. Central causes are not too many, but needs urgent recognition as they have different treatment and prognosis. Thank you all for your patient hearing, and I conclude my talk here.
Thank you, Dr. Sen.
Thank you,
Very
sir.
nice presentation. Probably it will help a lot of our physicians, you see, as far as the diagnosis of vertigo is concerned. And I think, again, you see, to diagnose vertigo, probably history taking, I think, is the most important. And the time period, as you mentioned, you see, whether it's a paroxysmal or it's a vestibular, you see, because the treatment depends upon, you see, once you make the diagnosis, what is the real cause of vertigo.
Yes, sir.
That's.
Thank you, sir.
Any question from the audience, please?
Okay. Thank you all.
Our next guest lecturer is Dr. Poonam Bharti, MD Psychiatry or Professor, Department of Psychiatry, MMI MSR, Maulana Ambala, who will be presenting on the topic Child Psychiatry in India, an overview.
Good afternoon, everyone. And I welcome you all on this MAPICON 2022. And I pay my gratitude and special thanks to Dr. Vital Gupta, who has given me an opportunity to be with you and to present on child psychiatry. So I am a professor in psychiatry in Maulana University. So here is the topic, Common Child Psychiatric Disorders, the Indian Scenario. In my outline of my presentation, there will be an introduction, classification, and I will be taking up few case-based discussions along with the how to assess the child in with the psychiatric disorders, and mainly the certification and the POSCO Act. So now talking about the statistical data, if we take out, it's 6.46%, there is a prevalence of child and adolescent psychiatric disorders. In worldwide, it is 10% of the children, they suffer from the psychiatric disorder. And the dropouts, if we say, it's a 50% of the school children, they have a dropout because of the mental illness. If we talk about, there is a 70% even the children who, because of the mental illness, they are not getting the proper intervention at the proper time, and the delay is around 8 to 10 years. If we talk about few of the psychiatric disorders, 11% of the children, they suffer from mood disorder, and 10% from conduct disorder, and 8% anxiety disorders. Suicide is the third most leading cause of death among adolescents. And 90% of the cases who commit the suicide, in them, they have the underlying mental illness. Now, very briefly, I will be going through the classification. According to the ICD-10 criteria, they are classified from F70 to F99. In 70s, we classify the mental retardation. 80s to 89, we have the psychological developmental disorders. And 90 to 98, we have behavioral and emotional problems. Whenever there are children who present in the clinics, they have the conduct disorder or ADHD or autism. So they come under behavioral and emotional disturbances. Now with an example, I would like to make sure that you understand how when a child presents to a clinic, basically the behavior the child represents with, what is the underlying cause? Supposedly a child of 12 years old boy, it presented in the clinic with a history that he is very cranky, very irritable and fights on a very small issues. The reason was when the history was taken and examination was done, it was found that he was overweight and he was bullied for this reason by the schoolmates. So he used to become aggressive and irritable to stop everyone from behaving like this. And eventually it became a behavior of a child. So with this, it's always an underlying situation which makes a child to behave in a certain manner. He was overweight, he experienced the bullying from the schoolmates, and he found a way of dealing with it, showing the aggression, and this became a learned behavior. Usually what happens, the parents, they bring this child with this behavior, he's very aggressive, he's very irritable, he fights on a small issues. So you have to find out the history and the details why the child is behaving like this. Usually there are factors which influence the child behavior. It depends upon the parent also and the child also. In the parents, what type of relationship they are sharing, what type of personality they have. And in the children, it is the temperament, the peer relationship, and the relationship with the family members. Very important is if there are warning signs. If there is a child, your child is facing some violence, it can be in any form, sexual, physical, or any violence. There is always a change in the child's behavior. It may be in any form, like a child is having a social withdrawal behavior. He's throwing the outbursts of violence. He's destroying some of the things. He's getting involved with the drugs, abuse, alcohol, or he may be destroying something or leading into the physical fights with the peer. Now in the brief, I will let you know according to the age group how the psychiatric disorders they are divided. I am categorizing in 3 groups from birth to 3 year, 3 year to 10 year, and 10 year to 18 or above. So in birth to 3 years, mainly what happened, there are 3 disorders which we must rule out: the cognitive disorder, autism, and reactive detachment. Why these 3? Because there is a milestone developmental issue and deficit is there during this time. So the cognitive disorders are more during this year. If I talk about 3 to 10 years, more of the anxiety, because the child starts going to school. There is a social phobia, separation anxiety, and learning deficits or disabilities are there. Now from 10 years to 18 years, more of the conduct disorder, personality starts framing from a temperament to personality. So emerging personality disorders are there, and even the child can get involved in the substance use too. This is basically, we always go through the delayed milestones, so I think everybody is well aware of this. Now, a little bit a pass by about the various psychiatric disorders which are very much commonly seen in the children. Autism. If I talk about 1% of the child and adolescents, they are suffering from this. Male to female ratio is 4:1. Basically here there are 2 main symptoms which you must know is that the social communication with the other peer groups or anyone is defective, as well as there is restricted and repetitive movements. Second most common is any child who is a little bit hyperactive or doesn't sit at one place. You always label the child as ADHD. So it is in ADHD, three main symptoms are there: hyperactivity, impulsivity, and inattention. Conduct disorder. How you have to differentiate the autism, ADHD, and conduct is, in conduct, basically there is a violation of rules. The rules, the society norms are there, you violate those things. Then is affective disorder and post-traumatic. So mainly in the children, we have autism, we have ADHD, what happens in children, usually we forget to find out the affective mood symptoms also. We usually don't, in adults only, we feel that the child cannot suffer from depression. There are many cases where the child can also suffer from depression also. This slide is specially made by my child. He is in 5th standard. He told me, Mom, you should also reflect something that because of mobile use, the children are, there is an effect on their mental illness. So he reported me that there are children who have the traits of ADHD, they use more of the mobiles. Depression is also very common among children. It is not only that this disorder is of adulthood. Warning signs for suicide. As in the last lecture, we had gone through stress management and stress. There also we had seen that there is a warning sign for the suicide also. You had gone through and you see that children in 1st standard, 4th standard, they all come with the complaint, आज मुझे बहुत stress हो रहा है, मुझे बहुत tension हो रही है, चाहे वो exams की है. Even elderly people or adulthood, we are ready to accept this feeling. But if the children come and report you, you always says, don't worry, you go and play. ऐसा क्या होता है? कोई tension नहीं होती. But there are warning signs for suicide among the children also. So that must not be ignored. Warning signs, you must talk to the child regarding what the child is feeling. The behavior of a child must also be taken in consideration. And the mood of the child, it must be, if it is he is depressed or anxious, you must take care. Anxiety disorders. Why the anxiety disorders are also very common among the children is because there is a separation anxiety. When they go to schools, they don't want to, and the primary caregiver, if they are detached from them, they feel alone, they feel separation anxiety. So anxiety disorders are also very common. Separation anxiety is when the child feels anxious, or anxiety disorder when he or she is being detached from the primary caregiver. Mainly when the child starts going to school. At that time, when they are living at this home and immediately they have to go to school, they feel they are being detached from their primary caregiver. At that time, the child can have a separation anxiety. Post-traumatic stress disorder also. Sometimes they are they go through some kind of violence or abuse. And after that, they can have the symptoms of post-traumatic stress also. Now, schizophrenia. This is being taken up only that though it starts at the adult age, or you can say in teens. But schizophrenia, here also they can present with abnormal audible hearing voices, hallucinations and delusions are also present. But how you can differentiate the adult schizophrenia from the childhood is there will be developmental problems also. The child may have a decline in their academic performance too. Now there are 11 interesting cases which I will be discussing, and I would want that from audience they can make a diagnosis, and they are very simple. Whatever I had discussed till now, the cases are based on those symptoms only. So maybe you will also be able to recognize the patients in your own clinic. Now my first case is a 7-year-old boy. He was suffering from epilepsy and he was on sodium valproate. He had a limited language skills, self-stimulatory behavior was there, fine motor skills were poor. He had a poor eye contact, important line. He used to line up his toys, used to get irritable on very, very small issues. He was a very fussy eater. Can anybody help me to make a diagnosis? There is a one movie also based on these things only. Very good. Good. Great, sir. It's a diagnosis is autism. Now my second case is Siba, 6-year-old girl. She was living with the mother and the stepfather brought her to the clinic. What happened? The parents at the age of 2 years, they got divorced and the custody of the child was given to the stepfather. She lived in a very chaotic environment but her language, cognitive, social development was delayed. On examination, there was an articulation language deficit was also seen. There was a mild mental retardation was seen on examination, and she was very extremely impulsive. What happened? After 2 years, she rejoined her mother, and the things got improved. Improved verbal skill was seen. Now, can you make a diagnosis? She was separated from the mother and she was living in a chaotic environment with the stepfather, and later on she rejoined. The things which were declining started improving. Good, sir. I think you need a chocolate. It's a reactive detachment. Basically, it was a kind of a reaction the child was showing detached from the attached figure. So because of the detachment, there was a reaction shown by the child. Next, case 3, 11-year-old girl, not speaking at the school. She was a twin birth. She spoke well within the family. She was a fussy eater with a minimal peer interaction in the school. Though she was a very affectionate child and was good in the studies too, but she was a little shy during interview and was clinging to the mother. Often she was very irritable and used to cry. Can anybody make a diagnosis? Not speaking at the school, spoke well within the family, minimal peer interaction. She was good in the school, academics. She was affectionate, used to be clinging to the mother, and little shy at the time of interview. Anyone? This was a case of a selective mutism. She was not speaking at the school or in the social situations, but she was well within the family. So it was a kind of a selective situation where she was comfortable enough. Selective mutism is when the persistent failure to speak in a specific social situations, when you are not able to express yourself in a social situations, but you are comfortable enough within your comfort environment, right? Another case, Daisy, 12-year-old girl, not spoken audibly outside her home. She used to talk to her parents and twin brother at home in audible voice. She used to avoid group activities. In school, she used to stand alone at recess. There was no history of school refusal. She used to love to go to school. And on the family history, it was found that her father was also a little shy and introvert. She was assessed by a psychiatrist. Can anybody now make a diagnosis? With these points, usually the parents come and visible? It's great, sir. It's again a case of a selective mutism with the social anxiety. Again, the child was comfortable at home, but not with the group activities. Next is Jack, 7-year-old. in class 1. He never used to sit at one position, keep fidgeting, squaring in the seat. His reading and writing skills were age appropriate, but teacher used to give a remark that he's a bright boy, but he can still improve. In a picture you can see, it can help you out. He usually forgets his pencils and everything, erasers at the school. And whenever a conversation is going on, he used to overly talkative, interrupt that conversation. I think you can make a diagnosis. Yes, sir. Great. So it's a case of ADHD where the child is suffering from hyperactivity and impulsivity. Case 6 is Samina, 9 years old girl. She was found to be positive for neurofibromatosis 1. There was a great genetic loading, huge in their family history, as the father and grandfather was suffering from neurofibromatosis. She was always found to be daydreaming, hyperactive, and there was a significant writing problems were seen. Like this, it's a combination, like a child can also go to neurologist also, physician also, and even there can be some issues in pediatrician also, drop in the academic performance, or because of this, they even land to a psychiatrist. But on the IQ testing, it was 104. But on ADHD rating scale, it was highly impulsive, inattentive was seen. So a question comes, you're dealing with adolescent issue, depression, dyslexia, or ADHD. A child is suffering from major neurofibromatosis, and in a neurofibromatosis, basically these were the behavioral changes secondary to the general medical condition. So the child had the learning disability and significant writing issues. Now a 10-year-old child, now age of the child is 10 years, and he presented from, otherwise he was going well, but from last 3 weeks, he had been more isolative, severe headaches were complained, more of the somatic complaints were there, and he used to complain one thing, that everyone in the family is going to die. He used to report this thing. And further, there was uncontrolled crying and screaming of a child was also seen. Now the main complaints were frequent somatic complaints, stomachache, headache, unexplained irritability, crying, shouting, anhedonia, isolation, and the fear of death of the family. A child was just reporting these symptoms from last 3 weeks. Can anybody help me out to make a diagnosis? A 10-year-old child. These are the symptoms with which the child present to the clinic. So basically, why I took this case was, usually we always feel depression can only be in adults. So this child was also suffering from depressive episode, and at the age of 10 years, we usually forget even, and we don't even pay attention that the child can also have a depressive episode. So he was suffering from this. Now a 9-year-old male, he was having defiance and emotional dysregulation. He kept on worrying on the small issues. Every small issue used to create a lot of anxiety in the child. He was feeling worrisome, anxious all the time for everything. Even a class test is there, even he has to go to a school, if he has to take a bath, then also he was anxious on every small issue. So there was always a feeling of restlessness, periods of worries, difficulty in concentrating, and irritability was there. Anyone? So it's a generalized anxiety disorder. Basically, the child was having a general anxiety towards each and every activity. So this thing is also very common. It's always, as a psychiatrist also, me also, and many more also, everybody feels depression, anxiety can only present in the adult, in the 20s or something, when there is some significant stressor also. But it is not, because the etiological factor are, there are n number of etiological factors, and the child can also present with depression and anxiety, right? I think, sir, my answers are visible. Okay. So, 12-year-old boy, he presented with the repetitive movements, and he had this repetitive images that of blood-soaked persons. He was suffering from these images, and this was quite distressing to him. These were irrational, absurd. He used to try to stop them by chanting or something, but it was uncontrollable. Repetitive behaviors were there of these unpleasant images. Because of these issues, his scholastic or academic performance declined, and he was not able to concentrate well. I think my answer is again clear. Can anybody tell me? Because of repetitive images and all those things, they were irrational. He was not having any control. Again, the child was suffering from obsessive compulsive disorder. Now, in case 10, again, here, what I am telling is the child was suffering from type 1 diabetes mellitus. She was taking insulin each day, and she used to have a suicidal ideation because of this, because she was tired of taking insulin, taking in consideration about all, irritable all the times. So again here, it's a diagnosis is depression secondary to the medical illness. As I talked about the neurofibromatosis, there can be other medical illness also which can lead to depression in the children. My last case is 11-year-old boy. He was from rural background, class 3. After that, he dropped out from the school. He used to adopt in abnormal postures. Whenever he was standing, sitting, abnormal postures were noticed by the family member. He had lack of friends at the school even, but there was no history of any low mood. What he used to do is, he used to accept the food from his mother only. No other family member can ask him anything to eat something. He used to only accept something from the mother only. He used to repetitively wash his hands up to 10 to 20 times each time. And he was always irritable. He was forced to take a bath, trim his nails, and groom him. So he was always, there was a smiling out of context, fixed gaze was there, and refusal to take food from anyone. Anyone? Meghna? Yes, I think psychiatrists can make out. Basically, the child was suffering from some psychotic illness. It was a schizophrenia. He was making abnormal postures. He was having a delusion that other people can give something to him in his food. So he used to only accept food from his mother only. And he was not groomed well. He never used to take a bath and everything. So he was suffering. And mainly when the schizophrenia starts in early childhood, they have 10 to 20% of the children, they present and they start with having obsessive compulsive traits, repetitive hand washing or something like that. Now, with the case-based discussions, we have understood what type of psychiatric disorders usually we come across. Now, how to assess the child? When a child presents in your clinic, you can make the assessment in 3 ways. The 3 ways are developmental assessment, about the development of a child, psychological assessment, and intelligence question. So in this table only, I will try to cover the all complete assessment. In developmental assessment, basically the milestones, they are well taken up by the pediatricians. The milestone, there is any kind of delay in the milestones, it is taken up. Emergent literacy, again, scholastic skills are disturbed. So they are taken up in the emergent. In psychological development, as I am a psychiatrist, I will be taking more, concentrating on the psychological development. This is by 3 psychoanalysts, Sigmund Freud, Erik Erikson, and Jean Piaget. So basically, the Sigmund Freud, he gave the psychosexual developmental stages. These are the 5 stages in which the child development is there. If there is a proper resolution of all the stages, then only the child will be having a proper development. If there is a fixation in any of the stage, the child may have a psychological deficit or any kind of psychiatric illness in the later life. Second is Eric Erikson. He gave this model on the basis of psycho-social development of a child. With the first example, I will try to explain you. Rest, you can have my PPTs. In this, there is a trust and mistrust feeling when the child is up till 1 year of age. A child is always having a trust. The primary caregiver is the mother, basically. If a child is having a strong bond with the mother, the child will develop a trustworthy feeling. If the primary caregiver, mother is not there, so he will develop a mistrust feeling. So how the psychiatric disorders they develop from the early childhood is because of these psychosocial crises. If there is a balance between a trust and mistrust feeling, there will be a hope. Positive will be, a hope will be there. And a child will never have any anxiety disorder or depressive disorders. Otherwise, if the mistrust feeling is more seen than the trustworthy feeling, a child may develop a substance abuse, may develop a depression, anxiety in the future life. Similarly, Jean Piaget gave this model on the psychocognitive, the cognitive level, how the cognition of a child develops through the various stages. Now in the assessment part, I will be just taking one main important. These are one of the example, it's a Raven progressive matrix. Here what happens, this is a display of one of the, I can say a subtype of the test, that we ask a child, this block will be filled with which of the following figures shown beneath. So the child will pick up according to the mental age. This is also a Seguin form board test. This board, we empty the board and we ask the child to place all these items properly on the board, and this is basically to assess the visual and motor skills of a child. The most important is the Mallin's intelligence scale for the children. Indian version is there. We have a subtype. We have 11 subtypes, out of which we have verbal and performance test. I will show you the most important. So basically the Wechsler intelligence test and the Mallin's test, there are a verbal and the performance test, where the child, if a child is having, suppose, hearing disability, a child is not able to perceive what you are saying, a child can do well with the performance tests. And the verbal test can be taken up accordingly. You can ask the arithmetic, digit span, vocabulary of a child, similarity between. So all these things will help in assessing the child. The most important Indian version is the Bhatia battery performance test. This was given by CM Bhatia in 1955. Here this test is not to find out the mental retardation. This is just a test to measure the intelligence in less educated and illiterate Indians. This is not used for the mental retardation. Now coming the further, my second last section is the management part. Basically, when the child comes with so many symptoms, it is not that we can improve the developmental deficits. What best can be done is, after taking the history and examination of a child, is that we can just help in improving the few of the symptoms. If a child is having aggression, self-harm, irritability, we can start with the various medications which are available according to the diagnosis and the rating scales. Now the goal in the managing such patient is to encourage the independent living, decrease the problematic behavior. More of the parent, mainly what happened, we have to counsel and psychoeducate the parents for regarding the disorder, the problem solving and the treating the comorbidities. These are the last my few important slides. Supposedly, if a child comes with a disability and you are asked to certify or give a certificate of the disability, what is available in India is the ideas. It is the Indian Disability Evaluation and Assessment Scale. This came in existence on 18 February 2002, where the ideas was taken having the 4 parameters. One is the self-care the patient is doing, interpersonal activities, communication, and work, social domestic work. So on these 4 parameters, we grade a child from 0 to 4 and assess the global disability score. We get this score as total disability score into duration of illness. And this must not be given by any medical practitioner not below the rank of civil surgeon. This is a pattern how this certificate is issued. Basically, the disability certificate in children is very important, and you are asked to, whenever the certificate of disability is given. POSCO Act is very important. It came in existence in 2012. This was a protection of the children against the sexual offenses. This was passed by both the Houses of Parliament, and on Children's Day, 14th November 2012, this came in existence. The most important features of POSCO Act was that it is a gender neutral. Number 2, investigating officers must not be wearing any dress, they must be in a plain clothes. When you are examining or assessing the child, he must be accompanied with a trustworthy person, number 1, and second, a female doctor. So these are the most important. There are few points where you have to refer a child to a psychiatrist. Number 1, if there is a threat to a child and to the caregiver. Number 2, if the primary caregiver is suffering from some kind of psychiatric issue, or there is a hallucinatory behavior or suffering from the psychotic illness. The last is, if a child is being given with the psychiatric medication, suppose a child is suffering from depression and you are putting a child on the stimulants, and it is seen that a child may be having a schizophrenia or manic symptoms, then there is a referral is required. My last slide is about facts and myths. Sometimes it is called taking a child to a therapist is just a waste of time. So it's not like this, though family support helps in recovering a child, but getting a perfect and expert opinion is must. Number 2, child don't go through any kind of mental health issues. It is not. I reported a child can suffer from suicidal ideation, depression also, schizophrenia also, OCD also. So they are having a mental health issues. Then a child with a psychiatric disorder is a damage for a life. It is not like this. He or she might be struggling very hard to cope up with the anxiety or depressive symptom. Then psychiatric disorders are result from the bad parenting. It is not that the bad parenting is the solely cause of a psychiatric issues among children. It can be one of the reason, as environmental factors are affecting the child's behavior. So it can be one of the reason. It can't be the only this criteria that the bad parenting is, a psychiatric disorder is because of bad parenting. So I want to ask, in Tare Zameen Par, what was the disorder which was shown in this movie? Anyone? Autism? Any other? In Tare Zameen Par. Anyone? There will be a special gift. Now my last 3 slides are my questions only. Have you Googled up? That's great then. He was suffering from dyslexia. He was having a scholastic skill issues. My name is Khan. Autism or? Be confident. I got a prompt, but answer is right. Who spoke up? Yes, sir. Great. You are a psychiatrist also now. Asperger's syndrome. He was suffering from Asperger. Last slide, my Burfi. Anyone? Which disorder was shown in this movie? Sir, be confident. You can. You are almost. You had given lot of answers. You need a special gift, sir. I think. So, thank you. Any questions regarding the child psychiatry disorders? Thank you.
फिल्मां तैयार है ना अपनियां चारों वीडियो लास्ट So if there are no questions, I think 2 psychiatry lectures have got the greatest applaud. Dr. Ravichand Sharma as well as Dr. Poonam Parthi.
Thank you. Thank you. Any questions?
So that means there is a hidden, psychiatric problems which people want to learn and applaud psychiatrists, but they don't like to go to psychiatrists.
No, sir. I think there are a lot many patients, they present in my clinic, and they comfortably come and discuss their problems even. I think that it's an approach of a psychiatrist also, like how to deal with their patients also, students also, and anyone around us. Though Dr. P.D. Bansal gave a good lecture on the stress, there is a eustress also I wanted to explain. Eustress always gives you a positive energy, an opportunity to work more in your life. Stress is I think it's a kind of a wave. It's like we all have a stress, but how we take it, how we take that opportunity to work upon this. And similarly, the psychiatric illness, they are very common among every one of us. It is not that you are suffering from some disorders. There can be some symptoms which can be recovered and can be evaluated soon and can be better tackled in the early stages. Yes, sir. Thank you.
Thank you, ma'am, for an excellent talk. Now we are going to start our formal felicitation ceremony, which is to highlight and honor our promoters, our organizing committee, as well as the volunteers who are backbone of this function. For that, I invite Professor Dr. D.K. Singh, Director AIMS, on the stage, and I request our organizing committee members to please escort them. And most important person for this conference, Dr. Janakraj Singla, observer from Punjab Medical Council. I request him on stage. Dr. Usha Goyal, 2-in-1 guest, our special guest, as well as from representative from Civil Surgeon's Office because of pulse polio. Dr. Tejwant couldn't make it. And Mr. Anil Pola, who is delegate Punjab Pradesh Congress Committee. So going on for this fact that this is non-political, this organization, and anyone who is supporting our academic activity is most welcome on the MAPICON platform. Thank you for gracing this occasion, and to start with our promoters, without whose help MAPICON may not be possible, and I invite team from Delhi Heart Center, headed by Dr. Naresh Goyal, to please come on stage. Dr. Rohit, गल्लां बाद च कर लियो यार, please सारे आ जाओ. Delhi Heart Center has been instrumental in providing us funds as well as speakers, and I request Dr. Rohit to please introduce members of their team.
Myself, Dr. Rohit Bansal. I am in charge of critical care, Delhi Heart Institute and cardiac anesthetics. Now I welcome Dr. Sonu.
So there will be one certificate and all the members are requested to shake hands and be there on stage for a group photo also. So I think it will be better if everyone is introducing themselves. Dr. Sonu, start with Dr. Rohit, I think. He is the team leader.
Hi, I'm Dr. Rohit Bansal, in charge critical care and cardiac anesthetics.
Hello everyone, I am Dr. Sonu Sharma, consultant cardiologist, Delhi Heart and Multi Speciality Hospital.
Dr. K.L. Bansal, I am looking after non-invasive part of cardiology.
Hello everyone, I am Dr. Varun Garg, consultant neurosurgeon, Delhi Heart Hospital.
I am Dr. Jagmohan Singh, cardiac surgeon, Delhi Heart Institute.
Good morning, I am Dr. Sapna Sisodia, working as consultant nephrologist at Delhi Heart Hospital.
Good afternoon, everyone. I'm Dr. Abhilasha Bhatia, working in the radiology department of the Delhi Heart Institute. Thank you.
Good afternoon, everybody. I am Dr. Ruby, consultant neurologist at Delhi Heart. Thank you.
Hi, everyone. I am Dr. Saurabh Bansal, consultant cardiologist, Delhi Heart.
Good afternoon, everyone. Myself, Dr. Rahul Bansal. I'm working as a consultant in critical care as well as anesthesia in Delhi Heart. Thank you.
Hello, everyone. I am Dr. Vijay Kumar, consultant general medicine.
I am Dr. Deepak Bajaj, consultant gastrosurgeon at Delhi Heart.
Good afternoon, everyone. I am Dr. Balraj, working in radiology department at Delhi Heart.
And see Dr. K.K. Bans, he is the backbone of all the medical activities there.
Actually, everybody is backbone of this hospital, and we are very much thankful to Dr. Vittal arranging so good function and giving us our...
So thank you very much. We can have a good photograph, group photograph of yours with our dignitaries. आजूगी यार सब्दी ਅੱਗੇ बैठना है young ਬੰਦੇ ਅੱਗੇ बैठ जाओ यार ਜਿਹੜੇ ਬੰਦੇ बैठ सकते हैं who are not, and that will be a test for osteoarthritis also. नहीं osteoarthritis ਦਾ ਪਤਾ ਲੱਗ ਜੂ ਨਾਲੇ. So please have a good. So we are really thankful to Delhi Heart Center for promoting as well as helping us for all the 9 years, including this year, and we expect more help. So maybe that is why we are getting the group photograph, and they will be enthusiastically participating in scientific session as well as in other financial help. So thank you very much, Delhi Heart Hospital team. Thank you so much. Next in our gratitude is Sardar Gurmeet Singh Ji Taliwal, Director of Baba Farid Group of Institutions. He is not there because of some engagements, but we are highly obliged for him, to him for providing us volunteers as well as all the logistical supports. Thank you, Dr. Taliwal. And next, the most familiar face of this conference is Mr. Ashwini Malhotra and Mrs. Ajo Madam Vinita Malhotra. Tu ki socha main bhul gaya. On stage. So he is here from 7 a.m. to 7 p.m. looking after each and every aspect. We are highly obliged and thankful to Mr. Ashwini as well as Mrs. Vinita. Next, I invite ਜਦੋਂ group photo ਕਰਨੀ ਹੋਵੇ ਹਿਲਾ ਦਿਆ ਕਰੋ. So next I invite Mr. Kunal Sharma and Mr. Gary on stage for all the technical support and help. Chala gaya Kunal? Aaja tu aaja. So you see his face, he is the technical brain behind all the web activity as well as live recordings and projections here. Kunal is here. So he has started new business of web thing in Dubai, so he is always busy on telephone conversation, and we are lucky to have him here now. Thank you, Kunal, for all the help. And next I announce Mr. Ajay Gupta, owner of JC Press, for all the printing materials, what he has provided us. He is not here for some reasons. And our pharma partners, starting from USV. Please come, USV team. And next in line is Torrent. Next in line is Torrent, Intas and TASMED. Please come near the stage. So USV has increased their contribution this time. We are highly obliged. And please convey to your head department that we want more next time. ठीक है भी करण? फोटो पे दी. Torrent. So thank you very much. And next is our TASMED team. Thank you for participating and giving beautiful gifts. And next I'll invite the backbone of this conference and whole activity, our volunteers from Baba Farid Group of Institution. So in task, please. मैं कहा किते हो गया यार. And Ranjinder is the most important person. Otherwise also, you tell him anything to do, he is always there to help promote MAPICON. I invite Mr. Jalal to come on stage. Khushbu. Stay here for a group photo. You can. Khushbu. Then is Ria. Rishabh. And Navjot. So Baba Farid Group of Institutions are providing us with volunteers for last 5 years. So they are very disciplined and you can judge from their performance. Every delegate have connection with them. So you can have a group photograph, good group photograph for your memories. बैठ जाओ अगे बेटा. And we are very fortunate to have AIMS Bathinda in Bathinda. And due to Pulse, which is very good and famous festival at Delhi, most of the students went there. So I am highly obliged to Professor Dr. D.K. Singh to giving us an opportunity to invite volunteers from AIMS. So I'll invite volunteers from AIMS, please come. Liza. Three volunteers have gone to Delhi yesterday, so they will be given certificates whenever they are available. Liza, Minakshi, Anshu, please line up. Ishan, Kashish, Vyakhya, Hargun, and Priyanshi. So after that, I'll invite the next group of Baba Farid group of institution volunteers, because they were manning the registration counter, to come near the stage quickly. Three people come this side, beta. बैठ जाओ आगे, बैठ जाओ, बैठ जाओ, बैठ जाओ. So next we invite second group of volunteers from Baba Farid Institution, Karan, Tamanna, Rupali, Ashna and Shivangi. Karan, Tamanna, Rupali, Ashna, and Shivangi. So thank you very much, volunteers, for an excellent job. And without organizing committee, I think the conference will not be possible. So I'll invite Dr. K.K. Noria, please, to come forward. Dr. Keval Krishan, Dr. Ashok Goyal, Keval Krishan है नहीं गा. Dr. M.R. Gupta, and most energetic person, Dr. Meghna Gupta. And our office secretary, Dr. Sonia Gupta. मैं तो आप पे ले लिया जी पहले ही. So thank you very much, sir. I request you to please take your seats at this, and we are going to display a few glimpses of our MAPICON TV, and after that, we are going to have a few words of wisdoms from our chief guest as well as guest of honors. Thank you very much. After that, we are going to have the vote of thanks. Thank you. Please display the videos. हैं? कौन? कौन? सर्टिफिकेट साइन होगा तो दमांगे।
डॉक्टर DK सिंह, डायरेक्टर एम्स बठिंडा, जो भारत सरकार का एक फ्लैगशिप प्रोजेक्ट है, उसके संचालन के लिए मैं यहाँ हूँ। मैं डॉक्टर वितुल गुप्ता को बधाई दे रहा हूँ। उन्होंने बहुत अच्छी चिकित्सा शिक्षा की एक सतत प्रक्रिया जो होती है उसको जारी रखने का प्रयास किया है और एक मालवा प्रांत के लिए एक अच्छी कॉन्फ्रेंस ऑर्गेनाइज की है। एम्स बठिंडा यहाँ बहुत तेज़ी से प्रगति कर रहा है। बठिंडा का लोकेशन भी ऐसा है कि यहाँ पर हमें उम्मीद है कि बहुत जल्द ही पंजाब का एक ये मेडिकल सेंटर, मेडिकल हब, चाहे वो प्राइवेट सेक्टर में हो चाहे वो गवर्नमेंट सेक्टर में हो, बनने जा रहा है। मैं आप सभी का स्वागत करना चाहूँगा एम्स बठिंडा के परिसर में।
मैं Dr. Janakras Singla, MD Medicine from Mansa. I have been deputed from Punjab Medical Council as an observer for this conference. I'll like to say कि ਜਿਹੜੀ ਇਸ ਤਰ੍ਹਾਂ ਦੀਆਂ ਕਾਨਫਰੰਸ ਸਾਡੇ ਬਠਿੰਡਾ ਵਰਗੇ ਇਲਾਕੇ ਸੁਣਦੀਆਂ ਨੇਗੀਆਂ, ਸਾਡੇ ਮੈਡੀਕਲ ਪ੍ਰੋਫੈਸ਼ਨ ਵਾਸਤੇ ਬਹੁਤ ਜ਼ਿਆਦਾ ਜਿਹੜੇ ਤਰੱਕੀ ਵਾਸਤੇ ਸਹਾਈ ਸਿੱਧ ਹੁੰਦੀਆਂ ਨੇਗੀਆਂ। ਇਹਨਾਂ ਦੇ ਵਿੱਚ ਜਿਹੜੇ 60 ਤੋਂ ਲੈ ਕੇ 70 ਲੈਕਚਰਸ ਹੁੰਦੇ ਆ, ਤਰ੍ਹਾਂ ਤਰ੍ਹਾਂ ਦੇ ਜਿਹੜੇ ਹੈਗੇ ਆ ਵੱਖਰੀਆਂ ਵੱਖਰੀਆਂ ਥਾਵਾਂ ਤੋਂ ਸਪੈਸ਼ਲਿਸਟ ਡਾਕਟਰ ਜਿਹੜੇ ਹੈਗੇ ਆ ਏਮਸ ਵਗੈਰਾ ਤੋਂ ਵੀ ਤੇ ਹੋਰ ਚੰਗੀਆਂ ਰਿਪਿਊਟਡ ਇੰਸਟੀਟਿਊਸ਼ਨ ਤੋਂ ਲੈਕਚਰ ਦੇਣ ਲਈ ਆਉਂਦੇ ਆ। ਤਾਂ ਸਾਡੇ ਮਾਲਵੇ ਦੇ ਜਿਹੜੇ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਹੈ ਉਹ ਸਾਰੇ ਉਹਨਾਂ ਦੀਆਂ ਗੱਲਾਂ ਬਾਤਾਂ ਸੁਣ ਕੇ ਬੈਨੀਫਿਟਡ ਹੁੰਦੇ ਆ। ਵੈਸੇ ਸਾਡੇ ਪ੍ਰੋਫੈਸ਼ਨ ਦੀ ਜਿਹੜੀ ਹੈ ਇੱਕ ਜ਼ਰੂਰਤ ਹੈ ਕਿ ਅਸੀਂ ਆਪਣੇ ਆਪ ਨੂੰ ਸਾਡੇ ਫੀਲਡ ਦੇ ਵਿੱਚ ਅਪਡੇਟ ਰੱਖੀਏ। ਸੋ ਇਸ ਕਰਕੇ ਮੈਂ ਕਾਨਫਰੰਸ ਦੇ ਜਿਹੜੇ ਆਰਗੇਨਾਈਜ਼ਰ ਹੈ ਉਹਨਾਂ ਨੂੰ ਬਹੁਤ ਵਧਾਈ ਦਿੰਦਾ ਤੇ ਪੰਜਾਬ ਮੈਡੀਕਲ ਕਾਉਂਸਲ ਵੱਲੋਂ ਹਰ ਤਰ੍ਹਾਂ ਦੇ ਸਹਿਯੋਗ ਦੀ ਜਿਹੜੀ ਹੈ ਉਹ ਵਿਸ਼ਵਾਸ ਦਵਾ।
मैं डॉक्टर विजय कुमार बोधल, मैंबर पंजाब मैडिकल काउंसिल। मैं इस मैपकॉन 9th ते एज ए ऑब्जर्वर आया। देखिया भी जो ਜਿਹੜਾ ਜ਼ਿਲ੍ਹਾ ਬਠਿੰਡਾ ਬਹੁਤ ਹੀ ਪਛੜਿਆ ਹੋਇਆ ਸੀ, ਪਰ ਅੱਜ ਦੇਖ ਕੇ ਇਸ ਤਰ੍ਹਾਂ ਲੱਗਦਾ ਵੀ ਜੈਸੇ ਇੰਡੀਆ ਦੇ ਸਭ ਤੋਂ ਵਧੀਆ ਜ਼ਿਲ੍ਹਿਆਂ ਦੇ ਵਿੱਚ ਇਸ ਦਾ ਨੰਬਰ ਆ ਰਿਹਾ, ਕਿਉਂਕਿ ਇੱਥੇ ਏਮਸ ਦਾ ਇੰਸਟੀਚਿਊਟ ਖੁੱਲ੍ਹ ਗਿਆ, ਇੱਥੇ ਕੈਂਸਰ ਇੰਸਟੀਚਿਊਟ ਖੁੱਲ੍ਹ ਗਿਆ, ਇੰਨੀਆਂ ਮੈਡੀਕਲ ਫੈਸਿਲਿਟੀ ਹੋ ਗਈ ਆ ਜੋ ਡਾਕਟਰ ਵਿਠਲ ਵੱਲੋਂ ਮੈਪੀਕੌਨ ਕਰਵਾਈ ਜਾ ਰਹੀ ਆ। ਇਸ ਦੇ ਨਾਲ ਇਕੱਲਾ ਪੰਜਾਬ ਦੇ ਵਿੱਚ ਹੀ ਨਹੀਂ, ਪੰਜਾਬ ਤੋਂ ਬਾਹਰ ਵੀ ਕਿੱਥੇ ਕਿਹੜੇ ਜਿੰਨੇ ਵੀ ਇੰਡੀਆ ਦੇ ਸਭ ਤੋਂ ਵਧੀਆ ਇੰਸਟੀਚਿਊਟ ਨੇ ਮੈਡੀਕਲ ਹੈਲਥ ਦੇ, ਉਹਨਾਂ ਤੋਂ ਡਾਕਟਰ ਇੱਥੇ ਲੈਕਚਰ ਕੁਛ ਆਨਲਾਈਨ ਦੇਣਗੇ, ਕੁਛ ਜੋ ਡਾਕਟਰ ਨੇ ਇੱਥੇ ਫਿਜ਼ੀਕਲੀ ਲੈਕਚਰ ਦੇਣਗੇ। ਇਹ ਇਕੱਲੇ ਪੰਜਾਬ ਦੇ ਲਈ ਨਹੀਂ, ਇਹ ਪੂਰੇ ਆਲ ਇੰਡੀਆ ਲੈਵਲ 'ਤੇ ਹੀ ਇਹਦਾ ਮੈਸੇਜ ਆ ਰਿਹਾ, ਕਿਉਂਕਿ ਇੱਥੇ ਜਿੰਨੇ ਵੀ ਸਭ ਤੋਂ ਵਧੀਆ ਡਾਕਟਰ ਨੇ ਆਪਸੀ ਤਾਲਮੇਲ ਕਰਕੇ ਜੋ ਨਵੀਂ ਮੈਡੀਸਨ ਆਈਆਂ ਨੇ, ਨਵੀਂ ਟੈਕਨੀਕ ਆਈਆਂ ਨੇ, ਉਹ ਇੱਕ ਦੂਜੇ ਨਾਲ ਡਿਸਕਸ ਕਰਕੇ ਉਹ ਪੰਜਾਬ ਦੇ ਲੋਕਾਂ ਦੇ ਲਈ ਭਲੇ ਦੀ ਗੱਲ ਕਰਨਗੇ। ਦੂਸਰਾ ਜੋ ਵੀ ਇਹ ਜ਼ਿਲ੍ਹਾ ਪਛੜਿਆ ਹੋਇਆ, ਮੈਂ ਸਮਾਜ ਦੇ ਬਾਕੀ ਜਿਹੜੇ ਸਾਡੇ ਭੈਣ ਭਰਾ ਨੇ ਕਿ ਜੋ ਵੀ ਇੱਥੇ ਲੈਕਚਰ ਸੁਣਨਗੇ ਉਹਨਾਂ ਨੂੰ ਮੈਂ ਇਹ ਅਪੀਲ ਕਰਾਂਗਾ ਕਿ ਸਭ ਤੋਂ ਪਹਿਲਾਂ ਹੈਲਥ ਆ, ਦੂਸਰੇ ਨੰਬਰ 'ਤੇ ਪੈਸਾ। ਪੈਸੇ ਦੇ ਨਾਲ ਤੁਸੀਂ ਹੈਲਥ ਨਹੀਂ ਖਰੀਦ ਸਕਦੇ। ਹੈਲਥ ਦਾ ਜਿਹੜਾ ਵੀ ਸਿਸਟਮ ਆ, ਕਿਉਂਕਿ ਅਸੀਂ ਇਹੋ ਜਿਹੇ ਵੀ ਮਰੀਜ਼ ਦੇਖੇ ਨੇ ਜਿਹੜੇ ਅਰਬਾਂਪਤੀ ਨੇ, ਜਿਹੜੇ ਕਰੋੜਾਂਪਤੀ ਨੇ, ਪਰ ਉਹ ਜਦੋਂ ਵੀ ਬਿਮਾਰ ਹੁੰਦੇ ਨੇ ਬਸ ਇੱਕੋ ਹੀ ਕਹਿੰਦੇ ਵੀ ਡਾਕਟਰ ਸਾਹਿਬ ਮੇਰੀ ਸਿਹਤ ਬਚਾ ਲਓ, ਮੈਨੂੰ ਬਚਾ ਲਓ। ਪਰ ਜੇ ਹੈਲਥ ਚੰਗੀ ਆ ਤਾਂ ਸਾਡਾ ਸਮਾਜ ਚੰਗਾ ਹੋਵੇਗਾ, ਜੇ ਸਾਡਾ ਸਮਾਜ ਚੰਗਾ ਹੋਏਗਾ ਸਾਰਾ ਸਾਡੇ ਜੋ ਬੱਚੇ ਆ ਉਹ ਵੀ ਚੰਗੇ ਹੋਣਗੇ। ਇਸ ਲਈ ਮੈਂ ਸਾਰਿਆਂ ਨੂੰ ਅਪੀਲ ਕਰਾਂਗਾ ਆਪਣੀ ਹੈਲਥ 'ਤੇ ਖਿਆਲ ਰੱਖੋ ਅਤੇ ਆਪਣੀ ਹੈਲਥ ਨੂੰ ਵਧੀਆ ਢੰਗ ਦੇ ਨਾਲ ਸਵੇਰੇ ਸ਼ਾਮ ਸੈਰ ਕਰੋ, ਚੰਗਾ ਖਾਓ, ਚੰਗਾ ਬੋਲੋ, ਮਾੜੀ ਸੋਚਣੀ ਨਾ ਕਰੋ। ਇੰਨੀਆਂ ਸ਼ਬਦਾਂ ਨਾਲ ਮੈਂ ਸਾਰਿਆਂ ਨੂੰ ਬਹੁਤ ਬਹੁਤ ਧੰਨਵਾਦ।
ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਜੀ, ਮੈਂ ਚੇਤਨ ਸਿੰਘ ਜੋੜਾ ਮਾਜਰਾ, ਹੈਲਥ ਮਿਨਿਸਟਰ ਪੰਜਾਬ। ਸੋ ਅੱਜ ਅਸੀਂ ਇੱਥੇ ਬਠਿੰਡਾ ਵਿਖੇ ਪਹੁੰਚੇ ਹਾਂ, ਜੋ ਮੈਪੀਕੌਨ ਵੱਲੋਂ ਜਿਹੜਾ 9ਵੀਂ ਕਾਨਫਰੰਸ ਹੈ ਉਹ ਕਰਵਾਈ ਗਈ ਹੋਈ ਆ। ਉਹਦੇ ਵਿੱਚ ਬਹੁਤ ਸਾਰੇ ਨਵੇਂ ਸਾਡੇ ਨੌਜਵਾਨ ਜਿਨ੍ਹਾਂ ਨੂੰ ਬਹੁਤ ਲੋੜ ਹੈ ਸਿੱਖਣ ਦੀ, ਉਹ ਇਸ ਕਾਨਫਰੰਸ ਦੇ ਵਿੱਚ ਪਹੁੰਚੇ ਨੇ, ਕਿਉਂਕਿ ਇਹ 9 ਸਾਲ ਕੋਈ ਛੋਟਾ ਪੀਰੀਅਡ ਨਹੀਂ ਹੁੰਦਾ, ਬਹੁਤ ਲੰਬਾ ਪੀਰੀਅਡ ਹੈ। ਜਦੋਂ ਪਹਿਲੀ ਕਾਨਫਰੰਸ ਡਾਕਟਰ ਬਿਤਲ ਗੁਪਤਾ ਜੀ ਨੇ ਕਰਵਾਈ ਤਾਂ ਉਹਨਾਂ ਨੂੰ ਕਿੰਨੇ ਜਿਹੜਾ ਮੁਸ਼ੱਕਤ ਕਰਨੀ ਪਈ ਹੋਣੀ। ਸੋ ਉਹਨਾਂ ਨੇ ਜਿਹੜੇ ਸਾਡੇ ਨਵੇਂ ਨੌਜਵਾਨ ਜੋ ਹੁਣ ਮੈਡੀਕਲ ਕਰ ਰਹੇ ਨੇ, ਉਹਨਾਂ ਜਿਹੜੇ ਡਾਕਟਰੀ ਕਰ ਰਹੇ ਨੇ, ਉਹਨਾਂ ਵਾਸਤੇ ਬਹੁਤ ਸੋਹਣੇ ਮੌਕੇ ਨੇ ਜਿਹੜੇ, ਜਦੋਂ ਕਿ ਉਹਨਾਂ ਨੂੰ ਆਪਣੇ ਟ੍ਰੇਨਿੰਗ ਦੇ ਵਾਸਤੇ ਜਿਹੜੀ 10 ਘੰਟੇ ਦੀ ਜਿਹੜੀ ਲੋੜ ਹੁੰਦੀ ਐਕਸਪੀਰੀਅੰਸ ਦੀ ਲਾਉਣ ਦੀ, ਕਲਾਸਾਂ ਲਾਉਣ ਦੀ, ਆਪਣਾ ਕਾਨਫਰੰਸ ਦੇ ਵਿੱਚ ਉਹ ਕਰਨ ਦੀ, ਉਹਦੇ ਵਿੱਚ ਉਹਨਾਂ ਨੂੰ ਉਹਨਾਂ ਦੇ ਘਰ ਦੇ ਵਿੱਚ ਜਦੋਂ ਮਿਲ ਜਾਂਦੇ, ਇਹ ਮਾਲਵੇ ਦੇ ਸਾਰੇ ਡਾਕਟਰ ਸਾਹਿਬਾਨ ਜਿਹੜੇ ਇਕੱਠੇ ਹੋ ਕੇ ਜਿਹੜੀ ਕਾਨਫਰੰਸ ਕਰਦੇ ਨੇ। ਔਰ ਪਹਿਲਾਂ ਜਦੋਂ ਸ਼ੁਰੂਆਤ ਕੀਤੀ ਗਈ ਸੀ ਤਾਂ 175 ਜਿਹੜੇ ਡੈਲੀਗੇਟ ਇੱਥੇ ਪਹੁੰਚੇ ਸੀ। ਅੱਜ ਉਹਨਾਂ ਡੈਲੀਗੇਟਸ ਦੀ ਜਿਹੜੀ ਗਿਣਤੀ ਆ ਉਹ ਵੱਧ ਕੇ 500 ਹੋ ਗਈ ਹੈ। ਸੋ ਇੱਥੋਂ ਪਤਾ ਲੱਗਦਾ ਕਿ ਇਸ ਜਿਹੜੀ ਮੈਪੀਕੌਨ ਜਿਹੜੀ ਕਾਨਫਰੰਸ ਆ ਉਹਦਾ ਕਿਵੇਂ ਲੋਕਾਂ ਦੇ ਵਿੱਚ ਜਿਹੜਾ ਪ੍ਰਭਾਵ ਛੱਡ ਰਹੀ ਹੈ। ਸੋ ਮੈਂ ਸਾਰੇ ਜਿਹੜੇ ਸਾਡੇ ਪੰਜਾਬ ਦੇ ਜਾਂ ਹੋਰ ਦੇਸ਼ ਦੇ ਵਿੱਚ ਜਿਨੇ ਡਾਕਟਰ ਆ ਉਹਨਾਂ ਨੂੰ ਬੇਨਤੀ ਕਰਨਾ ਕਿ ਤੁਸੀਂ ਵੀ ਆਓ ਔਰ ਰਲ ਕੇ ਅਸੀਂ ਸਾਡੇ ਦੇਸ਼ ਨੂੰ, ਸਾਡੇ ਪੰਜਾਬ ਨੂੰ, ਜੋ ਬਹੁਤ ਸਾਰੀਆਂ ਬਿਮਾਰੀਆਂ ਤੋਂ ਪੀੜਤ ਨੇ, ਉਹਨਾਂ 'ਤੇ ਅਸੀਂ ਵੀ ਕੁਛ ਨਵਾਂ ਕੁਛ ਲੈ ਕੇ ਆਈਏ, ਤਾਂ ਕਿ ਬਹੁਤ ਸਾਰੀਆਂ ਬਿਮਾਰੀਆਂ ਇੱਦਾਂ ਦੀਆਂ ਨੇ ਜਿਨ੍ਹਾਂ 'ਤੇ ਲੰਬਾ ਸਮਾਂ ਮੈਡੀਸਨ ਖਾਣੀ ਪੈਂਦੀ ਆ। ਸੋ ਉਹਨਾਂ ਤੋਂ ਕੋਈ ਨਵੀਂ ਆਜ਼ਾਦ ਕਰਕੇ ਅਸੀਂ ਕੋਈ ਇਹੋ ਜਿਹੀ ਮੈਡੀਸਨ ਲਈਏ ਜਿਨ੍ਹਾਂ ਨੂੰ ਲੰਬਾ ਸਮਾਂ ਜਿਹੜਾ ਮੈਡੀਸਨ ਦੀ ਜ਼ਰੂਰਤ ਨਾ ਕਰਨਾ ਪਵੇ, ਉਹਨਾਂ ਥੋੜ੍ਹੇ ਸਮੇਂ ਦੇ ਵਿੱਚ ਹੀ ਜਿਹੜਾ ਇਲਾਜ ਹੈ ਅਸੀਂ ਮੁਹੱਈਆ ਕਰਾ ਸਕੀਏ। ਸੋ ਅਸੀਂ ਆਪਦੇ ਵੱਲੋਂ ਅਸੀਂ ਪੰਜਾਬ 'ਚ ਜਿਹੜਾ ਸਿਹਤ ਪ੍ਰਤੀ ਹੈ ਸੋ ਪੂਰੀ ਸੰਜੀਦਗੀ ਨਾਲ ਜਿਹੜਾ ਕੰਮ ਕਰ ਰਹੇ। ਸੋ ਅਸੀਂ ਵੀ ਚਾਹੁੰਦੇ ਹਾਂ ਕਿ ਹਰ ਇੱਕ ਨਾਗਰਿਕ ਦਾ ਜਿਹੜਾ ਇਲਾਜ ਹੈ ਉਹ ਉਸਦੇ ਨੇੜੇ ਤੇੜੇ ਸੋ ਕੀਤਾ ਜਾਵੇ। ਸੋ ਸਾਰਿਆਂ ਦਾ ਬਹੁਤ ਬਹੁਤ ਧੰਨਵਾਦ।
So this was our new addition to MAPICON, and every delegate, most of the delegates, all the speakers and our dignitaries had this interview, and that will be available on our website. Now the last part of the felicitation function is messages and word of wisdoms. First I invite Mr. Anil Pola to please say a few words.
ਨਮਸਕਾਰ, ਮੈਂ ਡਾਕਟਰ ਬਿਤਲ ਗੁਪਤਾ ਜੀ ਨੂੰ, ਜੋ 9 ਸਾਲ ਤੋਂ ਮਿਹਨਤ ਕਰ ਰਹੇ ਸੀ ਮੈਪੀਕੌਨ 'ਤੇ, ਤੁਸੀਂ ਸਾਰੇ ਜਾਣਦੇ ਹੋ, ਪਰ ਜਿੰਨਾ ਕਿ ਮੈਂ ਜਾਣਦਾ ਉਹਨਾਂ ਦੇ ਪਰਿਵਾਰ ਅਤੇ ਉਹਨਾਂ ਦੇ ਸੰਸਕਾਰ ਆ ਕੇ ਜੋ ਕੋਵਿਡ ਦੇ ਟਾਈਮ 'ਤੇ ਜੋ ਉਹਨਾਂ ਨੂੰ ਮੈਂ ਇੰਨੇ ਨੇੜੇ ਦੇਖਿਆ ਸਮੇਤ ਪਰਿਵਾਰ, ਜੋ ਉਹਨਾਂ ਨੇ ਜਦੋਂ ਹਿੰਦੁਸਤਾਨ ਦੇ ਪ੍ਰਾਈਵੇਟ ਡਾਕਟਰਸ 'ਚੋਂ ਚੰਦ ਡਾਕਟਰ ਹੀ ਬਾਹਰ ਨਿਕਲੇ ਸੀ, ਡਾਕਟਰ ਸਾਹਿਬ ਨੇ ਜੋ ਉਦੋਂ ਵੀ ਸੇਵਾ ਕੀਤੀ, ਔਰ ਉਸ ਟਾਈਮ ਜੋ ਇਹਨਾਂ ਨੇ ਲੋਕਾਂ 'ਚ ਅਵੇਅਰਨੈਸ ਦੱਸੀ ਸੀ ਵੀ ਕੋਵਿਡ ਤੋਂ ਡਰਨ ਦੀ ਲੋੜ ਨਹੀਂ, ਨਵੀਂ ਟੈਕਨੀਕ ਆ ਗਈ, ਤਾਂ ਉਵੇਂ ਹੁਣ ਜਿਵੇਂ ਮੈਪੀਕੌਨ 'ਚ ਵੀ ਇਹ ਜ਼ਰੂਰਤ ਸੀ ਦੱਸਣ ਦੀ, ਜੋ ਹੁੰਦਾ ਹੈ ਵੀ ਮੈਡੀਕਲ ਸਾਇੰਸ 'ਚ ਨਵੀਆਂ ਅਗਰ ਨੇਚਰ ਬਿਮਾਰੀਆਂ ਦਿੰਦੀ ਹੈ ਤਾਂ ਉਹ ਨਵੇਂ ਇਲਾਜ ਵੀ ਕਿਵੇਂ ਆਪਾਂ ਅਪਗ੍ਰੇਡ ਹੋਣਾ ਹੈਗਾ ਡਾਕਟਰਸ ਨੇ। ਤਾਂ ਜੋ ਇਹ ਕਰ ਰਹੇ ਆ ਸਮਾਜ ਅਤੇ ਮੈਡੀਕਲ ਲਈ, ਸੱਚੀ ਰੀਲੀ ਗ੍ਰੇਟ। ਥੈਂਕ ਯੂ ਡਾਕਟਰ ਸਾਹਿਬ, ਥੈਂਕ ਯੂ।
Thank you, Mr. Anil. Now I'll invite Dr. Usha Goyal for his message.
I think that was not required. A very good afternoon. Thank you, Dr. Vittal. This is an educational feast, especially for the residents And since now we have AIMS here in addition to Adesh, I think all the undergraduate and postgraduate students are all waiting for this MAPICON every year. I know he started with 2 days to 3 days, and now it is 4 days. It is a Herculean task, definitely. And I know it is difficult to organize. He starts his conference like in 2022, and he plans his conference for the next year again, and registrations are started. That is a commendable job. Thank you, Dr. Whittle. Thank you. And next time, what I requested him was that we discussed all sorts of illnesses, diabetes, hypertension, hypothyroidism. Today we had 3 lectures in psychiatry also, very good ones. But we forget that in addition to providing the curative aspect, we also have to talk on prevention. We are considered to be the custodians of health of the society. So what I requested him to add a lecture on the dietary habits of the society. Because if we as doctors, even I when I got promoted, came into this field, I didn't know so many things. It was an eye-opener when I joined here as a district health officer, food in charge last year. Yes, and I wish I can continue working in this field because it is really enlightening. I mean, what I didn't know, and I know most of the people don't know what we are eating, why we are eating, what we should eat, how we should eat. We will be organizing talks in various institutes, schools, colleges. We have a limited task force. At least I have only 5 people with me. The experts include only 3 in addition to me. So what I request is we should have these lectures in such type of conferences so that we can also include the preventive part. Thank you, Dr. Whittle. Thank you. He's I think, a godsend messenger for Bathinda. Thank you.
Thank you, madam. We had a discussion on this, and I there and then offered 4 lectures to madam of her choice for food practices, prevention, and millet we were talking about. So give me 4 lectures, 20 minutes lecture, 5-minute discussion. So we will include the DHO's session in next MAPICON. So that is promised. Thank you very much for your suggestions. Now I'll invite Dr. Janakraj Singla, Observer, Punjab Medical Council, to please give us good... आजा यार ओ नहीं 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 असी थारा कह रहा थोड़ी छड़ना है So what we should do next, or any suggestions to improve the quality as well as promotion of MAPICON?
Respected guests and doctors, delegates, really it was some wonderful conference organized by Dr. Bitul Gupta and his team. ਸਾਡੇ ਬਠਿੰਡਾ ਇਲਾਕੇ ਵਾਸਤੇ ਜਿਹੜੀ 9 ਸਾਲ ਤੋਂ ਹੋ ਰਹੀ ਹੈ ਮੈਪੀਕੌਨ, ਬਹੁਤ ਹੀ ਵੱਡਾ ਸਾਡੇ ਡਾਕਟਰਾਂ ਵਾਸਤੇ ਇੱਕ ਸਿੱਖਣ ਦਾ ਪਲੇਟਫਾਰਮ ਹੈ, ਜਿਹਦੇ ਵਿੱਚ ਵੱਖ-ਵੱਖ ਸਬਜੈਕਟਾਂ 'ਤੇ, ਜਿਵੇਂ ਮੈਂ ਹੁਣ ਸੈਕਟਰੀ ਦੇ ਕੁਛ ਲੈਕਚਰ ਸੁਣ ਰਿਹਾ ਸੀ, ਡਾਕਟਰ ਪੂਨਮ ਭਾਰਤੀ, ਉਹਨਾਂ ਦਾ ਬਹੁਤ ਡਿਟੇਲ ਦੇ ਵਿੱਚ ਬਹੁਤ ਹੀ ਅੱਛੀ ਤਰ੍ਹਾਂ ਵੈਲ ਐਕਸਪਲੇਨਡ ਚੀਜ਼ ਸੀ। ਦੂਸਰੀਆਂ ਸਪੈਸ਼ਲਟੀ ਵਾਲੇ ਬੰਦਿਆਂ ਨੂੰ ਵੀ ਕੁਛ ਸਮਝ ਆ ਜਾਏ ਇਸ ਤਰ੍ਹਾਂ ਦਾ ਕੁਛ ਸੀ। ਤਾਂ ਮੈਂ ਕਹਾਂਗਾ ਕਿ ਸਾਡੇ ਇਲਾਕੇ ਵਾਸਤੇ ਇਹ ਸਾਰੀਆਂ ਬਹੁਤ ਅੱਛੀਆਂ ਚੀਜ਼ਾਂ ਕਿ ਦੂਰ ਦੂਰ ਕਾਲਜਾਂ ਤੋਂ, ਅੱਛੇ ਕਾਲਜਸ ਤੋਂ ਲੈਕਚਰਰ ਆਉਂਦੇ ਹੈ, ਉਹ ਸਪੀਕਰ ਆਪਣਾ ਜਿਹੜਾ ਲਾਈਫ ਟਰਮ ਐਕਸਪੀਰੀਅੰਸ ਹੁੰਦਾ ਉਹ ਸਾਰਾ ਸਾਨੂੰ ਡਿਸਕਸ ਕਰਕੇ ਜਾਂਦੇ ਹੈਗੇ ਹੈ। ਸੋ ਮੈਂ ਡਾਕਟਰ ਬਿੱਤਲ ਨੂੰ ਵਧਾਈ ਵੀ ਦਿੰਦਾ ਇਸ ਕਾਨਫਰੰਸ ਵਾਸਤੇ, ਅਤੇ ਪਰਮਾਤਮਾ ਅੱਗੇ ਦੁਆ ਕਰਦਾ ਕਿ ਕਾਨਫਰੰਸ ਜਿਹੜੀ ਹੈ ਦਿਨ ਦੁਗਣੀ ਰਾਤ ਚੌਗੁਣੀ ਤਰੱਕੀ ਕਰਦੀ ਰਹੇ, ਅਤੇ ਪੰਜਾਬ ਮੈਡੀਕਲ ਕਾਉਂਸਲ ਵੱਲੋਂ ਮੈਂ ਇਹਨਾਂ ਨੂੰ ਅਸ਼ੋਰੈਂਸ ਦਿਵਾਉਂਦਾ ਕਿ ਹਮੇਸ਼ਾ ਤੁਹਾਡੇ ਨਾਲ ਹੈ। ਥੈਂਕ ਯੂ ਜੀ।
Thank you, Dr. Janak. Now I'll invite Professor Dr. D.K. Singh, Director AIMS, for his word of wisdom as well as suggestions for MAPICON. Thank you.
Thank you. I congratulate the MAPICON team for organizing one of the good conference. I heard the suggestion of district health officer, SHO, what you call. I may be not telling the exact position of yours, but it's a good suggestion. We all know that prevention is better than the cure. We can't treat the whole population, but certainly by some recommendation, we can prevent problems, which is very economical and easy to do it. But at the same time, we need help from everybody. We need help from government, administrative organizations, police, doctors, and society at large. We should not tolerate any adulteration in food, at least. So it is our responsibility of everybody to see that we must eat good things. We also need at the India level also, I will say, that we need good institute of public health and hygiene. Malnutrition, even in developed state like Gujarat, is very high. So we need to change our habit. We need to change our food also, quality of food. This is a very good suggestion to discuss the preventive methods. I was lucky to listen the last lecture by psychiatrist. She made it, I must congratulate you that you made it very interactive. And lectures should be given like this only, interactive, so that active participation should be there. And I'm really happy and I'm surprised to have such number of attendance in valedictory session. Usually, even if I say the National API conference, valedictory doesn't attract so many delegates. It's a good participation. With this, I wish all the best for the next conference. Thank you, Dr. Bitul Gupta and team.
Thank you very much, sir. And I am sure under your leadership, AIMS is going to be both Center for Academics as well as treatment and prevention of the diseases. Thank you, sir. Now I'll invite our organizing committee member, Dr. M.R. Gupta, to give vote of thanks.
Hello, good afternoon, my dear friends and delegates. Any conference is not complete without a vote of thanks to all those who provided us support for the successful completion of this conference. First of all, I would like to thank all the delegates who participated in the conference, without whose presence this conference would have not been possible. Secondly, I would like to thank all the speakers who came from far-off places to deliver their lectures and whose participation in this conference was very, very much important. So I like to thank all the speakers for their contribution coming from far-off places. I would also like to thank our health minister and MLA Sahibans who came to this conference to attend the conference. Our distinguished Dr. D.K. Singh ji, Director AIMS, Civil Surgeon Bathinda, Dr. Tejwan Singh ji, Shrimati Usha Goyal, Dr. Usha Goyal. I also thank all of them for coming and to grace the occasion. I also thank Sri B.H. Taliwal, MD, Baba Farid Group of Institutions, for providing us volunteers for this conference. I also thank Mr. Anil Bhola for coming and grace the occasion. I also thank Ms. Ashwini Malhotra for providing us delicious and tasty food. I also thank Mr. Kunal Sharma and Mr. Hedy for all the technical support provided for the conference. I also thank from my heart, core of my heart, Mr. PMC members, Mr. Jankra Singla and Shri Vijay Kumar. I also thank Mr. Ajay Gupta for all the help in the printing work timely. Next, I would like to thank Mr. Dr. Naresh Goyal of Delhi Health Institute and Research Center Bathinda for providing us financial support as well as speakers for this conference. I would like to thank the pharma companies, USV, Torrent, Intas Pharma, Tasmed Pharma, without whose presence this conference would have been possible. Again, I thank everybody. Thanks.
So next we will proceed with our regular scientific session. You want to speak something? Come, please. Dr. K.K. Noria, Chairman Organizing Committee. Anji? Kaun? So I thank Dr. K.K. Goyal from Sarsa. Please stand up now. So he is my batchmate, excellent person. Dr. H.N. Singh, Director Health, retired now. And my batchmate, Dr. Rakesh Goyal also. Thank you very much. Hun theek hai?
डॉक्टर के गोयल ਤੁਹਾਡੀ ਕਮੀ ਪੂਰੀ ਕਰਨ ਵਾਸਤੇ ਮੈਂ ਉੱਠ ਕੇ ਆਇਆ ਐਕਚੁਅਲੀ ਬੇਸਿਕ ਰੀਜ਼ਨ ਮੇਰਾ ਉੱਠ ਕੇ ਆਂਦਾ ਹੀ ਹੈ ਸੌਰੀ ਹਾਂ ਹਾਂਜੀ ਹਾਂਜੀ I think you see, just want to add, you see what he has said, the vote of thanks. As a friend, an event of this magnitude, of this dimension, is not possible and it doesn't happen overnight. The wheel starts rolling months advance. We are fortunate enough to be backed by a team of very motivated members. Friends, my special thanks and gratitude to Dr. Vitul Gupta for his untiring efforts, stamina, beyond doubt, you see. So 3 cheers for him, you see, and so that's why, you see, because he didn't mention about Dr. Vitul Gupta, so I just came up, you see, to say few words, you see. And again, you see, once again, thank you everybody whosoever has participated in this meeting, in this conference. If anybody has left, you see, intentionally or unintentionally, so we feel sorry for that. Again, once again, thank you very much. Thank you. Friends, we are going to proceed for the scientific session next. See, scientific session, please.
Our next guest speaker is Dr. Alok Modi, consultant diabetologist, Jupiter Hospital, Cavalier Hospital, Dr. Modi's Diabetes Center, Mumbai.
who will be presenting on the topic Psychosocial Aspects of Diabetes and Overview.
Can I have the slides? Good afternoon. A very good afternoon to everybody. First of all, I'd like to thank Dr. Vitul for giving me this opportunity, and I'm really grateful and gratified to have flown in all the way from Mumbai. Last 2 years I've seen COVID, and we were all busy with a lot of webinitis and Zoomitis. A lot of conferences were running on a virtual platform. It's after a long time that I'm physically attending a MAPICON of this level and magnitude and as a faculty. So it gives me a lot of privilege and happiness to be here. And last 2 days I've attended a wonderful academic session. So thanks Dr. Vitul and the organizing committee sitting over here. So my topic is a very hatke topic, very different topic on psychosocial aspects of diabetes. Now, diabetes is something that we all are highly ingrained into. We talk a lot about sugar control. We talk a lot about glycemic and HbA1c management. We go beyond that. We go for the CVOT data. We go for the renal data. We go for the umbrella of diabetes of nephropathy, retinopathy, cardiomyopathy, coronary syndromes. We stop over there. We generally do not go beyond that. We are very happy if our patients are well controlled from a physical angle. How much do we care and how much are we concerned about the psychological aspects of a patient? And how much are we concerned about the psychological aspect of the healthcare provider who's managing diabetes? So I'll try to touch upon this, a huge lacunae that is prevalent in clinical medicine. There's not much work on the literature also. I'll try to cover this as to the best of my ability. And it's a real eye-opener once you see the figures and the study and the data that has been conducted. We can classify this into different forms. You have diabetes patients who present with symptoms which are psychiatry symptoms. You have another group where patients with diabetes result into a psychiatry patient and need the help of a colleague psychiatrist with overblown psychiatry overlay in diabetes. You have people who are primarily psychiatry patients who develop diabetes down the road, and it becomes a challenging task to handle both the scenarios in your patient as a diabetologist. You have certain patients who are already on psychotropic medicines, which result into diabetes, and it's a small list, but it's a very complicated list. That's something which we need to coordinate with our colleague psychiatrists and manage the diabetes over there. And we have a huge chunk of our diabetology patients that we all see in our practice who are totally non-compliant and non-adherent with their medications. And they pose a big challenge in managing diabetes, not because the prescriptions and the strategies are not right, but because patients are not comfortable taking those medications. So this is something which is called as a diabetes distress. This is the sign QAnon which is given in the literature. And the diabetes distress part is something that we are really not much aware of. You will be amazed if you look at the data that around 45% people are suffering from diabetes distress because of diabetes. And around 50% of this population develop diabetes distress during the course of therapy as soon as within 18 months of initiating therapy. This diabetes distress causes a lot of issues. There are a lot of medication taking behaviors. This diabetes distress is primarily a big reason why adherence to medications is not present, irrespective of the cost and complications and adverse events of medicines. In a huge chunk of diabetic population, and we know that India is a second world leader in diabetes, and a good chunk of our diabetics are adolescents and young people, not type 1, but type 2, including LADA and MODI. And these are the people who develop a huge chunk of diabetes distress with their work style and their medication style. We are not aware of the fact that 10% of our diabetes population which are suffering from type 1 are not the people that we need to tackle. We need to tackle their parents. More than the patient, the diabetes type 1 patients' parents suffer a lot of diabetes distress, and they have a huge chunk of a psychiatric overlay that we really do not address as diabetologists. We have a lot of patients whose HbA1cs do not come under control in spite of the most costly and the latest medications available. And they have poor compliance with exercise, lifestyle, and therapy modifications, and they result into diabetes distress. So eventually what happens, besides managing diabetes, these are the people who are shocked with the diagnosis of developing diabetes. These are the people who are worried and they're anxious because of their health. These are the people who develop neuropathy, retinopathy, nephropathy, and they get complicated and they get psychiatrically disturbed. These are the people who do not have any access to any support groups, and this is a big thing which I would cover down the road. We have a lot of these people who have a very negative impact on their lifestyles, and we don't see when we write a prescription what is the cost of a prescription, what I call as a prescription damage. How much damage is this going to cost to the pocket of a patient? And remember, in India, the OPD is not covered by most of the insurances. OPD practice with the newer drugs like GLP agonists and SGLT2 inhibitors can cause a huge chunk of financial drain. The second generation basal insulins yet come to be costly, and they cause a big overlay and complications to our patients. From my own practice for the last 25 years, I've realized one thing, that most of these patients suffer from adverse diabetes, mental issues because of loss of health, because of diabetes, and it's the other way around in metro cities. They lose health and then they develop distress because of diabetes. We ignore these people who have hypoglycemic episodes. They have a lot of diabetes, distress and anxiety and performance issues because of hypoglycemia, and the hypoglycemia complicates the distress. We ignore the fact that these people develop neuropathies and they have a lot of psychological issues because of neuropathies, because of performance issues. Imagine having tingling sensation in the hands and the legs, not being able to write, sign your bank checks, and having performance issues. We have a big chunk of people who suffer from insulin inertia. And I think we all know that insulin inertia is not an inertia in the patient population. There's a bigger chunk of insulin inertia in the doctor population. The healthcare providers are more reluctant to write insulin than the patients who are receiving them. There is a lot of negative media publicity about insulin. We have so much so-called oral insulin which is present in camel's milk, and so-called and so-all, which is all a lot of humbug, and it causes a lot of stress on our patients. I think most of our patients, including 90% of them, do not actually share their diet problems with you. I don't think most of them are compliant, and a big chunk of them are not coming to you because of dietary and exercise modifications. Erectile dysfunction and sexual dysfunction is a big overlay. We hardly address it in spite of the fact that we are aware of it. We also know that ED is one of the first complications to certain diabetes as a marker of microvascular damage. But do we address the psychological issues of ED? We don't. We see our patients hiding their diagnosis of diabetes in their insurance forms. We see people who are scared of putting CGM sensors. We see people who have got taboo of marriage in type 1 diabetes. And very important, we know that at least every 4th or 5th patient in the population is a diabetic. So what about us? A lot of healthcare providers and diabetologists suffer from diabetes. And like Meta very rightly said about preventive medicine, how many of us suffer from diabetes? How many of us address our own psychological issues? How many of us share our diabetes issues with our colleagues? And how many of us actually go to our colleagues for therapy and stop treating ourselves? Most of us who suffer from diabetes, being medical professionals, like to treat on our own, and we see complications and deaths, but we are shit scared of going to our colleagues for preventive and therapeutic modalities. So that issue of being discovered having psychological impact because of diabetes is something which runs through the medical professional and the patient group, and we don't really seek any peer support. So it becomes a vicious circle. It's a bi-directional relationship. Diabetes leads to mood swings, depression, health issues, and these mood swings, health issues, and non-compliance with medication leads to a worsening of diabetes. Eventually, everything bounds a patient into a capsule, poor social interaction, seeking out non-qualified medical help, seeking out non-qualified psychological help, and landing up in issues which worsen the diabetes and health. So am I talking through my head? Am I talking in the air? Do we have literature? Do we have hardcore data? Because we prepare and we practice evidence-based medicine. So I'll walk you through some Western data, and you will be surprised to know that there's a huge chunk of Indian data which can cover diabetes in a big way. So what is the impact of diabetes and quality of life and well-being if you look at the DAWN study? Now, DAWN study is one of the major studies in diabetes, and what this shows, okay, is this visible? So I'm not touching it, that's okay. I can use the mouse, right? Okay, now diabetes has a big impact on the life domains of a diabetologist. As you can see, the major chunk of people have a reduced physical health, but a very few chunk of people have poor interpersonal relationship with families and friends. The Dawn study, the Indian study, and the Canadian study, they have relied heavily on a questionnaire called as a paid questionnaire, which is called as problem areas in diabetes management. How many of us actually use this 50 questionnaire, 50 set of questions? We give it to our patients, take their response and classify it, use probably a Google form or technology to understand the psychosocial impact. We really don't do. There is a WHO questionnaire which looks for more than 20 points to assess the diabetes social scale, but we don't do that. So this is the kind of a database that we can utilize to understand the psychosocial impact. And what is very surprising is half of our people who suffer from diabetes in the Dawn study had emotional distress, where the paid 5 score was more than 40, which is the official cutoff in this score. What's even surprising is women patients with diabetes have got much more psychological impact and problems than the male counterparts. So this was quite surprising when I read it. And as you can see in all the 3 scales, the WHO 5 scale, the PAID scale, and the EQ 5D VAS scale, the p-value was significant statistically. It's a 60 to 65% chunk of women diabetologists who suffer more psychological impact than their male counterparts. And what in that? The financial issues were more bothersome to the female patients. Physical health was less bothersome. And hypoglycemic episodes was more bothersome to a female patient than the male patient. This is really surprising because we feel that there is a lot of discrimination regarding sex and gender and color. But do you know that not only tuberculosis and not only COVID, diabetes itself causes discrimination in society? Around 20% of patients feel discriminated and left out and poorly treated because they've got diabetes from their peer groups in their own community. And that itself causes a lot of stress. And this was something which was found by this Dawn 2 study. And if you look at the regional geographical distribution, the Dawn 2 study found that the adverse effects of psychological issues were much more common in countries like Turkey, India, and China. So, you know, the sad part is not only are we leading in the number of people with diabetes, we're also leading in the adverse social effects of diabetes in our own population. And as you can see, these are the countries which have a different socioeconomic impact. It has nothing to do being a developed country or a developing country, because even Japan is pretty high on the list over here. Now, if you look at an individual basis, if you assess your patients, they have found out that 46% of family members would like to help. They would like to get more involved, but they don't know how to get involved. Around 40% of people were actually willing to get involved, but they didn't get an opportunity to get involved. And again, around 37% people were willing to get involved with the care of their relative, but they just didn't know how to help. So that tells you that there is a big chunk of an iceberg that needs to be addressed, which has not been addressed. And they found in the Dawn study that the major issue that was causing diabetes stress among family members was hypoglycemia. So we really address hypoglycemia besides giving glucose or cutting down insulin or changing the medication from a sulfonylurea to probably a DPP-4 inhibitor? Do we go into the social impact? Do we talk to the relatives with the social impact? We don't do that. So the Dawn study did something very wonderful. They did a randomized study. They took around 8,500 patients who had diabetes. They took around 2,000 people of family members of diabetics, and they took around 5,000 people who were healthcare professionals, and they split it up into people with insulin, non-insulin, people who were not on medicines. The healthcare professionals split up into diabetologists, nurses, dietitians, and diabetes specialists. And it was so surprising when you look at this study that 71% of people they found of the family members were never involved in the healthcare of these people with type 1 diabetes. And again, around 77% people in type 2 diabetes were never involved. So what we do in our practice, according to the Dawn study, we give a lot of focus and attention on the patient, but we hardly bother to get the spouse or the family member concerned or involved with us in management of the patient. And they feel left out, but they're highly willing to be participant and involved in the healthcare. This is another eye-opener. When the study was conducted, they found that 29% of people, 56% of healthcare professionals felt that they have done their diabetes plan very well and they have done the necessary work that was supposed to be done for the patient. But only 30% of the family members felt that the doctor has done justice with the psychological aspect of diabetes. Around 77% of healthcare people thought that they knew how to listen and how to interact with the patients. But sadly, 40% of the family members felt that justice was being done. 72% of healthcare professionals felt that they have done the necessary thing, they have done their job, and they have done a prime job of managing their patients, but the relatives, no. 40% people felt that the healthcare professional has not delivered the goods, they have not done a good thing, they need to do better than that. So what they did was they changed the scenario, they got the people to get involved in healthcare, and statistically, evidence-based medicine, what did they find? A better quality of life, better empowerment of diabetes. Today is the era of patient empowerment. Whether you like it or not, your patient comes empowered with Google and WhatsApp. Your patients are empowered with their peer groups, and they are more empowered than you are in managing diabetes care. And if you do it through a proper channel, a better diabetes empowerment, less psychological problems, and a better quality of life, and all those 4 parameters were statistically significant. This is what the DAWN study has shown. So I think it's a big eye-opener to tell you that DAWN study has opened a way in which you can interact with your diabetes patient. Another major study is Diabetes Canada. And if I were to go into the details, it opens up a Pandora box because they conducted a series of dialogues between the healthcare provider and the patient group. And they found that down the road, both of them, they have a diabetes burden, they burn out, they both develop diabetes distress, and eventually both the healthcare provider and the patient eventually go into depression. That's a very sad thing. And they suggested that it's not your job just to treat the patient, it is your job to identify, it is your job to educate, it is your job to recommend, and it is your job to give them choices of functional therapy situations to a patient and support them. If you can understand stress management, if you can understand a social support system, if you can have an image of yourself as a healthcare provider beyond writing a prescription, and if you are capable of handling it yourself, then you can do something which is called a real diabetes management. So it is an interactive situation, it is a conversational situation, and you have to keep doing it. It cannot be delivered today and done. You can write a prescription of a metformin and a sulfonylurea and an insulin and take care of the HbA1c for the next 3 years, but your job as a psychological impact scenario management does not end with one visit. It has to keep going in every visit. This is what the Canadian scenario told us. How many of us address the sexual problems in diabetes management? I'm giving you this paper. This is a monologue. It's a wonderful paper. It's some 20 pages article which is worth reading. And they've covered the sexual problems in details in diabetes, the psychological aspect. And it is highly surprising when you read this article. They found that diabetes sexual problems in women have nothing to do with the complications of diabetes. Neither neuropathy, nor cardiopathy, nor retinopathy, nor any kind of insulin therapy resulted in any kind of a diabetes disproportionate behavior in a woman. It was something totally different. The sexual dysfunction in women was totally correlating only with the duration of diabetes, not with any other complication of diabetes. This is as far as women are concerned. What about diabetic men as per this study? Erectile impotence in diabetes is a prominent problem in diabetic men, but this problem is not so much of an organic problem, it is more of a psychological problem than organic problem. Now, what is important to understand is when your male patient comes to you with ED, do you directly start recommending them to a sex therapist or a sexologist and start doing investigatives? You realize that your patient may not be developing a family, may not be having infertility issues, not because he's suffering from a decreased sperm count or from an organic dysfunction. It is purely erectile dysfunction because of psychological issues. The MILE study, which was Impact for Long-Term Empowerment and Success, showed very clearly by using the PATE scale and the WHO scale that there is a huge chunk of diabetes distress which is never addressed and resulted in a lot of sexual dysfunction in men. And I won't go into this slide. It's a little busy slide. There's some 1,935 participants. They concluded it in both type 1 and type 2 diabetes. They showed overall 20 to 30% people having an overlay with sexual dysfunction, which is purely non-organic. Again, this is a good data, a small set of data from Pakistan done by some very good analytical work here. And what they showed is the approach to a psychological issue in a diabetes should not be a healthcare provider approach. So as a single clinician, you really cannot do justice to your patient. You need to have a teamwork. Unless you have a team of educators and psychologists and psychiatrists and a clinician working on a patient, you really cannot do justice to the patient's outcome as far as the psychosocial issues are concerned. I've gone through a lot of literature and my slides are not sponsored slide by any pharma company. This is all my work, and whatever literature I've scanned, it shows that 14% of diabetes patients have a generalized anxiety disorder, 40% of them have got a single anxiety disorder, and type 2 patients, 20% of them suffer from erectile dysfunction. So a big chunk of them have got a pure psychiatric issue. It has got nothing to do with any kind of organic overlay that we are so used to discussing in our diabetes patient. In 2016, ADA actually took the initiative and issued a position statement, and they've given a series of guidelines. If you look at the algorithm of ADA, like you have an algorithm of drugs in diabetes, they've given a series of algorithms right from the inception of diabetes till the end-stage complications of diabetes, what all behavioral changes you should do in your patient as well as in yourself to address these issues. And if you follow that, it gives you a lot of eye-opening approach to your patient with diabetes. So I've discussed the Canadian approach, I've discussed the Pakistani approach, I've discussed the American approach, I've discussed the Dawn approach. What about India? Are we doing some work in India? Have we actually addressed this issue in India? Do we have diabetologists in India who have actually taken it seriously and have done some evidence-based structure? And I was really amazed. I really didn't expect any data from India, but I was amazed that these are the people, Sanjay Kalra, Prasanna Kumar, Rishi Shukla, Avasthi, Manish Barua, these are the big names in diabetes, and they have actually done a phenomenal work. They've done a huge chunk of observational data, and they've given some very eye-opening recommendations for doctors. And they have found that the approach of psychosocial issues in India is very different from the Western world. Remember, we are a diabetogenic prone population, we are a coronary prone population, we are a young diabetes population, and we are a diabetes complication prone population. And they found that the psychosocial impacts in India is because of economic factors, cultural factors, religious factors, and something very important they found is most of our patients hate modern medicine. That I was educated today morning, not allopathic medicine, but modern medicine, and people hate it. They love alternative group of medications. They love Babas and, Chamatkars and Google and all that. And that is one of the reasons why they develop psychosocial issues. So you cannot blame yourself for the outcome. And would you believe they've given 94 recommendations that you should be doing? I don't think we even do 2 recommendations in our own practice, right? So this is your own peer group, your own faculty in MAPICON, your own faculty in MAPICON who are telling you this, but we are not following it. And I'll just touch the top recommendations. The top recommendations are to improve your skills. How many of us actually re-educate ourselves to improve our skill? We come to conferences, we take a big chunk of theoretical knowledge, but how many of us actually practice it when we go back? That is the main thing. Do we do this SWOT analysis? Do we do this water analysis? And do we do this care analysis? What is SWOT, what is water, and what is care in diabetes? Water approaches, welcome your patient with warmth. Ask your patient, don't expect your patient to tell you, look boss, I've got hypoglycemia, I've got neuropathy, I cannot satisfy my wife. Which patient comes and tells you all that? Do you ask? You don't ask. Do you tell the truth to your patient, ki, boss, if you continue like this, you'll develop neuropathy down the road. If you continue like this, you'll develop early microalbumin urea down the road. And do you explain it with empathy? I hear in so many conferences, doctors don't have time. They're handled by their receptions, by their assistants, and they say, boss, insulin ka shot nahi loge na to mar jaoge. You better take insulin. Where is the empathy here? Patient tells you, I cannot take medicines, I cannot take my insulin shots on time. I remembered a very beautiful talk by Dr. Kalra, Dr. Parth from UK. He asked us, when do you give dulaglutide, the very costly GLP agonist, which is once a week? So we said, naturally, the rich and affording obese diabetes. He said, no, I give it to truck drivers. Why? Because it's once a week and they can afford to take it. Do you know truck drivers don't have time to take their medications? They don't have time to go to toilet. They don't have time to take their insulin. Here I give them once a week and I get much better outcomes. So this is a practical approach. This is an empathetic approach. Do we synchronize with our patients? Since I'm practicing in Mumbai, where I have Bollywood personalities and Hiranandani group of people, and they are like, their day starts in the night when America opens up, and they sleep in the day because they are with IT sector. We have call center guys who have no time. Their breakfast is at 6 p.m., their lunch is at 1 a.m., so their breakfast is in Paris, lunch is in London, and dinner is in India. And we have the real middle class people who can get 2 meals a day, and they eat only junk food because McDonald's and burger and fries are the norm in those areas, including the thelewalas and the fruit sellers. We feel that they don't eat that, they actually eat more than what we eat. So these are the people, do we have empathy for them? We don't have any empathy for them. Do we reassure our patients, ki, fine, you have not taken your drugs, you have not done your blood sugar, you have not done anything, but I am supporting you, I will not throw you out of my clinic. That is the water approach. The care approach, do we improve the awareness in our patients? And how many of us actually work for the community? Do we take programs for the community in our area? Do we take programs for the spouses and the family members for our patients? And do we think of a prescription which will help our patient with his lifestyle rather than I need to put a GLP, I need to put an insulin? Not like that. Do we have precision medicine which is patient-centered prescription and not doctor-centered prescription? What is the care approach? Do we appear confident to handle a tough patient? Do we appear authentic to handle his queries? Do we respect him for not doing anything and going for a second and third opinion? Are we reciprocating that? Do we express our empathy through ourselves and not through our assistants? And are we simple in our prescriptions? Don't we tell them, ki, boss, if you're taking a 200 rupees ka prescription, le lo, acha rahega. Can't we explain to them, ki, ye loge to aapko bahut zyada acha hoega? Are we down to earth with them or not? Then they recommended a lot of other therapies. They recommended a cognitive behavioral therapy. They recommended a motivational therapy. They recommended a family therapy. But very important that we really don't do problem-solving therapy. Our patient comes with 10 questions which we think are useless questions, but for him it's a problem. He can't take his insulin. He thinks the insulin is costly. He thinks the pens are costlier than the vials. We have cases where people take out the insulin from the pen, put it in the vial and give it. They don't know that pen is 100 units per ml, but the vial is 40 units per ml, and they'll land up in complications. Do we do a problem-solving approach or we don't do? I mean, you'll be surprised. They recommended a folk dance approach. They did a sexual dysfunction counseling. They recommend classes for discussing the eating habits. Do we actually ask our patient कि तुम कितना lunch में कितनी रोटियां खाते हो, उसमें घी कितना लगाते हो, दाल में कितनी चम्मच घी डालते हो? Do we do a psychiatric assessment? Do we study the family structure? Is the patient controlled by the wife or the wife is controlled by the husband, or both of them are controlled by the mother-in-law? We don't discuss that. Do we actually take into account their Ramadan fast, their Guruvar ka fast, their Jain ka fast, their this fast and that fast, and we are not aware that they are not taking their medicines? Most of the people are fasting twice a week. They eat veg on 3 days, they eat non-veg on 3 days. Are we aware of that? We are not aware of it. And we just pump in medicines, you know. Some people have a fastidity. These kind of foods will not lower blood sugar. These kind of foods will not increase blood sugar. They will not listen to you because somebody in the society on WhatsApp is educating them on diabetes food. Are we serious about listening to that? And how many of us have gone to schools and Rotary clubs and Line clubs and delivered talks on diabetes to encourage the community to understand, like Madam said, how many of us actually physically work for preventive aspect of diabetes outside our chamber? How many of us take our insulin pens outside the clinic? And how many of us actually think of affordability of our prescriptions? We don't think for it. How many of us actually screen for symptoms, not for therapy? So these are the psychological issues that we need to do. Now it's a busy slide, so quality of life, glucose control, self-management, and they have recommended that we do the screening of symptoms by PATE scale or whatever scale at different times. But do we do it on per visit? Do we do it when the medical status change? And सबसे very important, do we actually do a psychological analysis when he is admitted in the hospital? And when he comes out from the hospital, we don't waste our time, you know, in discussing issues with the patient after coming out from the hospital. And something very important, how many of us learn to share our patients? How many of us have referred our patients to a psychiatrist when we fail to educate those symptoms? If our patients have got neuropathy, retinopathy, and hypoglycemia, do we think we need a psychiatric help over here who can better manage this case than we can manage? We never do that. I've hardly seen a diabetologist taking help of a psychiatrist. And believe me, it works wonders when they put their finger on the patient comes back with zero hypoglycemia without you reducing the medications. So that is very important, you know, working as a team, working in an umbrella approach becomes very important. So referring to a mental health provider is the way they talk about it in the literature. So declining ability, cognitive impairment ability, self-care difficulties, serious mental illness, lot of anxiety of hypoglycemia. There are so many issues. How many of us refer to a bariatric surgeon, get a good return from the bariatric surgeon, we get a good weight reduction, but do you think patient deserves bariatric surgery? Don't you think a patient needs a psychiatric assessment before going for bariatric surgery? Who can explain the complications in a better way than the bariatric surgeon would never do? Something like that. So what they said is, in summarize, out of those 94 things that they recommend, they said, you should be really smart in managing your patients. Smart means you should not dress up like Amitabh Bachchan or Shah Rukh Khan, but you should be smart in your approach. You should be very specific. You should be very measurable in your approach. You should be achievable. So there's no point telling an 80-year-old senior citizen whose children are staying in US that your HbA1c should be 6.5. It is not possible. So leave him at 8, right? You tell a 17-year-old guy that your HbA1c should be 6.5. Again, not possible. Leave him at 7 to 7.2. So be realistic and give them a time that I want you to come back to me with that. Patients will never come and tell you, "Ki, boss, my sugar has gone down." So you need to ask your patient. Don't ask for low sugars, ask for performance issues. My work performance has gone down, my HR is not happy with me, my boss is degrading me, I'm not getting the kind of incentives and increments that I deserve. And people come with their CGM reports. You know, a lot of pharma companies are giving them CGM report, and a lot of CGMs are below 40 for 2 hours and 3 hours, and patient goes into depression. They do their own glucometer assessment, and they realize that the sugars are below 70, and the glucometer has never been calibrated, it has never been cleaned, it has never been washed, and we never bother to check the glucometer of the patient. We directly look into the diary and accept the values. So those are some of the issues in hypoglycemia that I've seen. Erectile dysfunction, the only thing that I ask for is, nobody will come and tell you I'm having a poor performance on bed. If the patient is infertile, if the patient has not had a family for 5 years, believe me, if the patient is having an affair, and not necessarily if the husband has an affair, even the wife has an affair, if you ask for history of affairs, you realize the performance in bed is poor. And you realize that there's a problem with diabetes over here. It has nothing to do with low sperm count or XYZ or some Hollywood movie teaching them how to perform on bed. You need to ask them, and if you come to them and you ask the spouse of the diabetes patient, you get such glaring answers, and I've been able to save 2 divorces because of that, you know. A simple counseling gives a lot of difference. CGM is a very wonderful tool. It takes away glycemic variability, which your HbA1c can never teach you. So if your HbA1c is 6.5 over 3 months and 6 months, it is the worst thing that I like. I hate fasting and post-lunch and HbA1c done once in 2 and 3 months because it doesn't teach you anything. You look at CGM, you realize there is so much of glycemic variability, a lot of medications can change, a lot of hypoglycemia can change, and there's a lot of fear of CGM in the public population. You need to tell them that you need to do your glucometer assessment and your CGM assessment on a structured basis. A random glucometer assessment is useless. We need to do a structured glucometer assessment to get a proper scenario. How many hours post-lunch, how many hours post-breakfast, how many hours post-dinner, etc. Insulin is a big thing. Everybody knows how difficult it is to write insulin. Literature is full of knowledge where doctors are more reluctant to write insulin than patients. Trust me, patients are not that diswilling. You're more diswilling because you don't want to lose your patient to your competitor. So insulin is something, there is a lot of inertia. People have got such wonderful questions about insulin, but who has the time to tell them? Who has the time to tell them to rotate their insulin? So I don't do that. Obviously, even I don't have so much of time. So I've written a blog full of pictures and scenarios and videos. I direct them to my blog, they read it, then they come back and then I give them a demo. It puts my patient on insulin. So my pharma companies tell me one thing, that you don't initiate, but when you initiate, your patients keep taking it. So what's not important is writing 400 prescriptions of Ribelsis or semaglutide or dulaglutide or some hi-fi exotic analog insulin. What is important is maintaining your patients on insulin. That's very important when it's required. Our patients are more knowledged because of WhatsApp University and Google Baba. It's a big pain in the neck for all of us. So I believe in lohe ko loha kaatta hai. So why aren't you active on WhatsApp and Google? What's preventing you? Yesterday we were having a talk when we went to Gurudwara with Dr. Gupta, and he said, why aren't we on WhatsApp and Google? Why only the young generation should be on that? Why are we not? Why the mobile is meant only to watch Netflix and Amazon India and all that? No. You can communicate with your patients in a very informal and formal manner. You can share a lot of authentic information, which because you're not sharing, somebody else is sharing. So I'll come to this slide a little later. What is important is this. Who's handling this? Nobody is handling this. Do you know how many social groups are there today? Do you know how many programs on diabetes support groups are being run by quacks, non-allopathic, non-qualified people? Tons and tons and hundreds. And if you think I'm talking through my nose, look at this. This is from today's morning Google search. This is being run by somebody who claims that diabetes can be reversed, and it's a non-modern medicine personality. Look at this. total reversal of diabetes by 100 rupees consultation or your money back. I don't mind returning 100 rupees, and I also know diabetes cannot be reversed in most of the cases. But here he's pulling in the crowd, giving a big talk and returning money, and who wants to return the money? So these groups are running on diabetes, handling the social issues of diabetes, because we are not handling it, you know. If I don't spend time with my wife, if she spends dinner with somebody else, who is supposed to be blamed? If my wife does not have time to cook food for me and I get cooked by somebody else, why should I be blamed? So ask yourself, are you giving time to your patients or no? If you're not, don't blame these programs. Look at these 3 programs running on your mobile. Take out your Google app, Google Play Store right now. Download all this. None of them are being run by any authentic medical personality. And you see the amount of money they make, which you can make, but you don't want to make, right? So coming back to a few slides. So what I want to say is, remember one thing, this is written in Bhagavad Gita, your thoughts create your feelings, right? What you think is what you feel. Your feelings convert to your behavior. I feel that I'm stressed, so I bite my nail. This is my behavior. And your behavior reinforces thought. I tell myself biting nail is a sign of intelligence, you know. Right? We have a very qualified psychiatrist here, so I don't want to cross my limit by talking too much. But the bottom line is, your thoughts create your universe. And it is said that the whole universe was created by the thought of the Lord, God. So you create your own ecosystem, your own practice, your own community, your own medical system, your whole country, because of the way we think. And if our health system has gone down, blame us, because we are not thinking rightly, right? Time doctor. We are very timed, you know. I've got 10 consultations pending. I have to make X amount of money. Who cares if I don't give time to my patients? So those patients eventually get snatched from us, and then we crib. Why? Because of this, right? So coming to this, become part of the program. The days are gone when you can practice single-handedly alone. You need to be in an umbrella. So there are a lot of accelerator programs and support programs run by qualified people, including Hinduja Hospital and other hospitals in your area. I am part of this program called Fit to Fly Diabetes Program. I'm not an employee, but this is being run by many qualified people. I refer my patients over there. It's a vertical program. It's an online program run for 3 to 6 months with their qualified physiotherapists, diabetes educators, and psychiatrists and counselors. And they do a wonderful job, and we have published papers where we have reduced the HbA1c by 1.5 to 2 in 3 months without bumping up the medications. So this is run by qualified people, and the novel way to treat diabetes is through social media. I would tell people to get woken up, wake up, dear colleagues, and enlighten social media and embrace social media, because that is a way to go to handle many things. And this is a paper published by me this year in 2022 in ADA, where we showed that video call assessment of our patient for physical fitness and diabetes psychological overlay could produce results that even a gym trainer could not produce. You remember people are dying in gyms today? How many celebrities are dying in gyms? Because we are not there, no? So learn to be there. So learn to be in conferences, learn to be in your clinic, and learn to be outside the clinic. Get your mental of a doctor and behave like a doctor outside on the clinic. Become a doctor on the mobile and see the wonderful results. I give a lot of talk shows on televisions, on Facebooks. I was a member in NDTV 24/7 where I covered a lot of myths in diabetes, and we had some 10,000 to 20,000 people watching this program. So moral of the story is, if you want to take care of psychological issues in diabetes, get out of insulin, get out of GLP agonists, get out of SGLT2 inhibitors, get out of conferences, talk to your patient, hug your patient, embrace your patient in an empathetic manner, and interact with your patient. Let it be a two-way dialogue. So there should be support groups, there should be counseling groups, and learn to share your practice with your colleagues. Don't be selfish. Get colleagues involved with you. It saves you legally, medico-legally, ethically, morally, and many other ways. And the moral of the story is, get out of the conferences and outside and talk, and generate a huge amount of practice. And believe me, that is the way to go. So I put up like this, raise your hands, become a part of a community group, run a community, and get rid of your patients' issues. And believe me, it is much more rewarding financially and career-wise. Thank you very much for this opportunity. And I hope I could deliver some hard messages here. Pardon me if I have crossed the line somewhere, and I'm open to question and suggestions. Thank you very much.
Thank you, Dr. Modi, very much. You see, an excellent talk.
Thank you,
And
sir.
I must appreciate this thing. You see, very close to my heart for the simple reason. You see, for the last 40 years, I'm only telling everybody that we must spend time with the patient. I think that is the biggest drawback with our community, that we don't spend too much time with the patient. That's why we have all these sort of problems what we are facing today. I say any chronic illness for that matter, diabetes again is a chronic illness, a lifelong illness, will have its own psychological problem, you see, like most of the chronic conditions are. So you have very well nicely explained everything. And I mean, 20 years ago, if I have to tell 10 patients to take insulin, and even if one patient gets insulin, I was more than happy, you see, that I'm satisfied.
Right,
But
sir.
today, probably the things have changed with the awareness, with everything. Probably maybe out of 10, maybe 4 or 5. In your practice, maybe 10 out of 10 people may be taking insulin.
Right, sir, absolutely. I'll just share this with you. I am in the medical legal cell of our Association of Medical Consultants. You must have heard of AMC back in Mumbai. It's a big organization. Unlike IMA, it has got only qualified postgraduate people in the organization. Dr. Lalit Kapoor is heading it, and I'm also part of the High Court committee for that. And I handle the medical legal issues in my area. And Kapoor sir has sought something which I found very practical in my own practice. Either you spend half an hour with a patient or spend 10 years in court, you choose what you want. And that little 10 minutes of time spending, body language, more than talking, it's your body language. That empathetic behavior with your patients and their relatives fetches you much more brownie points, gives you hardcore patients who become loyal to you, and they become real brand ambassadors for you when they go outside. And it takes care of a much more, help. And I'm telling you, with madam, I'm sharing this with you, I am very much comfortable and free to tell my patients to go and see the psychiatrist. I mean, I cannot handle, you just don't want to take insulin, you're getting repeated hypos with your non-modern medicines. I cannot do a better job than this. I don't have the tools and the kind of body language that I need to give. Let her or him handle it, and I get a very energetic patient back to me. I don't lose my patient. I don't mind sharing my patients with a senior for a second opinion. I learn much more from my practice. So I've realized one thing which they say is very true. Unless we come out as a community, unless we show unity in the outside world, and unless we actually join hands and support each other, we really can't be successful. Otherwise, the days are not far when we would be eaten up by these non-medical MBAs and administrators and commercial people who are responsible for our downfall today. So I totally agree with you, sir. And thanks for your kind words, sir.
Thank you. Any question from the audience, please? That means they have understood it very well. Thank you.
Thank you. Or maybe I put them to sleep. Thank you, Vitul sir, once again for this opportunity. Thanks all of you. Thank you, sir. Bye-bye.
Thank you, Dr. Alok, for coming all the way from Mumbai and delivering the guest lecture. Thank you very much. Now I invite Dr. Usha Goel. She is going to communicate an important message. And I invite Dr. Keval Krishan also to come on stage to get his organizing committee certificate from Dr. Usha Goel.
Sorry for the interruption. इसे कहते हैं रुकावट के लिए खेद है. दूरदर्शन पे आता था. I think I missed the opportunity. I was reluctant when the hall was full. I just wanted to pass a few messages which have been which are being delivered by the FSSI. I mean, I told him next year. I was sitting there, then I decided why next year? Why not now? Just a few things. Just know what you are eating. The first message is read and know the food you are eating. Read the labels, please. Please read the labels, that is a request. Even I never used to read the labels till 31st December 2020. I was not reading the labels. Now I have known the importance of labels. It's a lunch break, everybody enjoying food, but once you are enjoying food, you should know what is going inside. कहते हैं ना जो पेट में जाता है पता तो हो, it's not a dustbin, it's not a garbage bin. I mean, anything lying in front of you, you eat, put it in your mouth and goes. Read the labels, read the ingredients. Please read the best befores written. That is very essential. I never knew the importance of the date of expiry of the food items. I knew about the medicines, yes. Being a doctor and a surgical specialist myself, I was very well aware of all these things. But as far as food was concerned, I was not aware. Please read the best before or the date of expiry. That really has importance. Because, you know, the last 2 days we were out. This is a hectic year because 2 years went into COVID, there were restrictions, we didn't have functions, we were not allowed for gatherings, and there was a fear also. COVID was something which we really feared about, कि जैसे कुछ वहाँ उड़ के ना अपने से चिपक जाएगा. I mean, we'll all be COVID positive. And now it is the other way around. If the government says put masks on, we are not doing it. That is a different issue. People are saying adulterated hai khana. Who is doing it? When I go out to the halwais, the mithai walas, the bakeries, you know what they tell me? Madam, demand hai bright colored products ki. We are crying hoarse since last year. Don't buy pink colored sweets and anything which is pink colored. Pink colored is totally banned. Then they tell me sundar lagta hai. I mean, everything which looks beautiful need not be bought. And if it cannot be bought, that it cannot be put into your mouth and into your GI system, no? Then we say, doctor ne treatment theek nahi kiya. We being doctors, if we can pass on this message to our family members, our children, our grandchildren, our patients, please ask them, don't eat bright colored food items. No pink colored rasgulla, chamcham, बहुत सुंदर लगते हैं. Pink colored is the most attractive color as far as rasgulla and chamcham is concerned. I agree. Even I used to have it long time back. Please don't take it. Good, जो अपने as far as Bathinda is concerned, जो अच्छे मिठाई वाले हैं, they are not making it. They are not. Last year we destroyed tons and tons, quintals and quintals of rasgulle and chamcham pink colored. I mean, because we are supposed to do it. We are supposed to do it. But how much can we destroy? We can't be everywhere. So it is demand and supply. If you demand bright colored things, the supplier will give you all those things. Read the labels. Don't go for bright colored things. Please, that's a request. Another, fast food. You don't know what MACD is serving you. You go get a burger. Starting from somewhere around, I even don't know the rates because I don't eat them. And that's an honest confession. I don't. Starting from somewhere 50 rupees to 250, maybe 300. Does anybody know what that burger contains or the processed cheese slice contains? Nobody knows anything. Please don't. Once in a while, it's fine. You can have it. Don't make it a routine for your children because it is easy to eat. I mean, you just order it online, it is delivered home, and the child just eats it. Don't do that. Another thing is soft drinks. Sir, Dr. Modi was talking about diabetes. All doctors are taking the aerated, carbonated drinks. You know how people in the society who are non-medicos, there's a group which is going around advocating not to take these aerated drinks. वो कहते हैं ये carbonated drinks हैं. To a layman, this is how they explained. I really like the idea. Carbonated is उसमें carbon dioxide होता है. और जब हम सांस लेते हैं तो ऑक्सीजन अंदर लेते हैं और कार्बन डाइऑक्साइड छोड़ते हैं. It's true. I think that thought never came up to many of us. They said if carbon dioxide, God made, ईश्वर ने शरीर बनाया कि कार्बन डाइऑक्साइड शरीर से बाहर जाएगा, तो हम कार्बोनेटेड ड्रिंक कैसे लेते हैं? I mean, we eat fried we eat anything spicy, and the most commonest sentence that I hear is, oh, कोक ला देना, पेप्सी ला देना, इससे नीचे हो जाएगा खाना. कैसे हो जाएगा खाना? I mean, you must be thinking, she is now food safety in charge and she's talking. I have never liked these carbonated drinks since childhood, and I don't take them. And people think कि मैडम शायद नाराज है जब हम फील्ड में जाते हैं इसलिए हमारा पी नहीं रहे हैं. तो I don't, because I don't have a taste. Please don't taste. Sugar is another thing. People will not understand if you tell them इसमें इतने चम्मच sugar है 200 ml में. Please tell them the simple language कि ईश्वर ने, भगवान ने शरीर बनाया, ऑक्सीजन लेते हैं, कार्बन डाइऑक्साइड बाहर छोड़ता है शरीर. तो आप एक कार्बोनेटेड ड्रिंक को क्यों पिएंगे? There are many groups going around, at least in Bathinda I have come to know so many groups, they are advocating these things. Read your labels, check the expiry, check the batch number. Last and the most important, nakli desi ghee, that is the in thing. Please, if you are buying desi ghee, get it from a reputed vendor. Number one. Number two, सबसे controversial है, हम लोग लेते नहीं हैं. एक पक्का बिल ले लीजिएगा. जो भी चीज डुप्लीकेट होगी उसका आपको एक पक्का बिल जो कहते हैं ना वो नहीं मिलेगा. He will just scribble on a paper and give you. Don't take that, please. Don't do that, because any brand, good brand desi ghee you are buying from a authorized outlet, you will never get something duplicate, synthetic, adulterated. It is going to be pure. Because all packets of all multinational companies are produced in Delhi in one of the markets. They come here in Bathinda. I know where they are. You can pack any desi ghee and any brand, name it Verka, name it Nestle, name it Mother Dairy, anything. You can get any masala also. They get the wrappers. I mean, surprisingly, the FSSI license number is also printed. I mean, to that extent, things are going on. They get the wrappers, and then the shopkeeper tells me, Madam, sare kar diye ji Bathinda ch. I'm not the only one who is doing it. Till last month, we were educating the shopkeepers. I've given a press routing and I've told them now, wherever we are finding these products, we are seizing them. We are picking up the products. But problem is the demand. We have to break that demand and supply chain. Supply chain will be only broken if we don't demand these things. Please check the batch number, check the date of packaging date or the manufacture date. The best before, last is the address of the manufacturer. That is mandatory on every packaged food. Please, any packet which does not bear the address, most probably it is from where even we don't know. At times even we don't know from where it is coming from, because वो ऐसे ही आ रहा होता है. Please don't do that. Keep healthy, stay safe. I mean, that was the only message I wanted to say. Similarly for oils, the government can't do everything and anything. I mean, the enforcement agencies can't do it. We were out yesterday till late evening, day before I was not supposed to come here, but I had a personal message from Dr. Vitul, and I just couldn't, I just got up at 10 o'clock, I got ready, I said, now I have to go, because I saw that WhatsApp quite late. I came here, I missed the opportunity when the hall was full, the director, Ames, was sitting here. Please educate your children, your grandchildren. Stay healthy, and this year is going to be really what people say, I don't know what, let's see how much we can catch hold of. We made a seizure about 10 days back. We have done it. But I don't know how many we can do it. If you have information, please pass it on to us. We will go, we will seal the premises, take samples, send them to the food lab, because that is what we can do. Don't post videos on the social media that the department doesn't do anything. You also are responsible citizens of the society. समाज सुधरता है जब हम सुधरते हैं. दूसरे के सुधरने से समाज नहीं सुधरता. पहले मेरे को सुधरना होगा. So with that I end. Please eat healthy, eat safe. Third we'll discuss later on, that is eat sustainable. Thank you. And sorry for taking your time. Thank you.
For our next guest lecture, I would like to invite Dr. Preeti Singh Dhoot, HOD, Department of Medicine, AIMS Bathinda, who will be presenting on the topic New Revolutions in Lipid Management.
Good afternoon, everyone. I thank the organizing team of MAPICON for giving me opportunity to be here. And I would like to talk about the new revolutions in lipid management. So I'll be talking about the new revolutions in lipid management and approaching a patient of dyslipidemia. So I will be discussing it under the following headings: the baseline lipid profile, total cardiovascular risk assessment, establishing indications for drug therapy, defining the treatment goals, and prescribing anti-dyslipidemic drugs, follow-up and monitoring of the adverse effects. So step 1, to approach a patient of dyslipidemia, we measure the baseline lipids and lipoproteins. So baseline lipid profile, there is always a confusion, fasting or non-fasting. So traditionally, fasting lipid profile has been recommended, but recent systematic studies comparing fasting and non-fasting samples have shown that non-fasting samples display a triglyceride level higher by around 27 milligram deciliter. So this increment will be of no clinical significance. For general risk screening, non-fasting samples seem to have at least same prognostic values as fasting samples. But the only practical advantage of non-fasting samples is better patient acceptability, overweight the potential imprecision in some patients. So what all do we measure? We measure the total cholesterol, we measure the high-density lipoproteins, the low-density lipoproteins, the triglycerides, the non-HDL-C, especially in patients with high triglyceride, diabetes, obese, patients of metabolic syndrome, and very low density lipoprotein C. ApoB we have to measure, especially again in patients with high triglycerides, diabetes, obese, metabolic syndrome, and very low LDL-C patients. Then lipoprotein A should at least be done once in the lifetime of every adult. Now, commonly derived formula that we use for LDL-C is the Friedel-Wald formula. But there are many limitations to this formula, so methodological errors accumulate since this formula necessitates 3 separate analyses of HDL, TG, and TC. With high triglycerides values, more than 400, this becomes inaccurate. So to overcome these problems, direct enzymatic methods for estimation of low-density lipoprotein C have been developed. So once we have acquired the fasting or the lipid profile of the patient, our next step is to calculate the total cardiovascular risk assessment. So there are various models that are available for the cardiovascular risk assessments. A number of models are available. Among the various models, the most commonly used is the American College of Cardiology, American Heart Association, atherosclerotic cardiovascular disease, that is the ASCVD risk calculator. And the second most that can also be equally used is the systemic coronary risk estimation score. We have another scoring system like the Framingham risk score, coronary artery disease, then the cardiovascular disease, the Q-RISK-2, Joint British Society risk calculator, and the WSO risk charts. So among these various calculators, the ACV-CD score and this score system can be easily utilized by us. So coming to the systemic coronary risk estimation, or the score. So it is a tool for cardiovascular risk estimation by the European Society of Cardiology for defining the CV risk in apparently healthy individuals. Persons with the following comorbidities are already at high CV risk, and no risk estimation models are needed for such persons, and we have to straight away initiate the therapy. So documented prior ASCVD or diabetes mellitus type 1, type 2, patients of chronic kidney disease, patients of familial hypocholesterolemia, very high levels of individual risk factors like cholesterol, LDL-C, and blood pressure. In these particular group of patients, there is no need to calculate the risk score by any of the scoring systems, and we have to initiate the therapy as soon as the patient visits us. So the total CV risk assessment according to the SCORE model, calculated score less than 1% for 10 years, the risk is very low for a fatal CVD. The moderate risk is more than 1 and less than 5 for 10 years risk for a fatal CVD. Young patients, type 1 diabetes less than 35 years, type 2 diabetes less than 50 years, duration less than 10 years without any risk factors fall under the moderate risk category. Then we have patients who fall in the high risk. Total cholesterol more than 310 milligram deciliter, LDL-C more than 190 milligram deciliter. If the BP remains above or equal to 180 by 100 milligram of mercury, patients with familial hypocholesterolemia without other major risk factors, or diabetes more than equal to 10 years duration with without any target end organ damage, CKD stage 3, or the scoring system shows a score above 5% and less than 10%. It wasn't moving. So score more than 5% and less than 10% for a 10-year risk of fatal CVD. These all fall under the high-risk categories. Now, very high-risk patients. Who are the very high-risk patients for initiation of dyslipidemia according to the SCORE system? So they should be a documented ASCVD clinically, previous ACS, stable angina, previous coronary revascularization, stroke, or TIA, peripheral arterial disease, unequivocal ASCVD on imaging, plaques on coronary angiography or CTCA, plaques on carotid ultrasound. These are very high-risk patients in which we have to initiate the therapy. Diabetes mellitus with target end organ damage with microalbuminuria or type 1 diabetes of long duration more than equal to 20 years. CKD stage 4-5, familial hypercholesterolemia with major risk factors, or a score above than or equal to 10% for 10-year risk of fatal CVD. So now there are two main scoring systems, as I told you. One is the SCORE, and other which we can commonly use is the ASCVD risk calculator. So what is the comparison between these two scoring systems? The SCORE is based on studies on European population, and the parameters include age, sex, systolic BP, total cholesterol, smoking, baseline CV based on epidemiology. Whereas the ASCVD score, the parameters included are age, sex, race, blood pressure, total cholesterol, HDL-C, LDL-C, diabetes, smoking, on treatment for hypertension, statin, or on aspirin therapy. So Indian scenario, coming to the Indian scenario, Indian population has a very different pattern of dyslipidemia. There is high triglyceride levels, low HDL-C levels, normal or modestly raised LDL-C levels. So the 10-year CV risk score calculator do not behave the same as in the Western population. So recent study comparing the different CV risk calculators for predicting risk and guiding statin use in Indian population Risk calculators fared inferiorly to most other commonly used CV risk calculators. CV risk calculators based on data from Indian population, though desirable, is not available as yet. Till then, we can easily use the score system or the ASCVD risk calculator. Now, after we have acquired the lipid profile of the patient and we have made the risk assessment for dyslipidemia, our third step is indication for initiating the drug therapy in dyslipidemia. So according to the score system, whenever we are treating dyslipidemia, there are two modalities. One is the primary prevention and second is the secondary prevention. So in the primary prevention, it is seen that if the risk is very low, low risk, less than 1%, but if the untreated LDL-C levels are more than 190 milligram deciliter, lifestyle intervention and concomitant drug intervention as I was discussing, according to the score system, if there is untreated LDL-C levels more than equal to 190 milligram deciliter, even if the scoring risk is less than 1%, we have to start the lifestyle intervention and the concomitant drug intervention has to be done. Again, if the score is between 1 to 5, and LDL-C untreated is more than 190 milligram deciliter, so lifestyle intervention and concomitant drug intervention has to be initiated. If the score is between 5 to 10, and the LDL levels are between 100 to 116 milligram deciliter, we have to initiate the treatment, lifestyle intervention, and concomitant drug intervention has to be initiated. If the score is more than 10 or at very high risk, if the score is if the untreated LDL-C levels are from 70 to 100 milligram deciliter, we have to initiate the treatment and educate the patient about the lifestyle intervention. Now, in secondary prevention, if there is very high risk, and the score, if the patient falls into a very high risk and LDL levels are 55 to 70 milligram deciliter, then again onwards, from that onwards, we have to educate the patient about lifestyle intervention and concomitant drug intervention. So indications for initiating, that was the scoring system. I told you there are those two scoring systems and both of them have different guidelines. So indications for initiating the drug therapy according to the American Cardiac Society and AHA guidelines. So we can start high-intensity statins as primary prevention if the LDL-C level is more than 190 milligram deciliter, age is between 40 to 75 years, LDL-C 70 to 189 milligram deciliter without diabetes, and an ASCVD risk is more than or equal to 20%. And for secondary prevention, as I already discussed, the ASCVD should be more than or equal to 20%, or the ASCVD risk is less than or equal to 20%, and age is less than 75 years. And when to start the moderate intensity statins? According to this, if the diabetes mellitus, primary prevention can be done in those having diabetes mellitus, age 40 to 75 years, LDL-C 70 to 185 milligram deciliter without diabetes, and an ASCVD risk more than equal to 7.5% and less than 20%. Or if the age is between 40 to 75 years, the LDL-C is 70 to 189 milligram deciliter without diabetes, and ASCVD risk more than or equal to 5% and less than 7.5. And secondary prevention, if the ASCVD risk is less than or equal to 20% and the age is more than 75 years. As I've already discussed, most of the primary prevention, if there is no risk assessment and LDL-C is more than 190 milligram per deciliter, they come in class 1, high-intensity statins can be started. If there is diabetes mellitus and age 40 to 75 years, they fall under the category of class 1 again, moderate intensity statins can be started. Then diabetes mellitus, age 40 to 75 years, risk assessment to consider high-intensity statin, they fall in the class 2A. And age is more than 75 years, clinical assessment and risk discussion is required. So what are the ASCVD risk enhancers? There are certain risk enhancers which increase the risk. We should always take care of such patients when they present to us. familial history of premature ASCVD, or persistently elevated LDL-C more than 160 milligram per deciliter, chronic kidney disease, patients of metabolic syndrome, conditions specific to women, example, preeclampsia, premature menopause, inflammatory diseases, especially rheumatoid arthritis, psoriasis, HIV, and South Asian ancestry. The lipid biomarkers, if the persistently elevated triglyceride levels more than 175 milligram deciliter. In selected individuals, special individuals, if measured, HSCRP more than 2 milligram per liter, lipoprotein A levels more than 50 milligram per deciliter, ApoB more than 130 milligram per deciliter, and ankle brachial index less than 0.9. So this chart again explains the primary prevention according to the ASVD risk in each age group. Now, coming to the secondary prevention, clinical ASCVD, if the patient has healthy lifestyle but very high risk ASCVD, high intensity or maximal statins have to be considered. If the patient is on maximum statins and LDL-C more than 70 milligram per deciliter, adding ezetimibe is reasonable. If PCSK9-1 is considered, add ezetimibe to maximum statin before adding PCSK9-1. And dashed arrow indicates RCT supported efficacy but is less cost effective. And if the ASCVD is not very high risk, ages less than 75 years, high intensity statins can be started. Goal is to decrease the LDL-C levels more than or equal to 50%. And if the age is more than 75 years, initiation of moderate or high intensity statin is reasonable, and continuation of high intensity statin is reasonable. So more important thing is the comparison between these two. So in the ECS EAS 2019, high potency statin at highest tolerable dose has been advised to start treatment. If on maximum statin therapy targets are not achieved, ezetimibe and PCSK9 inhibitors may be added. And treatment goals, which I'll be discussing later, they have been defined clearly. According to the ACC and the AHA update, scope for moderate intensity statin and high intensity statins based on ASCVD score and other risk factors. If on maximum statin therapy targets are not achieved, ezetimibe and PCSK9 inhibitors may be added. Treatment goals again have been clearly defined. So now we know how to initiate and what are the our target limits for starting the treatment. Step 4 is defining the treatment goals. So the treatment goal should be, there should be no exposure to tobacco in any form, healthy diet low in saturated fats with a focus on whole grain products, vegetables, fruits, and fish. There should be adequate physical activity, 3.5 to 7 hours, moderately vigorous physical activity per week, or 30 to 60 minutes most days. BMI 20 to 25 kilogram per meter square, and waist circumference less than 94 centimeter in men and less than 80 centimeter in women should be the target. And the blood pressure control should be less than 140/90. So what are our targets? So the LDL-C in very high risk group, there should be a 50% reduction from the baseline. In very high groups, non-HDL-C should be less than 85 milligram per deciliter. ApoB should be less than 65 milligram per deciliter. In the high risk group, again, LDL-C has to be more than 50% reduction from the baseline. Non-HDL-C should be less than 100, and ApoB should be less than 80. In the moderate risk, LDL-C should be less than 100 milligram per deciliter, non-HDL-C less than 130 milligram per deciliter, and ApoB less than 100 milligram per deciliter. And in the low risk, LDL-C has to be kept less than 116 milligram per deciliter. And there are no goal levels for triglyceride, but less than 150 milligram per deciliter indicate low risk. If there is a higher levels indicate if there is other risk factors or enhancers are present. So this is again what I discussed about the low, moderate, high, and very high treatment goals. So next step is step 5, prescribing the anti-dyslipidemic drugs. So high risk ASCVD, I have already actually explained earlier, but in short, if the LDL-C is more than 70 milligram per milligram deciliter, then we continue, and if on treatment it becomes less than 70, we continue the statins. If it is more than or equal to 70 milligram per deciliter, we add ezetimibe. And if it is on treatment, it comes less than 70 milligram per deciliter, we continue the statin and add ezetimibe. Now, if it is LDL-C is more than 70 milligram per deciliter, and then close physician-patient discussion, cost-benefit, adherence for sharing decision-making has to be done. PCSK9 inhibitors are recommended. LDL-C goal 25 to 50 milligram deciliter, or at least 50% reduction from baseline is recommended. And down titrate the therapy if LDL-C is less than 25 milligram per deciliter on 2 occasions. Now, coming to the drugs, the statins. So the mechanism of action is competitive inhibition of HMG coenzyme A reductase. And the effect on lipids, LDL reduction, high intensity statins is more than 50%, moderate intensity statins is 30 to 50%, triglyceride reduction is around 10 to 20%, and HDL elevation is around 1 to 10% elevation. So what are the high intensity? We have the atorvastatins, the rosuvastatins, and the moderate intensity statins are the atorvastatins, the rosuvastatins, the simvastatin, pravastatin, lovastatin, and the fluvastatin, and the pitavastatins. So effect on cardiovascular morbidity and mortality. The cholesterol treatment trial list CTT meta-analysis in which more than 170,000 patients participated in 26 RCTs of statin versus control. High intensity versus moderate intensity statins were included. And for each 1 millimole per liter or 38.7 milligram deciliter, it was found reduction in LDL-C, reduction in major coronary events by 23%, coronary artery death by 20%, total stroke by 17%, total mortality by 10%, and reduction in the major vascular events like MI, CID-related death, coronary revascularization, stroke by 22% over 5 years. So now as we are all aware of these things, statins have adverse effects, so we have to be very careful about the adverse effects of statins when we are initiating the treatment. Most common adverse effect is on muscles and clinically most significant. Statin-associated muscle symptoms, there are the statin-associated muscle symptoms, then there are adverse effects on the liver. Progression to liver failure, though, is extremely rare. But routine monitoring of ALT during statin therapy is not recommended because liver failure, because of it, is almost rare. Mild elevation of ALT, less than 3 times upper limit of normal, occurs in 0.5 to 2% of patients on statin therapy. So clinically relevant ALT elevation has to be defined as an increase of ALT more than 3 times of upper normal limit on 2 consecutive occasions. Then there is increased risk of dysglycemia and new onset of diabetes mellitus. There is increased risk of hemorrhagic stroke, however, there is conflicting data. Transient proteinuria can be seen in statin therapy. Drug interaction is seen in all statins undergoing hepatic metabolism. Pravastatin, rosuvastatin, and pitavastatin don't undergo hepatic metabolism, hence fewer drug reactions are seen. Now this is very important, statin-associated muscle symptoms. So what we have to do, we have to monitor the creatine kinase levels. Pre-treatment is that baseline CK levels have to be recorded. If the baseline CK is more than 4 times upper limit of normal, do not start the treatment. Recheck the CK, look for the cause of elevation. Monitoring has been to be done. Routine monitoring of CK is not necessary. Check creatinine kinase if patient develops myalgias. So if it is more than 10 times upper limit of normal, we have to stop the statins, check the kidney function, monitor every 2 weeks. If it is 4 to 10 times upper limit of normal, we have to check for the symptoms, stop the statins, monitor every 2 weeks. If there are no symptoms, continue therapy, monitor CK routinely between 2 to 6 weeks. And if it is less than 4 times upper limit of normal, no symptoms, continue the statin. Symptoms present, continue the statins, monitor symptoms and CK levels every 2 to 6 weeks. Symptoms persist, stop the statin, reevaluate symptoms after 6 weeks, and reevaluation indication for statins. Now coming to ezetimibe. As we all know, ezetimibe inhibits the intestinal uptake of dietary and biliary cholesterol at the level of brush border of the intestine. The liver reacts by upregulating the LDL receptor expression, which in turn leads to the increased clearance of LDL, cholesterol from the blood. So recommended doses, 10 milligram per day in morning, evening, irrespective of the meals. No dose modification is required in mild hepatic impairment or mild to severe renal impairment. Clinical effects of lipids are significant. Monotherapy at 10 milligram per day reduces LDL-C in patients by 15 to 22%. Ezetimibe added to statin therapy reduces LDL-C levels by additional 21 to 27%. Adverse effects, life-threatening liver failure is extremely rare in the ezetimibe-statin combination. Ezetimibe-statin combination does not appear to increase its incidence as well of elevated CK beyond levels which is noted with statin therapy alone. Now, effect on cardiovascular morbidity and mortality. The ezetimibe was added to improve IT trial, was added to simvastatin in patients after ACS. The average LDL-C during the study was 70 milligram per deciliter in the simvastatin group versus 55 milligram per deciliter in the simvastatin and the ezetimibe group. So there were 2% fewer incidents of cardiovascular event, 32.7% versus 34.7%, and 21% decrease in ischemic stroke as recorded in the group taking simvastatin and ezetimibe. Ezetimibe should be used as a second-line therapy in association with statins when the therapeutic goals are not achieved with the maximum tolerated statin dose, and in which it has to be used in those cases in which statin cannot be prescribed. Then there's the various trials have been done. There's the SEAS trial, then there's the SHARP trial. So the take-home message is that when dyslipidemia is not controlled on statins, ezetimibe can be added. So coming to the PCSK9 inhibitors, as we all know, mechanism of action is low levels of circulating PCSK results in increased expression of LDLRs at the cell surface and increase in the LDL-C scavenging. Statins have been shown to have a synergistic effect on PCSK9 inhibitor therapy. So effects on the lipids have been seen. LDL-C reduction by an average of 60% depending on dose. Receptor deficient HoFH responds poorly to this therapy. Triglyceride and high-density lipoprotein reduction in TG level 26% and rise in HDL-C levels 9%, lipoprotein A reduction by 30 to 40%. So recommended doses, evolizumab 140 milligram every 2 weeks or 420 milligram monthly subcutaneously, and elirosumab 75 milligram every 2 weeks or 300 milligram monthly subcutaneously. If adequate response is not achieved by this, may increase the dose regimen to 150 milligram every 2 weeks. Now, dose modification required for this. Renal impairment, no dose adjustment is necessary for evolizumab. Studies are not available for severe renal impairment for elirosumab. Hepatic impairment, safe in child class A and B. Studies for child class C are not available. And the side effect of these drugs are itching at the site of injection, since these are injectable drugs, flu-like symptoms, neurocognitive effects. However, safety has only been established in 3 major trials, and data on the efficacy is still less. So effects of cardiovascular morbidity and mortality, the 2 major trials, the Fourier trials and the Odyssey trial. So the Fourier trial for evolizumab, 27,564 patients with atherosclerotic CVD and LDL-C levels more than equal to 70 milligram per deciliter were included. And evolizumab reduced median LDL-C from 92 milligram deciliter at baseline to 30 milligram deciliter at 48 weeks. After a follow-up of 2.2 years, evolizumab treatment significantly reduced the risk of MI, stroke, hospitalization for unstable angina, or coronary revascularization for 15%. However, evolizumab did not reduce the risk of CV mortality or all-cause mortality. Now coming to the Odyssey trial, elorosumab, 18,924 patients after hospitalization for acute coronary syndromes were treated with statins, and with LDL-C more than or equal to 70 milligram deciliter, they were included in this study. Elirosumab reduced mean LDL-C from 92 milligram deciliter at baseline to 30 milligram deciliter at 12 months. After a follow-up of around 2.8 years, elorosumab treatment significantly reduced the risk of non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization by 15%. Did not reduce CV mortality. However, significant reduction was seen in all-cause mortality. So, monitoring lipids. Before starting treatment, at least 2 measurements at an interval of 1 to 12 weeks is required, except in conditions where prompt treatment is warranted, like acute coronary syndrome. And after starting treatment at 8 to 12 weeks after adjusting dose, and once targets are achieved, we have to monitor the patient annually. Indian scenario, how is it different? We are talking about the Western risk calculators. We are talking about the Western guidelines. There is a different pattern of dyslipidemia in India. It is more of atherogenic dyslipidemia with high triglycerides, low HDL-C levels, and almost normal LDL-C. Early onset CAD 1 decade earlier than the Western population, and rising incidence of obesity, diabetes, and metabolic syndrome. So what is needed for Indians? LDL-C should be a primary target of therapy. LDL-C reduction to a low level is essential to achieve the desired reduction of CV risk. LDL-C levels less than 50 milligram per deciliter is safe. Indians respond quickly to moderate dose statins. Therefore, moderate dose statin with titration to high dose may be the correct approach for Indian subjects. However, they are just observations. These are just observations, and these can be followed in a clinical practice. These are observations from few studies, and data from a larger sample is required to gather enough evidence to make this approach universally applicable to Indians. Now, non-HDL-C, which we calculate as a total cholesterol minus HDL, includes all atherogenic lipoproteins. Accurate predictor of CV risk, particularly in patients with elevated TG and those already on statin therapy. Non-HDL-C should be kept less than or equal to LDL minus C plus 30 milligram per deciliter. Statins are the first line for lowering the non-HDL-C. HDL-C, low HDL-C is an independent risk factor for CV risk. However, there is still lack of evidence that raising HDL-C will reduce the CV risk. Hence, HDL-C is not recommended as a target of therapy. Should we target triglycerides? PROVE-IT TIMI-22 trial conducted in acute coronary syndrome patients stressed the role of high triglycerides as a risk factor after reaching LDL-C goal of 70 milligram per deciliter. People who had triglycerides more than 200 milligram per deciliter had a higher CV risk of sudden cardiac death and fatal and non-fatal MI. Meta-analysis of 5 landmark trials with 7,389 patients with diabetes and CVD concluded that lowering triglyceride in people with elevated levels using fibrates reduces CV event by 25%. So the triglycerides should be kept less than 150 milligram per deciliter. So these are the case scenarios. I think I can skip them. So what are the take-home messages? Don't wait to start statin therapy until after a patient at intermediate risk has had a CV event. The 10-year ACC-AHA risk estimator alone could underestimate an individual patient's CV risk. Patient at intermediate risk with unremarkable lipid profile but risk-enhancing factors commonly fall through the cracks for ASCVD prevention. Be cognizant of statins metabolized by CVP3A4, that is the lovastatin, simvastatin, atorvastatin, and the potential for major DIs and significant statin-related adverse events, especially in HIV patients. Engaging the patient in steered decision-making is helpful in patients who feel fine, but are at increased CV risk or have experienced a statin-related adverse effect and resist statin therapy. So that was all, in short, I tried to cover regarding the approach to dyslipidemia. Thank you, everyone.
Thank you, Dr. Preeti, for a nice and elaborate talk. You could combine, in 20-25 minutes. Excellent talk. And thank you very much for accepting our invitation. And I think with AIMS faculty, the standard of MAPICON is increasing day by day.
Thank you, sir.
And we will like your all faculty to be invited next year also, along with volunteers. We have modified the dates according to the pulse, so that more and more students you can motivate to participate in MAPICON. Thank you very much.
Sure,
Thank
sir.
you, Ji.
It is an honor for us to be a part of MAPICON. Thank you, sir.
Thank you, ma'am. Thank you. Yes, yes, you can.
Yes, sir. Sir, as I already discussed, in the Indian scenario, we should not give much importance to HDL-C. And there are many studies which have shown that increasing HDL-C in the Indian setup has not led to a long-term reduction in mortality after many years of initiating the therapy. So instead of focusing on the HDL-C, I think a better indicator would be to focus on the LDL-C.
Ma'am, suppose suppose patient has very low HDL-C and he knows that this is bad and he wants you to increase it.
Sir, it can be increased. It can be increased. It can be increased. But that is what I'm saying, that whatever studies have been done on the Indian population on HDL-C, they say that HDL-C should not be the main focus of treatment. You can increase it. There are many things available. There are the fruits are available, drugs are available. You can increase it. But the studies on the Indian population have shown that it does not reduce. It is not a major factor for reduction of mortality in further years. Better is to focus on LDL-C. If we focus on LDL-C, there is many studies have shown decrease in mortality in after treatment after many years. Thank you, sir. Anything else? Thank you.
Thank you, ma'am. Next, I would like to invite Dr. Sapna Sisodia, DM Nephrology, Consultant Nephrologist, Delhi Heart Institute and Multi-Speciality Hospital, Bathinda. She'll be speaking on the topic renovascular hypertension. Ma'am, please.
So renovascular hypertension is really coming up, especially in young. So I think we'll be enlightened by your talk, ma'am, to what is relevance for young hypertensives.
I will try my best, sir. First of all, I will like to thank the organizing committee for giving me an opportunity to speak on from this prestigious platform. So, renovascular hypertension. First of all, definition. How do we define renovascular hypertension? It is defined as a syndrome of elevated BP. It may be systolic and or diastolic, which is produced by occlusive disease of renal vasculature leading on to reduced perfusion of the kidney. It is very uncommon because as such secondary hypertension is very uncommon as compared to the essential hypertension, but it is very distinctive form of hypertension because it is potentially correctable. So when a person of hypertension comes to us, when should we suspect that this patient may be having renovascular hypertension? So first of all, if the person comes to us with the age of onset of hypertension, which is less than 30 years or more than 50 years, the person who is coming to us with hypertension with the severe features of hypertension, like the patient is having disproportionate target organ damage as compared to the level of hypertension. And that will be in the form of left ventricular heart failure or grade 3 or 4 hypertensive retinopathy. Then if a person comes to us with resistant hypertension, that is the person, we have started the drugs, 3 optimal drugs in the optimal dose, including a diuretic, but still we are not able to achieve our BP goal. Then a patient of essential hypertension who was previously well controlled is now presenting to us with uncontrolled hypertension. Then hypertension which is accompanied by any electrolyte abnormalities, like in the form of hypokalemia. A patient of hypertension presenting with recurrent pulmonary edema or congestive heart failure is the presenting feature of hypertension. Then any patient who is presenting to us with unexplained progressive renal failure. And that unexplained progressive renal failure should be taken into account after ruling out the causes of pre and post-renal. Then the patient who is coming to us with deterioration of the renal functions after we introduce the ACE inhibitor or ARBs. This actually needs to be, this actually needs a little bit discussion, because normally even if we start the patient on ACE inhibitor ARBs, it is expected to have some decrease in EGFR. But that decrease in EGFR is up to the level of only 25%. If the patient of renovascular hypertension and of renal artery stenosis, usually bilateral, we are starting the ACE inhibitor ARB and the patient comes to us after say 5-7 days with deterioration of renal function, that will be usually in the tune of more than 50% from the baseline. So if the creatinine increases after introduction of ACE inhibitor ARBs, usually we should consider the possibility of bilateral renal artery stenosis. Then if there is asymmetry in the kidney size, that asymmetry will be usually detected on ultrasound or CT or other imaging. and that asymmetry will be of the difference of the size between two kidneys of more than 1.5 centimeter. Then causes, ARVD, that is atherosclerotic renovascular disease. It is the most common cause of renovascular hypertension due to renal artery stenosis in both Western and Indian population. And the second most common cause is fibromuscular dysplasia. But the thing is that fibromuscular dysplasia, which is usually a disease of young, it is the most common cause in the Western population, in younger population. So ARVD constitutes almost 80% of the cases of renal vascular hypertension. FMD constitutes almost 20%, say 15-20%. But in Indian scenarios and in Asian and African populations, Takayasu arteritis, it is the most common cause of renovascular hypertension due to renal artery stenosis in Indian population, in younger patients. The rest of the causes due to renal trauma leading on to renal artery dissection, infarction, coarctation of aorta, dissection or its emboli, any atheroembolic disease due to either instrumentation of aorta or any other cause, and other like miscellaneous due to hypercoagulable states, malignancy, RCC, radiation injury, all these causes constitutes less than 1% of all the causes. So pathophysiology, whenever there is any renal artery stenosis, there will be decreased perfusion to the kidney. This decreased perfusion to the kidney will lead on to decrease in the eGFR of the kidney. That eGFR decrease will be sensed by the kidney and there will be release of renin from the JG apparatus. This renin will convert angiotensinogen to angiotensin 1. This angiotensin 1 will be converted by ACE enzymes to angiotensin 2. This angiotensin 2, it has variety of functions in the body, variety of actions acting on different organs, leading on to hypertension. So, angiotensin 2 will act on preferentially efferent arteriole, leading on to renal glomerular hypertension in itself. It will lead on to renal sodium retention. It will lead on to aldosterone secretion. It has vascular effects, including hypertrophy, remodeling, endothelin release, prostaglandins release. Also, by some inflammatory pathway, it also induces oxidative stress. It also stimulates the sympathetic nervous system. And on myocardium, it has effects like LV hypertrophy, myocyte growth, and LV remodeling. So all these changes, they act as integrated renal response to maintain the GFR, which has been decreased at the first place. So, but in maintaining and in an effort to increase the GFR and maintaining the perfusion of the kidney, there is development of hypertension. So Goldblatt, he performed several experiments to understand the pathophysiology of hypertension which occurs in the cases of renal artery stenosis. So what he did, he took kidney of the mouse. This is the mouse model of the hypertension. He took kidney of the mouse and he applied a clip to one side of the artery. So this is 2 kidney, 1 clip model. So what happened? When he applied a clip to unilateral kidney and the other contralateral kidney is normally working, there will be reduction in the renal perfusion in the kidney in which clip was applied. So this will lead on to activation of renin, angiotensin, aldosterone system. So the hypertension will develop, which will be angiotensin 2 dependent. But because the contralateral kidney is normally working, it is still able to excrete all the sodium and all the salt which has been retained due to angiotensin 2. So there will be pressure natriuresis by the normally functioning contralateral kidney. So the effect on this, the underlying cause, the underlying mechanism of this hypertension will be angiotensin 2 dependent hypertension, because there will not be any edema, there will not be any other thing, because the contralateral kidney is still working and it will negate the effect of angiotensin 2 leading on to pressure natriuresis. So what happened, because now hypertension has been relieved, so the perfusion of the kidney in which the clip was applied, it was trying to maintain the perfusion by increasing hypertension. So there may be decrease in the perfusion of that kidney. So if we block the renal, RAS system, there will be reduction in the arterial pressure, there will be enhanced lateralization of the diagnostic test, there will be decrease in GFR in the stenotic kidney. Then if we perform a diagnostic test, there will be plasma renin activity which will be elevated because the underperfused kidney remains underperfused, and the captopril enhanced renography also can show the same results. So in second experiment, what Goldblatt did, he took 2 kidneys and he applied clips to both sides. So there is no functional contralateral kidney as it was in the earlier experiment. So what he saw, and also he took a single kidney and applied a clip. So kidney as a mass is involved in this experiment. So there is reduced perfusion of the kidney, there is activation of RAS as usually expected. But because now contralateral kidney is not there to for the pressure natriuresis and the excretion of the sodium and water. So this hypertension which occurs in the case of bilateral renal artery stenosis or renal artery stenosis of a single kidney, that will be volume mediated because the normal contralateral kidney is not there to negate its effect. So the effect of RAS will be reduced arterial pressure only after volume depletion. So if we want to control hypertension in this scenario, we first need to control the volume. Only then, after controlling the volume, we will be able to control hypertension with RAS blockade. Only RAS blockade will not be helpful here. So coming on after pathophysiology, so ARVD, it is the most common cause of renovascular hypertension in patients who are more than 50 years of age. Its incidence, usually if the patient, incidence depends on the population which is being studied. So if we see the patients in which mild hypertension is the presentation, the incidence will be very less, say less than 1%. But in patients, if we study the patients who present to us with refractory or resistant hypertension, the incidence raises up to 10 to 40%. And also its prevalence increases with age. Like if we are evaluating patients who are less than 40 years of age, the incidence is almost 0.4%. But if we consider the patients who are more than 60 years, the incidence is almost 30 to 40%. So its prevalence increases with age. It usually does not occur as an isolated disease. It is usually a part of generalized atherosclerosis in other vascular beds. Like the patient who is having ARVD may be having any coronary artery disease, may be having any limb ischemia or any other atherosclerotic manifestations. Bilateral renal involvement, it is usually in the 20 to 40% of patients. And the location of the lesion in atherosclerotic disease is usually near the origin of the artery. So even so much so that the atherosclerotic plaque, it can even cover the renal artery origin. It may be originating from the aorta only, and it can cover the renal artery ostium. So high risk predictors, what are the high risk predictors in which we can say that yes, we may be having renovascular hypertension in these patients due to ARVD. So those patients who have history of hypertension, diabetes, and who are even current smokers or reformed smokers, the patients who are having current CKD, chronic kidney disease, the patients who have coexisting peripheral vascular disease or coronary artery disease, and in those patients in which we can have abdominal bruise. Abdominal bruise may be systolic or diastolic. So if we are able to find bruise in a patient, we should always suspect the ARVD. Then whom to screen? Which patients should be screened? So according to ACC, AHA recommends that screening of renovascular disease in patients with hypertension with one or more severe profile, that is patients with resistant hypertension, patient with accelerated hypertension, that is hypertension with target organ damage, and hypertension which is presenting as heart failure. So when to investigate? This is a very important question, when to investigate, because the diagnostic test which we are going to perform first, and second, the intervention, even if we find the patient is having renovascular hypertension due to renal artery stenosis, these two things, they are associated with potential risk of diagnostic test and intervention. So even if so indication of investigation in patients is only indicated if we are going to perform a corrective procedure, which will be followed by that investigation. So patients without any kidney function impairment, the first investigation of choice is duplex Doppler, followed by CTA and CT angiography and MRA angiography. So how to investigate? The first most commonly available test with us is duplex ultrasound. It has got high sensitivity, but specificity is very low. And it has got two disadvantages. First is that it is operator dependent, so it is very subjective, and it is limited by the bowel gas or the obesity. If patient is obese, we will not be able to give the correct measures in the duplex ultrasound. Then we have multi-detector CTA, which requires the ionated contrast. Then we have magnetic resonance imaging, in which again no radiation is required, but we will be needing a ionizing agent for its performance. Then the gold standard remains to be catheter angiography, but it is an invasive procedure, and the advantage is that we can diagnose and treat in the same sitting with the catheter angiography. Then other tests, two other tests are available, that is captopril renography and renal vein renin level. So how to make a diagnosis? First, we have clinical suspicion of renal artery stenosis. We have suspicion of atherosclerotic renovascular disease. We evaluated the patient. The patient is having eGFR of less than 30. So all the MRA, CTA, they go out of the picture, because with eGFR of less than 30, we will be able to perform only duplex ultrasound, which is non-nephrotoxic. So we will be measuring resistive indexes, the renal ratio, the renal aortic ratio with duplex ultrasound. If even this is negative, then, but still we are suspecting that yes, patient is maybe having ARVD and we need to make a diagnosis, then only we should go for CT and MRA. And also the risk of contrast associated nephropathy should be negated to the patient at the first place. So if eGFR is more than 30, we can do MRA, we can do CTA. So management. First of all, we have to, because it is a generalized atherosclerotic condition, we just need to do some modifications in the lifestyle. Like if patient is a smoker, we should ask him to cease the smoking. Second, we should ask him for weight reduction. Third, there should be strict control for blood pressure and blood sugars. These are the two most important things for lifestyle modification. Then the most intensive management of hypertension, it is the single most important and modifiable cardiovascular risk factor. So according to ACC and AHA, the target for blood pressure should be less than 130/80. But our KDIGO, for CKD, it says that the blood pressure target for any patient who is having CKD should be less than 120. So initial choice for the management of BP should be RAS blocker. So if the patient is medically, this was for medical management. Second is, we can have option of revascularization, but there is some controversy regarding revascularization. So in the earlier parts of 1960s, the surgical management was considered to be, surgical correction of renal artery stenosis was considered to be the standard of care, standard of treatment for any patient who was coming with ARVD. Later in 1980s, with the advent of advancement in the endoscopic surgeries, the percutaneous transluminal angioplasty, it became the standard of care. But what happened afterwards? There were some small observational studies which show that any procedure of revascularization was not superior to medical treatment. So here comes the 3 RCTs which have been done in these ARVD patients. So first was STAR, second was Astral, and third was Coral. These were the 3 RCTs which were done and which directly compared the surgical treatment plus medical treatment versus medical treatment alone. So what did they find? They find that renal revascularization compared to optimal medical therapy alone did not consistently lower blood pressure, did not restore kidney function, did not prevent cardiovascular outcomes. So these trials, they made clear that any patient who is coming to you is not, we just need not to subject him to revascularization. So much so that the ACC and AHA, they make their level of the recommendation 2B, which is very weak level. And their level of recommendation is consensus of expert opinion, CEO. But in some patients, there were some caveats in these trials, because some patients who were having heart failure, who were having increased creatinine, they were excluded from those trials. So some high-risk patients having these features like acute kidney injury, like acute on chronic heart failure, those patients who present with rapidly declining renal function, and we are not able to control their blood pressure on normal medical management. So these patients still may benefit from revascularization. So if we are assessing the potential indication for revascularization, if patient is presenting with flash pulmonary edema, if patient is presenting with rapidly declining renal functions, if patient is presenting with severe uncontrolled hypertension. Because what happens with medical management, the goal of medical management is to control blood pressure and make the kidneys function stable. If these two functions we are able to control with medical management, why should we subject the patient to renal revascularization? So when we are not able to achieve our goal of these two things with medical management, only then the renal revascularization comes into the picture. So if flash pulmonary edema, rapidly declining renal function, and severe uncontrolled hypertension, if indications are present, initial medical management, we should discuss revascularization in these scenarios only. If no indication is present, we should again make some lifestyle changes, advise the patient, and treat blood pressure, and target less than 130/70. ACE inhibitors and ARBs as the first initial choice, second choice beta blockers, and third choice CCBs. And also the statins and antiplatelet, because as a part of generalized atherosclerosis, we need to give them antiplatelets and statins. So this was all about ARVD. Coming to FMD, it is a non-inflammatory, non-atherosclerotic disorder that leads to arterial stenosis, occlusion, aneurysm, dissection, and arterial tortuosity. Most commonly, renal arteries are involved, 75 to 80% of patients. Carotid and vertebral arteries follows on second number, 75%. Multiple arterial involvement is common in 2/3 of patients. And in adults, we have female preponderance, which is not usually seen in children. So if child is presenting with FMD, there will not be any female preponderance in them. And the lesions of FMD, they usually occur in the mid portion of the vessel. Usually from aorta, the renal artery arises away from the origin of the renal artery, 2 centimeters away, usually. So in the mid portion, as compared to ARVD, where the lesions were at the origin of the renal artery. So it is usually histologically classified into 3 categories, depending upon the layer of the artery involved. So it is medial, adventitial, and intimal. So in medial it is again divided into 3 things: medial hyperplasia, medial fibroplasia, and intimal hyperplasia. So in medial hyperplasia is the most common, which usually is seen as string of beads appearance. So by angiography, we can divide it into multifocal or focal. So multifocal, it is more common. It corresponds pathologically to the medial fibroplasia. And it usually, because there are intervening normal artery with the involvement of FMD lesions, so it gives a FMD string of beads appearance. Sorry, the image is not actually being formatted. So focal FMD, it is less common. It is usually circumferential and at only single point, because it is focal in nature. So if we have clinical suspicion of renal artery stenosis, first we did was ARVD, now coming to FMD. In FMD, if EGFR is more than 30, our initial choice of investigation remains to be MRA. If EGFR is less than 30, here we are subjecting the patient to CTA, to CT angiography, because fibromuscular disease is a disease of young people. We want to make a diagnosis as soon as possible, and we want to, the goal here in FMD is to cure hypertension. So even with the risk associated, contrast associated nephropathy, we can have potential risk for that also, but still we want to make a diagnosis and we want to do the CT angiography. The most common manifestation of renal artery FMD is hypertension, which is due to renal artery stenosis. Options remain the same: antihypertensive drug therapy and revascularization. Indications for revascularization in FMD patients. So as we saw that in ARVD, the indications for revascularization were flash pulmonary edema, declining renal functions, and severe hypertension, which was not controlled on drugs. But in here, the indications are totally different. So we have recent onset hypertension, particularly young patients with focal FMD. Resistant hypertension despite compliance with appropriate 3-drug regime. Hypertensive children with renal artery FMD. Adults with bilateral renal FMD or unilateral renal FMD to a single functioning kidney. So those patients who present with ischemic nephropathy. So these are the indications for revascularization. So which patient should be subjected to angioplasty and which patient should be subjected to surgery in FMD? So most patients with FMD who are selected for renal revascularization, they have percutaneous transluminal angioplasty rather than surgery. In some cases, surgery should be preferred than PTA. So if PTA fails, if the renal arteries, they are very small, that is less than 4 mm, if the branch renal artery lesions are there, which cannot be easily accessible by the PTA, and if there is extensive intimal fibroplasia, which cannot be corrected by angioplasty alone. So if we have a new diagnosis of fibromuscular disease, we just need to know the duration of hypertension, earlier detected, that makes it an indication for revascularization. Then general measures, which we give in ARV also. So here the difference lies between ARVD and FMD. If the age of the patient is less than 30, we straight away send the patient for revascularization. Because again, I'm stressing the goal here is to cure hypertension. And we want to catch them young. Because if we cure hypertension at this age, we will not be seeing that patient later on in his life as CKD patient or any cardiovascular disease or morbidity. So if the patient's age is less than 30, revascularization is indicated in patient of FMD. If age is 30 to 60 years of age, then again indication if malignant hypertension is there or rapid loss of EGFR is there, then we should send the patient for revascularization. If age is more than 60, then pharmacological treatment of this management of hypertension should be our first goal. And again, if patient on medical management develops decreased EGFR or blood pressure is not controlled, then we should send the patient for revascularization. So third and the last one, it is Takayasu arteritis, also known as pulseless disease. It is a large vessel vasculitis. It is a chronic granulomatous vasculitis of unknown etiology. It predominantly involves the aorta and its main branches. And the symptoms, they are usually characterized by end organ ischemia. Because what it causes? It causes inflammation leading on to arterial stenosis, aneurysm formation, and so the symptoms will be depending upon the vascular bed involved. And the female to male ratio is, again, as of all connective tissue disorders and vasculitis, it is more common in females. So the natural history of Takayasu arteritis, it involves two phases. First is the early phase, and second is the phase of active vascular inflammation. The early phase, as in any vasculitis or connective tissue disorder, the patient presents with constitutional symptoms like weakness, night sweats, low-grade fever, weight loss, arthralgias. In the phase of active vascular inflammation, the systemic manifestations, they subside and the clinical state is now characterized by ischemic events, which will be depending upon the vascular bed involved. So if renal artery is involved, there will be renal vascular hypertension. If any limb artery is involved, there will be limb ischemia, and so on. So if a person comes to you with a young patient coming to us with absence of pulses, then and hypertension, so we just need to examine all the pulses and blood pressure in different limbs in order to detect the asymmetry, because in these the patient may be having decreased or absent pulses in the upper limbs. Then there is no diagnostic test or lab test to make its diagnosis, but the most common finding which is usually seen is elevation in the ESR and CRP. Then imaging studies, they are essential for establishing the diagnosis and for determining the extent of vascular involvement. So the characteristic feature which will be seen, that will be the presence of inflammatory thickening or edema of the vascular wall, which will be seen on imaging. So there are many diagnostic criteria. The most commonly used diagnostic criteria for Takayasu arteritis is the age of onset less than 40 years, with claudication of the extremities, decreased pulse of one or both brachial arteries, difference of at least 10 millimeter of mercury in systolic BP between the arms, bruit over one or both subclavian arteries or in the abdominal aorta. Then last is arteriographic narrowing or occlusion of the entire aorta, its primary branches or large arteries in the proximal upper or lower extremities, but that will be after ruling out atherosclerosis and FMD. So if we are having 3 out of these 6 features, patient will be labeled as Takayasu arteritis. So treatment, it is a bit of controversy in this treatment. So the most commonly used treatment is systemic glucocorticoids, because the disease is very chronic and have relapsing course, so long-term glucocorticoid use is required. So for to decrease the toxicity which is induced by long-term use of glucocorticoids, steroid-sparing agents are usually used, and these are non-biological, including methotrexate, azathioprine and leflunomide, and TNF inhibitors like etanercept and infliximab. Revascularization in cases of Takayasu arteritis only indicated if short segment arterial stenosis lesion are present. If long lesions are present, this revascularization will be of no use. So take home message, last slide. Renovascular hypertension, it is a potential correctable cause of secondary hypertension, should always be suspected in any patient, any young patient, even older patient. The most common cause is ARVD in both Western and Indian population, followed by FMD in Western population and Takayasu arteritis in Indian population. Usually the the management includes medical management with optimal BP control with RAS blockers, and revascularization in patients who are having FMD less than 30 years of age, immediate revascularization, and in ARVD, there are certain high-risk groups in which revascularization should be done, not in every patient. Thank you so much. Any questions? Thank you.
Now, I would like to call our next guest speaker, Shrestha Agarwal, DGO MD, Member Society of Fetal Medicine, North Zone Coordinator, Fetal Medicine Foundation of India, who will be presenting the topic, Scope of Prenatal Genetic Testing.
I think for short women like me, it's very difficult to watch over the laptop. Okay. First of all, I would want to thank Dr. Vitul Gupta and the organizing team for making me a part of this esteemed event. It's really amazing to see an event of this scale happening in our own town. My topic for today is scope for prenatal genetic testing. I'm Dr. Shrestha Agarwal. I am a fetal medicine consultant. You've been hearing about all the hyperlipidemias and hyperglycemias and renovascular hypertension. Now from there, I bring you to the tiniest of all human patients, that is a fetus. That's who we deal with. Just to give you a brief introduction, what we are basically doing is doing these 3D, 4D and high detailed ultrasound scans for these babies, and also at the same time doing some genetic testing for them. Until a couple of decades back, all that we looked for was if the baby in utero was alive or not. Then gradually, as the scope of ultrasound increased, we started looking for the growth. If the baby was doing well, it was growing as per its biological potential. If the placenta was lying low and it could be of risk to the mother, then the amount of liquor that we could see around the baby. However, as the scope further increased, we gradually added some more major abnormalities to the protocols. So we started detecting things like spina bifida, anencephaly, etc. Okay, so this is moving. Yeah, I hope it had not slept. Still, until about 5 years back, if we had a stillbirth or an intrauterine death, the blame was always put that maybe there was some cardiac defect in the baby that was not detected earlier, and that might have been missed, and anyone could have gotten away with the excuse. But not now. Today, with the major groundbreaking research, we can detect more than 95% of the cardiac defects at a gestation of about 20 weeks. That's approximately 4.5 months of amenorrhea. So this is a case where I've given the images, and this is a case of hypoplastic left heart syndrome. So that's how early and that's how accurate we can give the diagnosis. But what about the prenatal genetic testing? These are all the names that you are all familiar with: thalassemia and Down syndrome, spinal muscular atrophy, Duchenne's muscular dystrophy, Fragile X syndrome, Rett syndrome, hemophilia, skeletal dysplasias, Dye-George syndrome, Edwards syndrome, Patau syndrome, etc. And you must be dealing with some or the other in your OPDs from day-to-day basis. And this is the burden of the genetic diseases in India. Can you imagine the number of births happening every year with these defects that can be prevented? The reason why we want to prevent these is there is no treatment available for most of them, and the cost of treating each of these diseases is much more than what we could spend on screening our entire pregnant population for the common genetic defects. Not just that, when you have a baby affected with a gross defect or some genetic defect in a baby, it adds to the mental agony and the social pressure these families live under. If only one member is affected, and you come across all these patients on your day-to-day basis. So what does prenatal genetic deal with? There are some families who would approach you with the history of a known genetic defect or possible genetic defect. Say, for example, you have a patient coming to your OPD for treatment of thalassemia. What you need to be conscious about is that this couple, the parents of the affected child, can have another baby that might possibly be affected with thalassemia major. They might have a genetic diagnosis in such cases, and many times they do not. There might be patients who are coming to you with mental retardation or with an abnormal gait, or there are other issues that you may think there is a family history of similar disorders in the families. So these are the cases which need to see the genetic counselor and, if possible, a fetal medicine specialist. Apart from these is what we will call the high-risk population. But there are a lot of pregnancies which fall in the low-risk population. So in these pregnancies, approximately it is said that 1 in 300 pregnancies would have a recognizable chromosomal defect. Out of these, 95% are what we call as trisomy 21, that is Down syndrome, trisomy 18, that is Edwards syndrome, and trisomy 13, that is Patau syndrome. So these are the commonest, and apart from them, there are changes in the X and the Y chromosome. A majority of these are Down syndrome. Why we are so much after Down syndrome is these babies have a good life expectancies. They may go on to live up to 15, 20 or 25 years, but the life quality is extremely poor. So much so that they are dependent upon their families for their day-to-day care also. The list of detectable genetic syndromes is increasing in context of the genetic testing becoming wider in horizon and increasing knowledge of patterns we see in ultrasound in specific syndromes. Something like a Down syndrome may not necessarily have a specific pattern, but there are things like Meckel-Gruber syndrome where we see a multicystic dysplastic kidney along with a polydactyly or along with an encapsulocele. So these are autosomal recessive disorders. They can recur in 25% chances. Similarly, we have many other diseases which can give us specific patterns on ultrasound by which we can give the diagnosis. If that is not there, then many a times the ultrasound gives us a hint of what we can possibly be looking at. In these cases, we can offer genetic testing and confirm the genetic diagnosis, and based upon that, we can further give them the idea of how much is the recurrence risk of these diseases. So how do we approach it? There are two methodologies. As I've already said, that if there is a patient or there is a family that is already having a history of an inherited disorder, we can offer them the direct diagnostic test, something like thalassemia, spinal muscular atrophy, Duchenne's muscular dystrophy. We have specified gene mutations and variations. We locate those variations in the affected patient, and then we offer the family the genetic testing in the baby, that is the fetus. But however, most of these diseases occur in low risk settings. So we don't know. Any lady, a pregnant lady walking into your office may be a baby that is affected with a genetic disease. So in these cases, we offer screening for the common disorders, that is your trisomy 21, 18, 13, and the abnormalities of the sex chromosomes. So what is screening? This is screening. It's like finding a needle in the haystack. So the textbook definition says that identifying in apparently healthy individuals those who are sufficiently at risk of a specific disorder so as to justify a diagnostic test or procedures. We can't be offering the diagnostic tests and procedures to everyone in the population because these are, one thing, they're invasive, and second, they are expensive. So what we do is we offer them screening tests, and based upon that, the high risk population is offered the diagnostic tests. So how do we do? This is exactly what we are doing. So what are the various screening options? In the pregnancy, as you know, is divided into the trimesters, first trimester, the second trimester, and the final trimester. The screening is offered in the first trimester. We call it as the first trimester screening. This is by far the best time to screen the pregnancies because this is the time when we are most likely to pick up the normal from the abnormal. Then there is an option of second trimester screening. In the first trimester screening, we have two components. First is our ultrasound, or what is popularly known as the NT scan. In this scan, what we search for is the nuchal translucency, that is the thickness of the skin at the back of the neck of the baby. There are very particular ways in which these images are supposed to be taken and measured because they are done in millimeters. So a 2 millimeter NT is entirely different from 3 millimeters entry. So I have to be very particular in the way I am taking the image and taking my measurements. The other parameters that we assess are the nasal bone, the tricuspid flow, ductus venosus, that is the vessel that connects the umbilical vein to the inferior vena cava, then the fetal heart rate. In addition, we may detect many abnormalities like an AV septal defect, megacystis, holoprosencephaly, encephalocele, or spinal defects. These defects per se have a very high association with these genetic defects, and hence they may give you a clue that there may be something genetically abnormal with this baby. In addition, to improve the efficacy and the sensitivity of an NT scan, we go do a dual marker test. Please note that dual marker test has to be done in association with an NT scan and not on its own. So its values are dependent upon and they are interpreted in relation to the findings of your scan. The dual marker test, in dual marker test, we are testing two hormones. These are the maternal hormones that are produced in response to the pregnancy. The hormones that we test for are beta-HCG and PAP-A. So how do we interpret these screening tests? So the data from the NT scan and the values of the serum biochemistry, that is your dual test, we put in a software, and the software calculates the risk that woman has of her baby being affected with trisomy 21, 18, 13 respectively. For trisomy 21, in first trimester, if the risk is more than 1:250, we call the patient as high risk and we offer them the genetic testing, the definitive diagnostic tests that will come to. If the risk is between 1:250 to 1:1000, we call them the intermediate risk category, and these patients need further evaluation. If the risk is less than 1:1000, we leave them as the low risk population and follow up routine and keep looking for any signs later on. For trisomy 13 and 18, the cutoff is 1:100. So if the risk is more than 1:100, we'll offer them the definitive test. But if the risk is lesser than 1:100, we just let them be themselves. So what if we miss the train? It is not uncommon in our Indian scenario that the patient comes to you when the first trimester is already gone. But never mind, we may not be the Shah Rukh Khans, but then we can quite catch up in the situations. So there comes the role of the second trimester. So the second trimester screening has got two components. Again, just like your first trimester screening, we have an ultrasound or a genetic sonogram. Here, what we are looking for are the genetic soft markers. Traditionally, what we were doing was, when we were doing our scans, we were just looking for the anatomical abnormalities, but here what we are looking for are soft markers. Soft markers are not abnormalities per se, but they are only the variations from the normal that are more common in genetically affected babies as compared to the normal population. So the soft markers that we look for are a nasal bone, nuchal fold thickness, the lateral ventricular width, that is the lateral ventricles of the brain, then the long bone length, that is your femur and humerus, bowel echogenicity, echogenic intracardiac focus, and the renal pelvic diameters. Please note that a baby, if it has an absent nasal bone, if it is nuchal thickness is increased, that does not mean it is abnormal. It just means that it has a higher chance of being abnormal as compared to the other population. So whenever one of these is present, we put them together along with the serum biochemistry. Similarly, we calculate the risk and then we further counsel the patients. In addition, there is a huge list of abnormalities that may be associated with aneuploidies. Say, for example, there is a baby that has a duodenal atresia. So a duodenal atresia has a 20% association with Down syndrome or trisomy 21. However, once we have done the genetic testing, and if the baby is not having any major genetic abnormality, a baby with duodenal atresia has a very good outcome because the surgery for duodenal atresia is only one-step surgery. Similarly, a tetralogy of Fallet's. Again, a very high association with aneuploidies, that is your trisomy 21, 18, 13, and apart from Dye-George syndrome. But once we have ruled them out, the babies with tetralogy of Fallet can have a good survival. So there are more and more cases of these abnormalities that are coming across that can undergo treatment and have a good outcome, provided there is no genetic association with it. The biochemistry or that we offer at the time of the second trimester is what we call as the quadruple marker. So here we are studying 4 maternal hormones, that is your beta-HCG, unconjugated estriol, inhibin A, and alpha-fetoprotein. Again, just like we were doing for the first trimester, how are we interpreting them is, we have a cutoff of 1:250 for the trisomy 21. If the risk is more than 1:250, we call them high risk and we offer them the diagnostic testing. However, if the risk is below 1:250, we do not offer any further testing. For trisomy 18 and 13, the risk cutoff is 1:100. The reason why this is that ultrasound is highly effective in picking up babies with trisomy 13 and 18. Now, there is the new kid on the block, relatively new, but it has been there for some time now, what we call as the non-invasive prenatal test or cell-free fetal DNA. In this, what we are doing is, we are taking the maternal blood sample, and from that maternal blood sample, we are taking out the fetal DNA, because some amount of fetal DNA goes into the maternal circulation through the placenta. It is a very good screening test, mind you. However, it is not a diagnostic test. The accuracy for NIPT for trisomy 21 is almost 99%. So in given scenarios, in selected situations, it may be good, but once it is high risk, it has to be confirmed with a diagnostic test, that is your amniocensus. It has its own limitations. One of the commonest limitations is that the fetal fraction should be more than 4%. So if I have a maternal blood sample where I cannot find the fetal fraction of DNA less than 4%, I cannot interpret the results. So this was about the screening. So we have now come to the diagnosis. So which are the patients that are offered the diagnostic test? First and foremost, obviously, from our first trimester screening as well as second trimester screening, the patients who are screened positive, they'll have to be offered the definitive diagnostic test. Then, just as I told you earlier, if there is a known genetic defect in the family, say for example, thalassemia, DMD, or hemophilias, or Rett syndrome, or anything like that. Or as I was already talking to you, if there is one point that you can take home from this talk is that it is extremely important to work the index case. I cannot just put my needle inside, take the amniotic fluid out and run a test unless and until I'm very sure what I'm going to, the test that I'm going to run on that sample. Say for example, there is a couple who approaches you that their first child is affected with deafness. Deafness, as you all know, can have a varied etiology. It can be genetic but need not necessarily be. And there is a whole long panel of genetic tests that we can do to know if it is genetic or not, and if it is genetic, then what exactly is the mutation or variation that is responsible for deafness in that family. The thing is that in the affected child, you know what is the presentation or the phenotype, but in the fetus, if we find a variation or a mutation, we would not be sure if the baby is deaf or not. So we cannot correlate the phenotype with the genotype. Hence, it is extremely important that we work up the index case, because all these tests have a turnaround time of sometimes 4 to 6 weeks. And in pregnancy, we are always running against the time. The clock is always ticking. The patient needs to know at the earliest that if the baby is affected or not. So if the index case or the affected case is already worked up, that saves us a lot of time so that we know exactly what we need to look for or rule out in the current pregnancy. There are diagnostic procedures that are available. They are chorionic villus sampling, amniocentesis, and chordocentesis. So this is a procedure of chorionic villus sampling. It's done between 11 to 14 weeks. We visualize the uterus, we visualize the placenta. This is the skin, and then a 18 gauge needle under supervision, under constant ultrasound monitoring, under aseptic precautions is introduced into the uterine cavity along the axis of the placenta. You can see the tip of the needle. You can see this is the movement. That's the tip of the needle that goes into the placenta along the long axis of the placenta. We just make some movements, connect the cannula with the culture medium along the needle, and just moving the needle along the placental axis with a negative pressure, we take the placental biopsy and come out. So this is the sample that is taken, and because we are taking the sample from the fetal part of the placenta, these are the fetal cells, and then we run the tests, whichever test is required on the sample that we have. You can please notice here that the fetus lying here on the sides, we are not even going close to the fetus. It is all done under ultrasound monitoring. It is an OPD procedure. There is no anesthesia required, and loss rate of pregnancy is roughly 1 is 500. This is an international data, and we've been doing it for last so long, so many years. We do almost 4 to 5 CVS a month. There is no issue at all, absolutely no fear that a pregnancy would be lost just because we have done a CVS. The second procedure that is available to us, and that is more commonly done, we are doing about 30 a month, is an amniocentesis. This is done after 16 weeks, can be done anywhere later also. You can see similarly a 22 gauge needle, it's as thin as 22 gauze, is introduced into the amniotic cavity, and under ultrasound guidance, we take the sample and come out. It's again an OPD procedure, no anesthesia required at all. The pregnancy loss rate is 1 is to 500 to 1 is to 1000. Almost similar to that of chorionic villus sampling. Chorionic villus sample is, because we use an 18 gauge needle, is slightly more painful, technically more challenging, so not many people are confident in doing a CVS. Amniocentesis is a very simple procedure. If you see this was a patient that I had done in 2016. So that's how long we've been doing. And these are so safe and so easy to be done, and they give you such a reassurance that an amniocentesis is still a gold standard when it comes to diagnosis of prenatal genetic diseases. And the third procedure is cordocentesis. Here you see the needle is going into the umbilical cord. This is usually not done anymore for the diagnostic per se. What the procedure that we use nowadays, cordocentesis, is for intrauterine blood transfusions in cases where there is severe fetal anemia, maybe secondary to Rh isoimmunization, or in cases where there is parvovirus infection or other causes. So in those cases where there is severe fetal anemia, we do the cordocentesis and transfuse the blood intrauterine. So this is what, we've taken a sample out, be it blood in the cordocentesis, amniotic fluid in the amniocentesis, or a placental sample in the chorionic villus sampling. So this is just like a sample taken out from an adult. There is a huge list of tests that we can run on the sample available. So what is this huge list is? FISH is fluorescent in situ hybridization, and QFPCR. These are, two of them are quick tests. Because in pregnancy, a patient needs to take a call whether they would want to continue the pregnancy or not. So we run a FISH and a QFPCR, though they can be done for a varied list of indications, but most common being for ruling out your trisomy 13, 18, 21, and any abnormalities of the sex chromosomes. So we get the turnaround time is roughly around 3 to 4 days. So if I do the test today, so by Wednesday I should have my report, and I can tell the patient that don't worry, your baby is not affected with Down syndrome or Edwards syndrome or Patau syndrome. Then the gold standard even today is a karyotype, that just like you run on your blood sample. However, because these are the fetal samples, the processing time is more. In an adult, if I send a blood sample today, I would get a karyotype in about 6 or 7 days, because it is very easy to catch the cells in the metaphase. In the fetal samples, they have a processing time. So an amniotic fluid sample or a CVS sample, it takes roughly about 3 weeks for the karyotype to come. Then in addition, if karyotype, in some cases when we feel that there may be more to it than just a karyotype, we do a chromosomal microarray, which is more detailed as compared to a karyotype. Then there is a clinical exome sequencing, there is a whole exome sequencing, then there is new generation sequencing and MLPA. New generation sequencing and MLPA are done specifically for a particular gene disorder. Say for example, Duchenne's muscular dystrophy, we know it's an X-linked recessive disorder. So we know which is the gene that are responsible for DMD. Those are the only tests that are specifically run on those samples. Chromosomal microarray, clinical exome sequencing, whole exome sequences, these are expensive tests and they are way more detailed tests. They are supposed to be sent only when there is some particular specific single gene disorder that we are expecting. Many a times what happens is, sometimes patients come and say, ma'am, since we are already doing the test, we are already running, paying say about 20 or 25,000, why not pay 35,000 and get done clinical exome sequencing? I say no. The reason is, in tests like clinical exome sequencing and whole exome sequencing, where we're mapping the whole of the exome, we end up finding sometimes variations of unknown significance. Because in the fetus, we would not know if it is going to be presenting clinically or not, unlike an adult where you know the exact clinical presentation of a genetic disorder. In the fetus, we would not know if it is exactly the genetic presentation or not. So clinical exome sequencing and whole exome sequencing especially have to be run in particular scenarios and only under genetic counseling, not otherwise. To conclude, the aim of prenatal genetic testing is not to generate perfect babies, but it is to let the parents know about the health of their unborn child to help them make informed decisions about themselves and their families in context of their value system. Say for example, there is a 45-year-old woman who has conceived with an IVF pregnancy and who does not know if she's going to conceive again or not, and she comes and tells me, no matter how my baby is, I just want to have a baby. So I tell her that's fair enough. It's her decision if she wants to have a baby with Down syndrome. So we do not offer any screening, we do not offer any testing. So the pre-test counseling is extremely important. On the other hand, you have a 22-year-old girl who walks in and has a pregnancy, who's tested high risk. She says, I want to be 100% sure that there is no such defect in my baby. So you go ahead and offer them every possible test. What is important is there has to be a proper pre-test counseling, telling them about the benefits and the disadvantages of each test and the limitations of each test. And once the report comes, there has to be a post-test counseling to tell them exactly what is wrong and how they're going to go about it. Just as Francis Collins said, there are no perfect human specimens. We are all genetically flawed. I was just reading this paper and it said that each one of us sitting here in this hall has at least 5 autosomal recessive genetic abnormalities. Luckily, they are autosomal recessive and we do not manifest them. This is one beautiful family. Gabriela has Down syndrome. Fabio struggles with slight mental delay. And still their daughter Valentina was born with no mental disability. So let's just give them the choice of informed decision. Thank you so much.
Thanks, Dr. Shrestha Agarwal. Excellent talk on prenatal genetic counseling. Any queries from the audience are welcome.
I think they're all exhausted by 4 days of storming. Thank you. Thank you so much to the organizing committee once again to give me this opportunity to stand here amongst the august audience. Thanks once again.
Now our next guest speaker is Pankaj Kumar Sharma, MS Ortho from AIMS Delhi, FACS from USA, Fellow IOA from Fellow AOT from Germany, Assistant Professor, Department of Orthopedics at AIMS Bathinda.
Good afternoon, all esteemed senior and faculty, and I am very thankful to Dr. Gupta and his team to invite me to deliver lecture. So, I'm surprised that we are not a number of people, so this lecture is very important for the youngster, which is more prone for the osteoarthritis nowadays. So, we are here for discussing some osteoarthritis diagnosis and its management. So, as we can see that if you are asking about osteoarthritis, so we all see about the bones only. But this is not the only bone. It is a systemic disease, and we only discuss about the bone itself, like knee arthritis, arthritis hip, or arthritis shoulder. But we has to be discuss about the system all. So it is a mapping of my lecture, that is definition, then diagnosis, then classification of little bit, and management, which include lifestyle, physical activity, oral medications and other alternative medications, intra-articular injections, and last but not least, surgical intervention in the last. So what is definition of osteoarthritis? As I say that it is gradual loss of articular cartilage. So it is gradual loss. So it is not a, as per se, bone problem. It is systematic problem which affect bone also. It is gradual loss of articular cartilage. Then it is complex interplay between the genetic, environmental, biomechanical, and the local article factors. So local factors are in very minimum percentage. It is mostly genetic, environmental, biomechanical. So if the three things, one of three things has someone, local factors are also added. And it could be primary and secondary. So primary is age related, then the secondary is if some underlying factor is there and overlap by the disease. So you can see that mostly we are suffering from the knee arthritis in this malva region, and hip arthritis is very less. So we will discuss more about the knee osteoarthritis. So you can see that left side we have normal knee joint, where we can see both the spaces of the joint very clearly, and there's good bone stock subchondrally. But in the right side, you can see that there's arthritic joint, and the space more middle side is very affected. There's no cartilage in between, and both sides are kissing to each other. So it is kissing lesion of the arthritis. That means the one surface of femur and the second surface of tibia is affected equally, and the second side, the lateral aspect, it is also affected. So it is a severe osteoarthritis, which is common in this region. So how to diagnose this kind of disease? So very first, like other lecture or other disease, history is very important. So in 100 patients, there is single symptom, it is pain. But pain is of different kind of pain. It may be light, it is maybe moderate, it is maybe severe, but pain is there. And associated symptoms are walking distance. You can see the walking distance is different in different kind of arthritis. If you can see that some people are comfortable in walking 1 kilometer before the pain. Some people are comfortable up to 500 meters. Some people are comfortable in only 50 yards. But the concern about the patients are mostly less walking distance. Then activity of daily living, it is very important for the Indian perspective, because activity daily living is the activities which are we're doing daily by routine basis, like even you are rural population from the urban population, but the activity of daily living is affected, so disease is more important. Then the second part is examinations. So what is the single entity which is found in every patient, which is tenderness. That means if you are feeling pain after the examining by the doctor or by pressing your joint, it's tenderness. Then crepitus, that means some sounds when you are moving your joint. Then deformity, it is the last one, which may be in frontal part or coronal part. So deformity is the last part, and in most severe condition. The most common diagnosis tool mark after the history is radiology, which is a radiograph. It can be anterior posterior standing position. Then the lateral view in different direction. For the knee, it is more 30-degree flexion. Then sunrise view, that means the knee is flexion in different condition for the anterior part of the arthritis. Then some special view for the hip and the shoulder. We are not discussing the radiology proper, but we can see this kind of X-ray in the routine osteoarthritis. There is some varus deformity of the knee, and the joint are subluxated. So you can see the deformity of knee in the inner angulation of the knee joints, and the knee are subluxated. If you are moving the knee, the subluxation of knee either in medial side or lateral side, but more in medial side. So it is varus deformity of the knee, and you can see this type of X-ray in severe arthritis. The same kind of X-ray you can see AP in lateral view. Lateral view you can find some osteophyte, articular space degeneration, and the subchondral degeneration of the bone or cartilage. So in other joints, like knee joint, there is hip joint also, there narrowed joint space from the loss of cartilage. Then there is some bone spurs or bone osteophyte you can see. The same thing in knee joint itself. Then if you are feeling that there is pain in the knee, it is not always osteoarthritis. So what kind of other pain you can see in the knee? So if there is lateral pain, which is less common than the medial pain, so there may be osteoarthritis. It is lateral collateral ligament injury, it is meniscal affection, or it may be iliotibial band syndrome. But these symptoms are all clinical. You can find this symptom by clinical examination. Then anterior pain, it is mostly found in the osteoarthritis. Then patellofemoral syndrome, some kind of bursitis like knee bursitis in housemaid and the clergy people. Then the quadricep mechanism. If there is some lack of the quadricep problem, you can find anterior pain. What is your management algorithm for this kind of osteoarthritis? So you can see the base, the biggest platform foundation of the management, it is the education, exercise, and weight control. So the first kind of thing, you has to be managed this kind of entity by the education of the person, society, and even the medical people. Then exercise and the weight control for the all people. You can see it is first line treatment of the all kind of osteoarthritis or knee pain. Then some kind of pharmacological pain relief. Then passive treatment and given by therapists, which is the second one. But we are doing firstly this thing, which is second line treatment by the physician or the surgeon. Then the last and third one is surgery, which is more common in India because the people are coming later in OPD and other way to find out the treatment part or outcome of the disease. But the first part is the education, exercise, and the weight control, which is very less neglected in India, I think. We are going with the second line treatment, which is pharmacological, and the third one is surgery. So the first line treatment is that it is only education, exercise, and the weight control of all people, even doctors also. Hello? So we can see treatment either by medical part or non-medical part. So if you are going first line treatment, it is non-pharmacological, it is your muscles strengthening, then weight management, self-management and education, then water-based exercise, it is not common in India. We can go we can improve our walking. Even if you are walking with the bad posture, it make more arthritis. So walking can. Biomechanical intervention we will discuss later on. Then pharmacological. There are number of treatment by pharma company which we can use in early to moderate arthritis, not in severe arthritis. Then orthopedic surgical intervention after more conservative treatment. There is no clear-cut criteria that we can wait for 6 months or 1 year or 2 years. It is all subjective. How can we tolerate the pain? So the pain is the only criteria which make the surgery earlier or the later on. So how do we think about the treatment of the osteoarthritis? So it is mostly stage-based. So we literally classify it basically in stage 1 to 4 in all kind of arthritis. So which is stage 1 and 2, it is mild to moderate. And what is stage 3 and 4? It is severe condition of the arthritis. So stage 1 and 2, we go mostly with the conservative and the pharma treatment. And the last stage 3 and 4 and so on, we use mostly surgical entity for the treatment. So what are these? You can see the knee arthritis. If you are talking about the knee, stage 1 is a doubtful arthritis. You can't see on the X-ray the disease progression. Then stage 2, it is mild, and there is little bit joint space narrowing only. Then the stage 3, which is moderate and more common in this region because the condition is painful and the not recovery. You can find the activity daily living is more hampered. So it is stage 3 is moderate, which need treatment very aggressively. Then stage 4, which is severe and need mostly surgery. So it is stage 3 and 4, which we counter mostly in the OPD. Then there is some recommendation world over the world, like AOS, it is American Association of the Orthopedic Society, which is latest recommendation in 2021. And they strongly recommend, first is education of patient for the treatment and the lifestyle, then the oral and topical NSAID, which is more common used in India and world over. Then oral narcotics, which is now in more trend. Then exercise therapy, which is moderate recommendation. It is walking with some walking aid like cane and brace. Then weight loss, intra-articular injection in form of either steroid or some hyaluronic acid. So what is patient education for the arthritis? I think my first thing was that it is not of bone disease. It is a system disease. So all the physicians of the society, like even the CFM people or the medical people or the even CMO of the any hospital or some MBBS student, he can or she can teach the patient for the education regarding the treatment of disease. So it is natural history of disease. You has to be evaluate completely the patient, how the disease progress or how the disease started. So starting disease and the progression, it is very important for the prevention. Then the third is more important, lifestyle modification. Like in India, like this Malwa region, we are mostly doing our activity by the squatting and the kneeling position. Like paravar baithna, chokdi marna, this kind of thing, we has to be we has to be modify these practices in our daily living. Then exercise, it is not a exercise, it is only stretching of muscles, which is around 10 to 15 minutes. But we are always neglected this part of lifestyle or our daily activity. Then medication is already described, and surgery if needed in later stages. So education about all the things is very must for all the patient and as well as doctor. Then the other things also, the treatment like anxiety, if you are having chronic disease of like arthritis, so it is very painful the patient for the even for psychological purpose. So you has to be elevate the anxiety of the patient for the chronic treatment, and that helps at targets. It is community level treatment strategy. So, but we are going only for the medication and surgery. So these all things we has to be include in our treatment and other parts. So what is lifestyle modification? The most common is weight loss. Mostly in around 40 and 40, after the 40, we are suffering from the weight gain. It is a pandemic disease, like obesity is a pandemic disease now. So weight loss, the first and the most important criteria to treat osteoarthritis. The weight loss is very common, very most important. Then physical activity like exercises and the different kind of aerobics. Then the cane use. So the third one is, it is mostly severe disease. So there's some study about the John Hopkins Center report, if you're reducing your weight even more than 10 pounds, so your disease progression will decrease more than 50%. So it is very important if you are getting your weight loss about 10% of your body weight, actually 10% body weight. Like if you're 80 kg, so if you're reducing your weight by 8 kg, you can improve your condition by 50%. Or if your BMI scale is reducing by 2 scales, so you can decrease your problem by the 21.5% in the man or 33% in the woman. So it is a study by the very reputed institute, John Hopkins Institute, and the weight reduction is very important for that purpose. Then some food supplement, we are also deprived of food supplement in India because we think that stopping the food is the treatment, but it is not food stopping. The modification food or modulation of the food strategy or food practices in India, it is very important. So what are the food supplements for the osteoarthritis? It is first, it's cartilage matrix optimizers, like some chondroitin sulfate we are getting in different foods now also, or some supplement of medicine. Then the inhibitors of the inflammation. It is any kind of good things in herbal or Ayurvedic treatment also, like boswellia, curcumin, hadjod. We are now using hadjod from the Himalaya company, and now it is commonly in allopathy also. Then fish oil, amino acids in different kind of essential or non-essential both. Then viscoelasticity, like some fluid or some medicine which can improve your joint fluid. It is viscoelasticity improvement substances. Then inhibitors of the neoangiogenesis, which prevent your bursitis or arthritis. So you can see sea cucumber extract. So it is very important. Sometimes other than allopathy people are doing very good in this kind of arthritis, like in kind of Japan or China. The alternative medicine are very popular than these allopathic treatment. So with physical therapy, the next part, a very important part, which is also lacking in this kind of this part of India. The first is muscle strengthening of different kind of muscles. We will discuss the next slide. Then range of movement exercises for the all joint, including shoulder, your wrist, your elbow, your fingers, your toes, your knees, your elbow, any kind of joint you can move your joint properly, and you can gain power within simple exercises, like only range of movement exercises. Like it's very simple and no need assistance also. Then swimming is little bit less in this part, but cycling. The cycling we can go for the cycling every day. Even cycling is two types, like static and dynamic. So we can go do cycling in our room itself with static cycling. Then some iontophoresis is a different kind of thing which use acetic acid with other molecule, and it mobilize the things in body which prevent the antioxidant or oxidant effect of the other drugs. So it is newer in India, but mostly used in Japan and China. Then laser therapy. Nowadays in metro countries, laser therapy is very important, and people are doing that for the pain relief basically. So laser therapy is very important for some extent in elite society or elite community, which is using non-medical treatment mostly nowadays. So laser therapy is very important. Then it is new therapy pilots based rehab exercises. So it is Jupiter pilot which invent this thing, which include complete coordination of the body, mind and spirit. So it is a different thing. You can include three things: body, mind and spirit. So these are some centers, space center, which include exercises, drugs, and some drugs, medicines. And the spirit means some mythological or some spiritual treatment therapy. So it is newer therapy which is mostly running in some Asian country. Then which muscles you has to be improved routinely, like gluteus muscles, hip muscles, then quadriceps, hamstrings, your calf, tibialis anterior or leg muscles, hip abductors, spine muscles, and shoulder muscles. These are joints mostly affected by the arthritis, so you have to improve these muscles routinely with the only simple exercises. There is no need of machines or no need of some assistance. So you can improve your muscle strength by these exercises. So these are some kind of simple exercises, and you don't need any machines or any equipments for these kind of exercises. Only your floor and your some mattress, some kind of. So how use can, or what is the advantage of can in routine practice for the old people in like in India? But there's no old people, old age. Actually, this is physiological age. Nowadays, in my practice, I can see also arthritis in 40-year female, not in 60-year. The old people are more healthy than the middle people because they use some good exercises and fast, and their dietary habits are very good. But the can use are mostly in 50s of nowadays, not in 60. So why these are problems more in this age group? Because they have the mixed culture of the modern and old. They use junk food but not doing exercises. Newer people are little bit active for the something, not for both things. So either new people are very old or either they are very active. But middle people are suffering from the multiple diseases because they have a transit period of the, like I am in middle people, but the new generation are very, either they are good or bad. But middle people are mixture of the good and bad. So the different kind of can you can use in your routine practice, but it mostly help your body weight to support and to move around. So second thing is it distribute your joint direction force. There are some different kind of lever forces over the joint. Lever force mean your hip is doing as a lever, your bones are like elevator. You can, this is some physiology. But after, with using your cane, you can transmit your weight from that disease joint to the cane and ground. So it is useful for the using over the normal hip, because in disease hip or disease joint, you are forcing your other part of body weight toward the normal limb. So always use cane or some support over the other normal limb, not the disease limb. So this is some kind of braces or some kind of deformity, either inside deformity or outside deformity on knee. But with these kind of braces, which is normally formed for the, it is usually formed for the your redistribution of the body weight from the stress area. So you can use, there are some strap over the either lateral side or middle side according to your disease. So you can use this kind of braces. So like I'm repeating the same thing. What is the treatment algorithm? So it is medical. Before it is primarily information, diet and exercise is the first part. Then NSAIDs. Then your mixture of NSAID and narcotics. Then surgery. So all people are aware about the medicine, so I will not discuss this parts. Mostly it is ibuprofen and diclofenac and COX-2 selective inhibitor or narcotics, which is commonly used in the routine practice. And doses are, it is all depend on the routine practice of people. But these are not for all people, because all the people physiology are different than the different other people. So use your medicine dose according to your physiology, not according to body weight. A patient in diabetes but 60 kg weight, the patient non-diabetic and 60 kg weight, you can't use a similar kind of medicine. Diabetes, there are some renal impairment, so you can't use narcotics or you can't use NSAIDs for the same kind of amount. So don't use the formula in internet, like 10 milligram per 60 per kg weight. So it is wrong phenomena. So use, consult your doctor to evaluate your treatment dose. So diclofenac is most common drug used in routine practice. It is used in many forms, like oral treatment, it's ointments, injection also. But it elevates your blood pressure in some kind. Then it is liver toxic, and some kind skin problem in these tubes, like mixture of some capsicum, mixture of castor oil. These are the different kind of treatment nowadays you can found in market. Then opioid, nowadays the newer treatment is opioid in different form. So it's used in moderate to severe pain. If you are not getting treatment with the NSAIDs, you can use or add on your opioids. But if you are having renal and gastro toxicity, you can't use more than like the NSAID. Side effects are number of side effects. Actually, first is habitual. It is habitual, habit forming. Then constipation, sedation, and different kind of mental disorder also. So commonly use codeine and tramadol, which is mostly banned in this area without the. It is not the over-the-counter drugs. So you can use without. You can't use this drug without any consultation of the doctor. Then intra-articular steroid, it is very common in Haryana and Punjab in this region, because the people think that injection are very helpful to the regression of disease. But in my practice, I use only in early stage of the treatment for the steroid. because it doesn't change the diseased part. It only can prevent the some kind of bursitis of some kind of inflammation only. So there is combination of the treatment like steroids, then lignocaine and the bupivacaine. You can use either alone or with the combination of these all drugs. Indication I already says early stage grade 1 and 2. But it affect or the adverse effect is disease progression. Some kind of people using every month is steroid injection and getting problem more worse because the treatment part is hampered, because the patient relieved with the symptoms but disease is progressing. Then some chondral insufficiency fracture. There is bone loss, osteoporosis and the subchondral fractures. Then osteonecrosis, it is part of avian or necrosis, which like in jaw, every kind of bone, mostly in the hip, but jaw, forearm, or small bones of the hand and foot, which you can see. Then the bone loss, or some kind of fracture, osteoporosis. The intra-articular hyaluronic acid is different than the steroid. It is safer than the steroid, but it is costly. So we are not using it routinely, but it is more anatomical, more physiological than the steroid. So what is mechanism? It replaces the disease fluid from the joint, reduce pain, it increases the elasticity of the joint fluid. So movements are very smooth. Then sometimes it is visco-inductive. Nowadays we are using animal source or some synthetic source. So some the good amount of good company product, they are also visco-inductive, but very costly, not in India. Indication, the middle indication, like grade 2 and 3, moderate up to moderate, then patients should be young enough to use this kind of injection. Then knees should be aligned. It is not any kind of instability like ACL tear or some kind of ligament tear, but the reaction are plenty. So you use these injection under your observation before some kind of anti-allergic treatment or observation for 2 or 3 hours, not in OPD basis. It is a day care basis. You can use injection in different kind of part of knee. Mostly it is anterolateral part. Then other you can superolateral, anteromedial, anterolateral and anteromedial, but mostly superolateral part. This is a method to inject the injections. And not the orthopedic surgeon, even physician can introduce this kind of injection in the patient. So don't send all the patient to the orthopedic surgeon. You can treat this kind of patient itself. Nowadays, some people, even radiologists, are doing this practice with the use of ultrasound guided injection. So it is very safe technique in some complicated patient, like you have some cyst or Baker cyst or some femoral artery problem, some kind of neurology problem. You can use ultrasound probe for the placement of the knee joint, placement of needle into the knee joint or some hip joint. So it is nowadays, it is very common, done by the interventionist radiologist people. So what are the contraindication of this injection? First is infection, which is more common in mostly unhygiene condition than non-infectious. So what is the non-infectious problem? First is stereotoxicity, which is more common due to the inadvertent use. Like we are using every month single injection, but it is not recommended before the 6th month. If you are using every month, it is toxic. You can use injection over the gap of 6 months or sometimes 3 months. So steroid, if you are using steroid more profoundly, so these make systemic absorption, then osteoporosis, in females some kind of menstrual irregularities, ecchymosis of skin and the cataract. So steroid you can use very cautiously, not every month, even the gap of 3 months or 6 months. So we have the case one, which is a very young man, which having some medial side pain of the right knee, which is worse over the previous year. There no trauma, but some kind of daily activity affected. There is no mechanical symptom like locking, catching or instability of the joint. So this is only the pain which the patient came to the hospital. So patient told that I want to be, I don't want conservative, I need surgery. So this is very good operation. It is not need TKR or total knee replacement. It is only widening of the joint space by the plate. It is osteotomy at the proximal side. You can see osteotomy, this side, and the widening of this space. So this medial side is improved. The second case, you can see 50-year man, which is more enthusiastic with cyclists or swimmer. It is more energetic people, but 6 months history of the activity limiting knee pain. He is not able to do these kind of cycling or swimming and the affected daily activities. So it is depressed little bit. I'm not able to doing this thing. So again, you have to be measured first all the parameter like angle of the knee, both knee, to compare what is the pathology. So for that you can also did first surgery or the other surgery. This is 70-year male with severe arthritis. So actually the slides are not running properly. So this is my case, which is I did in both knee, and there's severe arthritis of the knee, and patient wants surgery, and the indication surgery was there. So we treated by the both TKR. The case is hip arthritis. The left side is very arthritic, so you can give the patient comfort and movement in very first day. It is very good surgery, and sometime in orthopedic we say it surgery millennium. So it is knee arthritis, hip arthritis. This is again the lower picture is other kind of hip surgery, which is hip preservation. Like you are not changing the complete hip. There is some small small hip in the lower side. So you are changing the only part of head. So nowadays this is obsolete in market, but it is very famous. So this is the complete profile of my OT. The single day we operated 4 cases, one of knee, bilateral knee, one of hip, one of shoulder arthroplasty, and one is the early arthritis, which we operated by the plate only. So we did all the 4 joint, all the 4 kind of arthritis in single day. So this is a 4 case of my one OT. So what are the conclusion or what we have message for the home? So it is not an orthopedic problem alone. So we have to think about the systemic problem first. Then it is multidisciplinary management. So the people think this is the orthopedic problem, so send patient all to the orthopedic. But it need good dietitian, good physiotherapy, physical exercise teacher, then the physician who is recommending treatment and everything. Then PMR is a different branch. It is physical and mental rehabilitation branch, they can use simple procedure like injection and these all things. Then the last, if surgery needed, orthosurgeon. So we need a multidisciplinary approach. Then prevention and prophylaxis is the key of the disease. So first has to be treat primary cause, which is disuse atrophy or disuse atrophy muscles or the lifestyle modification. Then surgery decision only clinical, not radiological. Mostly patient roam around with the X-ray only. Ki my hip is bad, my knee is bad. But patient is comfortable, you don't need any surgery. If patient is moving pain-free, you don't need surgery. Then patient education and awareness is the most important, which is for both, either for patient as well as for doctor also. Ki when we treat and how we treat. Thank you. So thank you for all people, all organizers, and say it often and say it with meaning. Like thank you for cooperation and thank you for listening to me. Thanks. Thanks a lot.
Thanks, Dr. Pankaj Kumar Sharma, for your very useful and informative talk on management and diagnosis and management of osteoarthritis. Thanks.
Any questions? I think. Thank you very much.
Our next guest speaker, Dr. Aman Bharti, Assistant Professor at Department of Medicine at Guru Gobind Singh Medical College and Hospital, Faridkot, Punjab, who will be presenting the topic COVID, past, present and future.
Good evening, everyone. So I thank you all and pay my regards to all the committee members to be part of such a good conference and who will be a good speaker. And so today I, Dr. Aman Bharti, as Assistant Professor in the Department of Medicine in GGS Medical College, Faridkot, will be discussing about the COVID past, present, and the future. So everything we do before a pandemic will seem alarmist, as we all had underwent through the lot of COVID situations and the pandemic era, and everything we do after will seem inadequate. These are beautiful lines which have been debated by the Michael Levy, and these are true also in the day-to-day life. So going for the COVID structure or the coronavirus structure, it is an mRNA encased in the nucleocapsid, and it has crowns or the spike as its name suggests, and it is having a lipid bilayer. That is why we always say wash the hands, because these soap works to disrupt this layer and makes the virus inactive. So going to in brief about how did this coronavirus originated. So the most ecological reservoirs for the coronavirus are the bats. But it is believed that this virus jumped the species barrier and entered the human from some intermediate animal host. So this intermediate animal host in the case of COVID is still not identified. So there are some of the theories like it went to bats, to the mammals, through the pangolins. Now what are these pangolins? They are the mammals, and they are most likely used in the Chinese medicines and most probable link to the seafood and exotic animal markets. So it's just like Wuhan level 4 biohazard lab. So this COVID, as you all know, is a disease caused by virus that is named SARS-CoV-2 and discovered the 31st December 2019 in Wuhan, China, and is very contagious and had quickly spread around the world. So going in a little flashback at the timeline, that is December 31, 2019, China alerts the whole World Health Organization as a severe cases of pneumonia with no known cause. Right after exactly 1 week, this WHO officials announced that they have some kind of new virus which they have identified as the family to the coronavirus, and after 3 days, the China announces the first death, and it was all the world terror that what is this happening, what is this coronavirus, and after that, we all know but then NIH began into functions on 26th February 2020, and they started the trials on remdesivir, and then later the vaccination processes started, and that all. So the overview of the COVID-19 pandemic slides there, we passed through the 5 stages, like stage 1, 2, 3, 4, and 5. The stage 1 was, as you all know, that some unknown virus originated, and then the pandemic, it unfolds, and then the pandemic accelerates. And then later, the multifaceted pandemic it took. And the last was the medical countermeasures, which we asked in this stage. So in all this slide, what we have learned till now is that the explosion was predictable. That could have happened wherever the conditions that had allowed it and could be duplicated. And what was not been predicted was the transition from epidemic to pandemic. As in 2021, we just have a lot of cases from August, September, October, till there was so much cases, nobody was just aware that this much of pandemic will exactly occur what it happened in the last year. So having to this slides, still now the new cases are emerging. So this is basically daily new cases, that is 14-day roll average. This is from 2020, then 21, still the new cases are there. But now the variant is different, infectivity is more, the virulency is less, still the COVID is there. So the current global situation is already discussed in 2021. We had a lot of the pandemic area and we passed through that many, in fact, all of us had once a time COVID, twice, and even thrice also. So this we all learned that there was middle age was more affected, right? So it was this middle age, and the more died, this red color is in the elderly group, that is from 60 to 90s. So more death were seen. So this mortality was more with who have the comorbid conditions like cardiovascular comorbid, COPD, and other diabetic and hypertensives. So this pandemic area, and then our strategy was to flatten the curve. Now what is this flatten the curve is very important. It's in every country there's limited number of hospitals, nurses, as well as doctors. So the capacity of the health system can be exceeded if too many people seek health care at the same time. So this strategy was to flatten the curve, and this was possible because of testing, then isolate the positive cases, and then again contact tracing, and this lead to the slower to take the rate of infection, and more hospital and staff could tackle with such a pandemic. So in the March 16, as we all know, the schools were closed, the basketball tournaments, and everything was shut down completely. And then we learned that the triple approach, that is quarantine, isolation, and the social distancing, triple these benefit, gave benefit to the community as well as to all the people. So if there is the uncontrolled, we have a lot of cases in the ICU bedded demand to the tune of 35,000. And if we had quarantine with isolation along with social distances, the number was just 5,000. So what is the planning ahead? We made a lot of triage protocols, phone scripting, mask, hand sanitizers. We all had dealt with all this era, and we are now really and fed up from all the masks and sterilizing. Still, we have to take these measures in the daily to daily life, because we never know about what is happening in the future or what will be coming in the next coming years. So then telemedicine came in for, and then cancellation of non-essential surgeries. We all underwent this, and the mental health definitely it all hampered, and we need to really reach out if we are having such a stress. So triage, we had classification of patients at casualty. We made a lot of triage. There were respiratory areas. Then outside the COVID symptoms, we made 1 meter distances, and that all we had done. So the treatment I will be discussing in very brief, like we had in the mild, moderate, and severe cases, and the critical cases. In the mild cases, we do have used the supportive therapy, and the moderate, we used to use ostelmivir, that is 150 milligram twice daily for 5 days, and these therapies also used in the swine flu also. And the severe cases, we used to give them ostelmivir along with the ribavirines, and the other therapies like remdesivir, teicoplanin, and tocilizumabs were also used. So the other therapies, we learned that it was Swiss cheese respiratory virus pandemic defense which helped out, and this comprise of multiple layers. That is personal responsibility along with the shared responsibility. We have to use personal protective along with social distancing and the other travel related and environment factors. So these all the Swiss cheese respiratory virus pandemic defense was very successful. So beyond this, country also had health impact. National restrictions were there, huge impact on business and travel sectors, along with there was a pressure mounts to reopen the societies. So overall, what happened? More than 4% contraction of the GDP was there in the last 2020, and along with 88 to 115 million people living in extreme poverty due to crisis, and the 9% of the global working hours lost in the 2020, and that was equivalent to 225 million full-time jobs. So at the last, I would like to summarize like that median age was 50, and the deaths were more in males, and kid and pregnant women, they seem to be okay. Right, the mild cases were more 80%, the severe cases were 15 to 20, and the 2.5 to 10% they require ventilator. Case fatality ratio was from 0.7 to 7.7%. This all was passed. So what and where we are now? At present scenario, what's this? India's COVID-19 daily test positive rate is still at a benchmark of 7%. We should not forget that COVID is not gone yet, but it is still there. After a long period of time, still on August 14, 2022. And according to the government's daily bulletin for the day, it stood to be 7.52%. That is a rate above 5% for which WHO sees a potential cause of concern. So A5 subvariant of Omicron at present has been the most dominant, one of the few last months in India. So the vaccines and precautions have played major role, and still they are playing. So the vaccine was, as we all know, started in December 20 in the US, and approximately the studies had showed that it gives 90% protection rate. And now, at present, at the May 2022, almost 1 billion people in the lower income countries remain unvaccinated. And only 57 countries have got vaccinated of the 70% of the total population, and all they are high income countries. So we need to goal, that is we need at least 70% of vaccine coverage, and 100% should be of the age of 60, and 100% in healthcare workers, and 100% of those with some comorbid conditions. So India's cumulative COVID vaccination coverage at present and 18 September 2022 is to the tune of 214.27 crores. So what are the future predictions? How will be in the next future or the coming years? What will be like in the post-COVID, or some new virus will be emerging, or what will be happening? Or if there is some pandemic also in the coming years, then how we have to tackle? We are all prepared because we had learned a lot from the last 2 years. So as the ripple of COVID-19 careens around the globe, it's focusing humankind to innovate and change the way we work and live. The upside of where we found ourselves right now is that individuals and corporations will be more resilient in the post-COVID-19 world. So the coming years, more contactless interfaces, interactions will be used. And today also we are using COVID-19, all we all know, has made most of us hyper aware of every touchable surface that could transmit the disease. So in the post-COVID-19 world, it is expected that we will have fewer touchscreens and more voice interfaces and machine vision interfaces. So what are these more voice interfaces and machine interfaces? So like we all know, prior to pandemic, we all saw the rollout of contactless payment options through the mobile devices, and the machine interface are already being used to day-to-day apply social media filters and to offer that is autonomous checkout at some of the stores. So there will be expansion of the voice and machine vision interface that recognize face and gestures throughout the several industries to limit the amount of physical contact. As we all know, we are using Alexa, Siri, Cortana, Google Assistant are there. So like this will be coming in the next future, and it will be used very routinely. Since strengthened digital infrastructure will be there, we all know we had doing work from home and in the isolation, even the meetings and lessons workouts are more going when sheltering in our homes. Now also we are all, many of us are maybe in the virtual lectures on the YouTube channels we are following, or there are links, we are just using that and we are more comfortable for that reason, right? So online classes of the kids, we already had seen the last years and the video calls, and thanks to our social distancing requirements, and it went surprisingly well. So the video calls for all kind of meetings, yes, even the board meetings can be equally effective without traveling to other countries. So the better monitoring of the use of information and technology and the big data will be in the coming years. Likewise, we see the power of data in the pandemic in the real time. At present also, because the data is so much wide, we can, within fraction of seconds, we can get data of the US, even of the China, because of this all information and technology and the big data system. So there are national and global apps that could result in the better and early warning symptoms, because they could report and track who is showing symptom of an outbreak. Because you maybe have heard a lot of latest app like Arogya Setu, they are saying you have to mention your comorbid conditions, your age, your treatment, you have been diagnosed with COVID once, twice, or prior. So they all keep a GPS track of our informations, and they report and track who is showing symptom of an outbreak, and this will definitely help in the early warning symptoms in the coming years. So the GPS data that could be used to track where exposed people have been and who they are interacting with show the contagion. So I will be talking, so this is very important because the person is sharing information, and the careful implementation of the safeguard of individuals' privacy is very important, because it prevents the abuse of data, right? And will be able to effectively monitor and tackle the future pandemics. So AI-enabled drug development. So this is the new artificial intelligence. This is an ideal partner. It is very much in the coming years in the drug development, because it can accelerate, complement human endeavors, and our current reality will inform future efforts to deploy AI in all the drug development cases. And this, a lot of vaccines and drugs are made through the AI. So the telemedicine will be coming in the near, we all know we are dealing with the cases in medical college of the emails. We got a lot of emails for the telemedicines for the profile. We get the virtual consultations also at present. And the consultations can be done through video rather than rushing to the doctor or the healthcare. Even the remote care enables clinical services without an in-person visit. So to the next coming year, eras will be like this. So the people will like to do more online shopping, because majority of shoppings move to the online channel. And the business who do not have online shopping option will fail financially, ruin definitely. And after COVID-19, the business that want to remain competitive will figure out some ways to sort out the online services, even if they maintain a brick and mortar location somewhere. So there will be enhancements in logistics and the delivery system definitely in the coming year or the next. So there will be more increased reliance on the robots. That we all know that robots aren't susceptible to any of the viruses wherever they go. So whether they are taking some vitals or they're delivering some groceries, right, or keeping a factory running. So you can see the robots are used to take vitals as well, and they are even using in the agriculture for the groceries and in the factories also. So the companies are recognizing how robots could support us and today and play an important role in the post-COVID world and in the future pandemic areas. So robots are used in farming to spray for the agriculture, pesticides and everything, even for the healthcare professionals, we do have all this robotic use. So the more digital events, as we are taking technology debates will be there, virtual events, and the no capacity issue because more of the attendees will log on all from around the world. There will be some hybrid events. Now, what are these hybrid events? So the hybrid events, they are in the coming future, organizers will figure out the ways how digital aspects can complement in-person events. That, for example, some person is in person dealing with, for example, we are dealing here with a lecture, and I will be, again, virtually, you all will be delivering some or in connection with the other countries like, so these are some hybrid events in the coming future. Organizers will figure out definitely. There will be steep rise in hybrid events where the part of the event take place in the person and other are delivered digitally. So there will be rise in esports. So esports is definitely sporting events were all cancelled in the COVID era, and because esports are thriving nowadays, so they are even e-versions of the F1 racing cars on the television and every video games. So it's giving people to sports outlet. There will be hybrid sports. This is a new term and technology. Even in the healthcare system, the hybrid medicines and other things will be very soon in the coming future years. So there will be sports will be where there is physical event are there, it will complement it with the digital offerings. So the tossers are there, we hybrid tennis with polo or handball or the football. So hybrid sports are there. So there are certain myths that really Donald Trump named the coronavirus. No, it's just a fake. And the second myth that only Asian men get the coronavirus, no, it's not. It's also a false, because Asian men may have higher number of ACE2 receptors as the type 2 alveolar cells, but the other studies do refute. So this is also one of the myths. And the third is that COVID-19 was predicted in 1981. There was a book called Dean Conard's, The Eyes of the Darkness. In that, it is clearly written that in around 2020, a severe pneumonia-like illness will spread through the globe, attacking the lungs. They also just a bare coincidence. So other was coronavirus come from beer. No, you can enjoy that also. So I just briefly summarize all the present, past, and the future. And I just thanks you all for the compassionate listening. And I just end my lecture over here. Thank you.
Thanks, Dr. Aman Bharti, for your excellent, informative, and useful talk on COVID. Thanks, madam.
Now I'll invite all the volunteers to come upstage for a group photo. Mr. Ashwini Malhotra. Dr. M.R. Gupta, Dr. K.K. Dr. Poonam Bharti and Aman Bharti also. ਬੱਚੇ ਦੱਸਣਗੇ ਨਾ ਜੀ ਬੈਠ ਜਾਓ ਆਪਾਂ ਹੇਠਾਂ ਹੀ ਰੱਖ ਦਿੰਦੇ ਆ ਚੱਕ ਹੀ ਦੇਈਏ ਤਾਂ
ਚਕਾਈ ਦੀ
ਕਰਦਾ ਸ਼ੁਰੂ ਬਸ ਇਹਦੀ ਲੋੜ So dear friends, now we are coming for the online section of lectures, and for that now we are going to have the recorded lecture of Dr. Vinod Sharma. He is GM Cardiology, Intervention Cardiologist and Head of Cardiology Service, National Heart Institute, Delhi. He is going to speak on management of ST elevation MI in 2020. Thrombolysis is not dead. So this is rather important topic because intervention cardiology is taking up and people are forgetting thrombolysis. So recorded lecture of Dr. Vinod Sharma, please.
Good morning, Chairperson, friends, colleagues, ladies and gentlemen. At the outset, I would like to express my sincere gratitude to Professor Vitul Gupta for inviting me to speak in this symposium. I would also like to express my sincere apology for not being able to be there physically at Bathinda due to last-minute domestic compulsion. Coming to subject thrombolysis and what is its current status in 2022. As we all know, ST elevation MI represents the critical phase of acute coronary syndrome. In this entire syndrome of acute coronary event, on one hand, there is a purely a platelet dependent event like unstable angina and non-ST elevation MI. Contrary to that, ST elevation MI is a fibrin rich thrombus which has formed instantaneously and occluded the coronary artery completely, leading to the necrosis. Looking to the pathology of acute myocardial infarction, as the coronary occludes, the necrosis spreads like a wavefront. And if we try to correlate it with the time, in the beginning, within 40 minutes, only the 40 to 45% of the myocardium is irreversibly injured. More than 55% of myocardium is at risk and it can be salvageable. But as the time passes, at 3 hours, only 33% of myocardium is salvageable. And at 6 hours, only 16% of myocardium is salvageable. And therefore, opening the artery and the benefit of reperfusion is time dependent from the first moment of occlusion of the coronary artery. As we can see in this graph, as the time passes beyond 120 minutes, we end up with the larger area of necrosis, large size of myocardial infarct, and that translates into the poor outcome. When we talk about the time to reperfusion in STA segment elevation acute myocardial infarction, the question is, where does the clock start? What we have been talking all these years, the door to balloon time, is it a right metrics? To address this issue, very recently published, it was published in last year only, the time delay in infarct size and microvascular obstruction after primary PCI for ST elevation MI were correlated with the different time interval, and it was clearly concluded that it is not the door to balloon time, but it is the symptom to balloon time, which is a combination of symptom to the presentation for the primary angioplasty. That is the one which captures the total ischemic time, which correlate better with adverse outcome. It was a meta-analysis of 10 randomized trial, which has shown that longer symptom to balloon time were associated with larger infarct size, greater microvascular obstruction, reduced ejection fraction, and increased death and heart failure. And therefore, as far as the STEMI is concerned, time is very important, time is essence, and choice is rapid perfusion. The aim in ST elevation MI is to open the blocked infarct related artery and reestablish the coronary flow. It should be rapid, it should be early, it should be complete, and it should be sustained. As of now, we have 3 modes of reperfusion available with us: thrombolysis, patient with STMI, even now they present to the non-PCI capable center, and less than optimal outcome is expected in a center which is a low volume center with a less experienced operator. Even the time of the day when the patient presents, patients who present during the off hours after the routine office hours between 6 p.m. to next morning 8 a.m. These patients had a higher rate of PCI failure and 30-day mortality compared to those who presented during the normal duty hours, as we can see here. And from the National Cardiovascular Registry data, if we see that median transfer time for STMI was 109 minutes, Median door to balloon time was 152 minutes. Only 27% of the patients were within less than 120 minutes. If we look at the Indian scenario, it is further poor. In South India, it is almost average patients having pain and presenting to the hospital was 10.8 hours. North India is slightly better, 5.2 hours. It is a lot of us are aware about it. Look at this great registry. It was a more than 20,000 patients who were restrained. Same CAPTIM trial, 30 days mortality, cardiogenic shock, 1 year mortality, all were lower when the patient were offered the pre-hospital thrombolysis. Again, this is a French registry data. Pre-hospital thrombolysis has an age over even primary PCI. Another strategy with the thrombolysis is we can have a drip and ship strategy. That is typical pharmaco-invasive strategy. Now, patient present with any location with ST elevation MI. Once the diagnosis is confirmed with thrombolyze, and once the patient is thrombolized, then patient is shifted to a PCI center within 24 hours. But in case patient present within limit to the a PCI capable center, and if everything can be performed within 120 minutes, then yes, it is good to offer primary PCI. Now, pharmaco-invasive approach for reperfusion that offsets the logistic and economic difficulties which are there with the primary angioplasty. We have benefit of pre-hospital thrombolysis, overreaching importance of time to reperfusion regardless of the strategy that is achieved with the thrombolysis. Thrombolysis alone has serious limitation, and combining the benefit of pharmacological with mechanical strategy of reperfusion that gives a much needed result. And also thrombolysis followed by pharmacoinvasive approach provides clinician with more time to determine the optimal reperfusion strategy, whether the patient can be kept on medical therapy or patient should be offered coronary artery revascularization. Pharmacoinvasive strategy has been applied all around the globe. As we can see data from 2005 onwards, there are several landmark studies, Nordi STMI trial, Transfer MI trial, West Care MI, Capital MI, and Gracia 1 and Prague 1. All these trials, if we look at their pool data, the 30 days composite mortality and reinfarction rate is much less with pharmacoinvasive approach than just primary PCI. Now, last in the study was the STREAM trial, which was published 7 years ago. As we can see the data of STREAM trial, the comparison of 30 days outcome between the pharmacoinvasive and primary PCI, as we can see here, that primary composite endpoint, cardiogenic shock, congestive heart failure, and overall data were in favor of aborted MI that was using the thrombolysis followed by primary PCI compared to those who had a just primary PCI. At 1 year follow-up, as we can see, the mortality in aborted MI was 3.1% compared to non-aborted MI, that is 4.5%. So as on today, if we look at the strategy, what should be our strategy for managing ST elevation MI? Yes, patient with ST elevation MI who present, and there is a possibility of performing PCI within 90 to 120 minutes. Yes, primary PCI is a therapy of choice. But if there is a delay, we should go for thrombolysis. Once thrombolysis is achieved, patient is stable, then watchful waiting can be adopted, and within 24 hours, patient can be transferred to a PCI capable center where diagnostic angiogram can be performed, anatomy can be defined, and a proper revascularization strategy can be planned. Another end of the patient are those who continue to have pain despite thrombolysis, those who do not achieve reperfusion, they need rescue PCI, so they should be transferred to PCI center immediately. Now, if we look at the data all around the world, this is Canada, pharmacoinvasive strategy versus primary PCI, and they found that pharmacoinvasive strategy scores better. So was the result from the France in the FAST MI program. Similar outcome were seen in the Mexico, and this is a data from the India. And here also, as we can see, pharmacoinvasive strategy was as good as primary PCI in STMI in the setting where primary PCI may be delayed or not possible at all due to logistic reasons like financial and other difficulty. If we look at the current global status of thrombolysis in ST elevation MI, still in the major geography of the world, not less than 30 to 40% of the patients are subjected to the not less than 30 to 40% of patients are still receiving fibrinolysis. No doubt in some part of the world the primary PCI rate has improved, but still major geography are using fibrinolysis as a initial treatment of choice in patient with STMI. Similarly, if we look at the median time to primary PCI, in many part of the Southeast Asia and in the Europe, still it is ranging between 5 to 8 hours. In India, almost even now it is 15 to 20 hours. If we see medium time to fibrinolysis, similarly this time is 3 to 5 hours. In India, still this time is 6 to 7 hours. If we see the another part of the world, that is Egyptian registry, even there rate of primary PCI is just 37%. Thrombolysis is being utilized in more than 10% receive fibrinolytic therapy. Access registry. This is a this was published in 2011. It was a prospective observational study. 134 cities in 19 countries in Latin America, Middle East, North and South Africa, and they found fibrinolysis is used in 30% of patients and primary PCI in just 26%. If we see the Indian scenario, there was a registry involving 50 cities. Only 58% of the patients with STMI were thrombolized, mostly with a streptokinase, and a minority received primary PCI. Besides that, thrombolytic therapy is still a very preferred situation. This is a data coming from the Australia. There are situations when we come across this kind of pattern. You can see the right coronary artery, picture A1. Artery is full of thrombus. We have taken the patient for the primary PCI. Looking to the thrombus, in spite of thrombosuction, you cannot get a clean artery. Instill intracoronary thrombolytic therapy and see the last image, that is image C. You could achieve a better lumen. So thrombolysis is still useful as an intracoronary agent in situation where we take up the patient for primary PCI and artery is full of thrombus, and there one can use intracoronary thrombolytic, and thereafter you get a better lumen, and then artery can be assessed and stented. Now, recently published two major trials, TREAT 2019 and MIDTAS trial 2019. This was primarily a trial involving ticagrelor in patients with ST elevation MI treated with pharmacological thrombolysis. And similarly, in the MIDTAS study, ticagrelor was compared to clopidogrel in patients with STMI. And look at the number of patients in both the study. It means major part of the world are still using thrombolytic therapy as a till date, and the reperfusion is more important than the choice of reperfusion. Similarly, on-site pandemic. In COVID pandemic, we had dual goals: achieving a timely reperfusion and safety of healthcare provider. Here, the pharmacoinvasive approach came as handy. Patient arrived, we thrombolized the patient if patient was stable. Meanwhile, patient could be assessed for COVID. If the COVID was positive, patient is stable, we continued with the conservative treatment. If patient turned unstable or if it was a high risk MI, medical personnel safety were taken into account, and then patient was subjected to the intervention. So at this time of pandemic also, pharmacoinvasive strategy scored over a primary PCI. So ladies and gentlemen, what we have learned till date, that one mode of reperfusion cannot always fit all patients in all locales. When we are choosing the reperfusion strategy, we should have a humanistic and holistic rather than a mechanistic approach. Choice of reperfusion should be based on shoulder of scientific knowledge and also in the evidence which is there from the real world scenario. If we see the journey of reperfusion in STMI, right from the beginning in the early days of 1970, when we had just patient to be admitted in CCU and the bed rest and some antithrombotic in form of unfractionated heparin. When we came to 1986, thrombolysis came into the scenario. It was a mode of reperfusion. 1990, primary PCI was introduced, of course, but thrombolysis remains along with. In major part of the world, both the modalities were going on. In between, intracoronary thrombolysis has always been there, even those days and even now, as I shown in when there is a artery which is rich in thrombus, intracoronary thrombolysis can be attempted and it salvages. When we move further ahead, by 2000, we have a newer generation of thrombolytic agents which had a better patency rate, which were fibrin selective, but primary PCI and thrombolytic therapy moved side by side. When we reached to 2010, there were mega trials of pharmacoinvasive strategy which found that those logistic difficulty of primary PCI can be overcome by pharmacoinvasive strategy. Again, here thrombolysis remained. If we look at in 2022, there is a primary PCI, there is a pharmacoinvasive therapy, and some cases where we need intracoronary thrombolysis. So thrombolysis was there in the past, it is there in the present, and thrombolysis going to remain in the future. And the current data of pharmacoinvasive therapy, where the thrombolysis is followed by the primary intervention, if it is compared with the primary PCI, pharmacoinvasive strategy in all score stands better. So ladies and gentlemen, thrombolysis is a mode of reperfusion in major part of world, especially in the middle income and poor country. And in fact, thrombolysis is a panacea for poor man with heart attack. Essential component of pharmacoinvasive strategy of reperfusion in developing and developed country, it remains. Mode of reperfusion in developed countries, wherever anticipated delay of PCI is more than 120 minutes, thrombolysis is there. Of course, as I said, intracoronary thrombolysis remains an option in patient with ST elevation MI with large thrombus burden where crossing with wire and aspiration or thrombosuction fail to achieve TME3 flow, we can still instill the intracoronary thrombus and achieve reperfusion. So ladies and gentlemen, if we look at reperfusion in ST elevation in MI in 2022, thrombolysis is there. It is not dead yet and it cannot be buried alive. Thank you very much.
Okay. Thank you, Dr. Vinod Sharma, for an enlightening talk. Now I'll invite the recorded lecture by Dr. Kavita Mandala Bhatti. She will be speaking on hyperglycemia during pregnancy, what to do. This is really important because we need to know whether patient is having gestational diabetes or it is chronic diabetes. Dr. Kavita is Professor and HOD Ops and Gynae, CMC Ludhiana, and President Ludhiana Menopausal Society, Executive Council member of LDGS. Dr. Bhatti, please.
I'm going to talk on hyperglycemia in pregnancy. Diabetes is a rapidly escalating global public health problem, and it has been seen to be increasing among all age groups, be it adolescent, reproductive age group, or the elderly. In India, gestational diabetes complicates nearly 4 million pregnancies annually, and if not appropriately managed, these patients are at a high risk of adverse perinatal morbidity and mortality. Diabetes begets diabetes. What does it mean? If a patient has pre-gestational diabetes or develops diabetes during pregnancy, the fetus is at risk of developing diabetes future in life. So there are adult diseases which have a fetal origin, which begins intrauterine itself. The proposed classification for diabetes in pregnancy first is gestational diabetes, which is diagnosed during pregnancy. The pre-gestational or pre-existing diabetes, also known as overt diabetes, that is type 1, which results from beta cell destruction, leading to absolute insulin deficiency with or without complications. Type 2 diabetes is because of inadequate insulin secretion, and it also can occur with or without vascular complications. There are other types of diabetes, genetic in origin, associated with pancreatic disease, which may be drug or chemically induced. The diagnosis of overt diabetes in pregnancy is when the fasting plasma glucose level is 126 milligram percent or more, or if the hemoglobin A1C level is 6.5% or more. Random plasma glucose done anytime during pregnancy is 200 milligram percent or more. Patients may also have symptoms of polydipsia, polyuria, and polyphagia. Prosomia, fetal growth restriction, hydramnios, preterm delivery, and an unexplained intrauterine demise. Maternal effects, development of preeclampsia, diabetic neuropathy, nephropathy, retinopathy, repeated infections, and diabetic ketoacidosis if sugars are not well controlled. Neonatal effects are also many, such as respiratory distress syndrome, hypoglycemia, hypocalcemia, hyperbilirubinemia, polycythemia, cardiomyopathy, cognitive disorders, and inheritance of diabetes in future. Now, the key elements in management of overt diabetes is to achieve and maintain excellent glycemic control during pregnancy, avoiding hypoglycemia and ketoacidosis. We need to screen, monitor, and intervene for any maternal medical complications and comorbidities such as retinopathy, nephropathy, hypertension, cardiovascular problems, and thyroid dysfunction. Any obstetrical complications such as preeclampsia, preterm birth has to be dealt with. And also we need to screen and monitor for fetal complications. In the first trimester or even in the preconceptional period, we need to address maternal and fetal risk during pregnancy. So we have to optimize glycemic control not only during pregnancy but even before that, before the patient conceives. So this patient should have undergone preconceptional screening for common comorbidities such as retinopathy, nephropathy, neuropathy, hypertension, and cardiovascular and thyroid dysfunction, and dealt with accordingly. So a prenatal visit, if not done before conceptional, and in the first trimester, one should address these issues. So what are the points which have to be kept in mind at the first visit? A routine prenatal laboratory test and evaluation should include blood pressure, body mass index, urine culture or urine microscopy. Hemoglobin A1C levels should be done at the first visit and periodically during pregnancy. Serum creatinine for renal function test, a 24-hour urine collection for protein, dilated eye examination for any retinopathy, which may have to be repeated, clinical evaluation for atherosclerotic vascular disease and neuropathies. In selected patients, especially in the overt diabetics, we need to do an electrocardiogram and thyroid stimulating hormone test. When managing these patients, a team approach should include an endocrinologist, certified diabetes educator, and a nutritionist. We need to inform the patient on diet, insulin therapy, glucose monitoring, and glucose targets. And these levels should be provided to the patient so as to do self-monitoring of glucose levels and achieve these targets effectively. So a fasting blood sugar is a must with 1 or 2 hour post-meal blood sugar monitoring. If the patient is on insulin, then a 2 a.m. glucose level should also be measured. What are the target levels during pregnancy? The fasting, preprandial, and nocturnal glucose can vary between 70 to 95 milligrams per deciliter. 1 hour postprandial glucose should vary between 110 to 140 milligram per deciliter, and a 2 hour postprandial glucose can be between 100 to 120 milligram per deciliter. There are some non-glycemic pharmacotherapy which are important. Folic acid supplementation, which should begin even before prior to conception. The minimum dose is 400 micrograms of folic acid to reduce the risk of neurotube defects, but we give 5 milligrams of folic acid daily and ideally should be begun at least 1 month before conception. Pre-gestational diabetics are predisposed for developing preeclampsia during pregnancy. So it would be good to start low-dose aspirin as a prophylactic measure after 12 weeks of gestation. And this has been recommended by the United States of Preventive Service Task Force, the American Diabetes Association, and ACOG, that all patients who have overt diabetics who are at a higher risk of preeclampsia, one should be started on low-dose aspirin. Fetal issues are many, one of which is very important, overt diabetics are more prone to develop congenital anomalies, especially if the blood sugar levels are not well maintained in the first trimester. So this should again be told and re-emphasized that proper management of glycemic controls should be done in the first trimester. Ultrasound examination in the first trimester is a must, followed by anatomy scan at late first trimester, that is between 11 to 13 weeks of gestation. Though maternal diabetes mellitus is not a risk factor for aneuploidy or chromosomal anomalies, but we need to screen them and practice the same guidelines as used for the general obstetrical population. The risk of malformations according to the HbA1c levels, as the levels are higher, the risk of developing congenital malformations goes up to 22% when the HbA1c level is 10% or more. In the second trimester, the prenatal visits are scheduled every 2 to 4 weekly. And if there is any development of complications or uncontrolled blood sugar levels, then the schedule of visits will be individualized based upon the severity of diabetes, glycemic control, and pregnancy complications. Glucose self-monitoring is very important and also important to maintain the targets of blood glucose level throughout pregnancy. So insulin requirement may vary from patient to patient, and we need to also monitor them for preeclampsia. In the second trimester, we need to screen them for neural tube defects. At 18 to 20 weeks, we can combine it with the maternal serum alpha-fetoprotein, detailed examination of the heart of the fetus because they are more predisposed to congenital heart diseases. So a fetal echocardiogram can be included in the second trimester to rule out any cardiac anomalies. Prenatal visits during the third trimester become more often, 1 to 2 weekly until 36 weeks, and then weekly till delivery. Continued control of blood glucose concentration should be maintained during the third trimester. Self-monitoring and target levels to be maintained throughout pregnancy. Rule out fetal complications such as macrosomia or fetal growth restriction. And one may require to escalate the doses of insulin as pregnancy advances. Usually, the insulin requirement plateaus by 37 weeks of gestation and may decline slightly thereafter. A more than 15% decline in insulin requirements requires prompt evaluation of fetal well-being. In the third trimester, one needs to be more vigilant for asymptomatic bacteriuria. So urine culture is very important, as in the first trimester when you screen for asymptomatic bacteriuria. One should repeat this not only in the third trimester, but second trimester screening is also advisable. Preeclampsia means close monitoring for any disorders which may develop during pregnancy because of hypertension, and these patients are also predisposed for spontaneous and indicated or iatrogen preterm birth. So whenever planning a preterm birth in patients who have complications, we need to give antenatal corticosteroids. And one must remember that the glucocorticoids, that is betamethasone and dexamethasone, which is given for lung maturity during pregnancy, when anticipating a preterm birth, there could be transient hyperglycemia, which begins approximately 12 hours after the first steroid dose. And it may last for approximately 5 days. So an intensified monitoring of maternal glucose level is required with temporary addition or increase of the insulin dose. So increasing the dose of insulin by 20 to 30% of the previous level, or one may also increase the number of injections per day. Rarely, intravenous insulin may be required to achieve glycemic control after glucocorticoid therapy. Fetal surveillance is important because pre-gestational diabetes have a 5-fold increased risk of stillbirth. So a twice weekly antepartum surveillance in the form of non-stress test, biophysical profile is important to reduce the risk of stillbirth. And this has been recommended by the American College of Obstetrics and Gynecology. In complicated pregnancies with fetal growth restriction, oligohydramnios, preeclampsia, or uncontrolled hyperglycemia, this antepartum fetal surveillance may start as early as 26 weeks. We need to also monitor the growth of the fetus. So this may begin at 28 to 32 weeks and can be repeated every 3 to 4 weekly. Macrosomia becomes apparent as early as 26 to 28 weeks of gestation. Delivery is timed based upon gestational age, estimated fetal weight, maternal glycemic controls, and comorbidities. Well-controlled glucose levels without any vascular disease, one can deliver at 39 weeks to 39 plus 6 weeks. But expectant management beyond 40 weeks is not recommended. Patients who have complications, whether it be a comorbidity or uncontrolled blood sugar or obstetrical complications, one may plan to deliver them before 39 weeks of gestation. Uncontrolled hyperglycemia or vascular disease, sometimes delivery at 36 to 38 plus 6 weeks may be warranted. But we need to have a shared decision making before delivering these patients. One needs to balance the risk of stillbirth with the preterm effects. So always individualize each patient before deciding for delivery. The route of delivery remains vaginal, preferably. Patients without macrosomia is not an indication for cesarean birth in the absence of obstetrical indications. But those with macrosomia, ACOG recommends that it is a reasonable option to prevent brachial plexus injury, especially when the expected fetal weight is greater than 4.5 kg. So in these patients, a prophylactic cesarean birth may be considered. The incidence of shoulder dystocia has been seen to increase with the increasing birth weight. So it is maximum if the birth weight of the baby is 4.5 kgs or especially in the diabetic pregnancy. So in these patients, a prophylactic cesarean planned delivery should be the recommendation. Patients who undergo forceps or vacuum-assisted vaginal birth, the blood sugar levels should vary between 90 to 120 milligram percent, the mean around 100 milligram percent. And as the blood sugar levels go higher, one may have to titrate with the insulin requirement. So this can be added to the intravenous normal saline. Postpartum glycemic management again is important because insulin requirements drop sharply after delivery. So one may have to omit or reduce the dose of insulin depending upon the blood sugar levels. Breastfeeding is encouraged and supported, and this should be as early as possible to prevent any hypoglycemia in the neonate. Both insulin and metformin are compatible with breastfeeding. Postpartum depression is very common among these patients with diabetes, so routine screening is important. Contraception again needs to be emphasized. All hormonal methods may be acceptable for patients with diabetes and no vascular disease, but with embolic events, and these are preferred. Ophthalmological follow-up is a requirement last year in the postpartum period of 140 milligram percent or more anytime during pregnancy with the single test procedure when you label them ketonuria. And once the blood sugar levels are maintained where the 2-hour ppbs is less than 120 milligram percent, then we need to follow it up every 2 weekly. But if not controlled on medical nutrition therapy, we need to start on insulin therapy or metformin. So on medical nutrition therapy, you can follow up the blood sugar level every 2 weekly, after 28th week, every week till delivery. Insulin is the drug of choice. Metformin, if added, has to be started as 500 milligram twice daily, up to a maximum of 2 gram per day. And one should remember at night with dinner. Self-monitoring is less than 60 milligram percent. The mean blood glucose